and I will ask you to start the presentation. Manika, are you there?
I think Ma'am Menka is not there, so you can start the
Okay.
from the next presenter.
Second presenter is Dr. Suresh Sharma and Purva Bhalla as outreach capacities in to public health system for out of school anemia. Just let me read the paper title. Out of school anemic adolescent girls. So Suresh Sharma is presenting.
Ma'am, good morning to all. I'm Purva Bhala and I am going to present this presentation, ma'am.
Okay.
Ma'am,
So,
are you able to see my presentation?
Yes, yes. It is second slide.
Yeah, now it is. You can easily see that, ma'am.
Yeah. Please go ahead and take 12 minutes.
Yeah, sure. Good morning, everyone. My name is Purva Bhala and I'm going to present on the topic outreach capacity of public health system of outer school anemic adolescent girls. As we all know that anemia is most common nutrition problem disorder worldwide. Anemia is common during adolescent girls due to demand of increased growth and menstrual loss, blood loss. Although it occurs in
Be little louder, please.
Okay. Anemia is most common in nutritional order as worldwide. Anemia is basically during adolescence due to the demand of increased growth or menstrual loss. Although it occurs in all the age group as there will be a higher prevalence among adolescent girls. As anemia is basically an heterogenic in distribution of social and demographic biological disorder. Normal hemoglobin of women should be 12 to 15 gram and types of anemia are severe, moderate, and mild. Here's the distribution. Here's this flow chart showing the distribution of outer school anemic adolescent girls and how we are capturing the late adolescent girls, and specifically this paper is or the whole paper focusing on the out of school anemic adolescent girl while seeing the socio demographic anthropometric measures contacted with healthline workers. As this flowchart shows the period of adolescent as it's a critical period which profoundly influence the adolescent girls' future potentials. And we can see that the adolescent girls and womanhood, and basically in womanhood, those who are educated and working and their housewife, and adolescent, those who are going to school, and those who are out of school, the main focus, and those who are out of school, basically they're having issues of early and forceful marriages as their nutritional depreciation at their home and their early marriages took place and they're anemic too. So there is a means chances of dual vulnerability, exposure to violence and high maternal mortality. Of course, the first early marriages and they're out of school, they're having babies, and plus they are anemic. So there are heightened of adolescent girls to be influences. There should be and very much important to invest in out of school adolescent girls and giving them the priority as the out of school adolescent girls having expanded vulnerability in which socio-economic awareness comprises even the educational level comprise. So it is very important to address the anemic status of out of school adolescent girls, otherwise they will fall to early marriages, out of school babies or unhealthy pregnancy, and which is a major vulnerability expansion of out of school adolescent girls in terms of their education awareness, social and economic awareness. It is very important to study the adolescent stage, and especially those who are out of school. And even the government, earlier there was a huge gap between the set of population as there was a major vulnerability, but due to these national health mission programs the gap now has been reduced. And to the best of our knowledge, there is no study has explored anemia among out of school adolescent girls in India. And these are the problem being faced by the anemic adolescent girls as they reduce physical development, their impair sexual and reproductive development, and also reduce their cognitive development. And this viscous diagram basically shows the out of school adolescent girl scenario. And if it does not address the out of school adolescent girl, irrespective having anemia, they are having poor health outcome, which definitely reduces their educational prospects and their health wellness prospects. So then there will be a less number of chances for them to go to school, and they will again bound to out of school. And the main aim of the study is to realize out of school adolescent girls, anemic adolescent, by public healthcare system. And the objective of my study is to understand the reliance of out of school adolescent anemic girls on public healthcare system via means of frontline workers. These are the basically showing the way I have collected my data. And the focusing of the study is like out of school anemic adolescent girls contacted healthcare workers, which is around 15, around you can say that 16%. And how I have calculated the out of school anemic adolescent girls is through this education attainment. This graph shows the profiling of the study through age group as adolescent girls and out of school adolescent girls. Similarly, we can see in this graph that the maximum number of adolescent girls, who are 18% total out of school adolescent girls, were from rural areas, and 19% were from urban areas. And we can see that the wealth index scenario also. Now the role of the frontline workers, as they are, we already know that they are very important for our life. So like Anganwadi, Ashas and ANM, and they perform different activities in their scenario. As Anganwadi workers assist in implementation of Kishori Shakti Yojana and motivate and educate adolescent girls and their parents and the community in general in organizing the awareness, and also assisting in nutritional program for adolescent girls. Similarly, we can see in Ashas, they create awareness and provide information to the community determinants of health, such as nutrition, basic sanitation, health living and working conditions. And for the ANM part, it's basically for they are catering to maternal and child health along with family planning, nutritional and health educations. This graph shows the out of school anemic adolescent girls who recently contacted healthcare workers, and it is found that the maximum number of out of school anemic adolescent girls have contacted Anganwadi workers. Adolescent specific programs are majorly restricted, firstly with Anganwadi workers and then with Ashas. As we already discussed the above, the profiling of the healthcare workers, so the people who goes to ANM, they will be additional layer in terms of pregnancy, or we can say ANC or medical issues. And the other major concentration is like Anganwadi and Ashas, which is well reflected in this graph. Now this graph shows the reflecting the out of school anemic adolescent girls with types of anemia by contacting the healthcare workers. As all the frontline workers are contacted, but we can see that in severe anemia status, we expect that the comorbidity with the will be expecting to cater by ANM at these cases of adolescents. And for the case of moderate and mild anemia, we can see that the major concentration with Anganwadi workers. This table shows the percentage distribution of outer school anemic adolescent girls and why they have contacted uh, with the healthcare workers. And it is observed that adolescent girls who have contacted any healthcare workers for family planning services, majority of them has preferred ashas. And it is also noted that those who have contacted the healthcare workers for like supplementary food, nutrition, and education and menstrual hygiene, maximum percentage of out of school anemic adolescent girls have contacted Anganwadi workers
Hello.
for their problem. This
जिसका
next slide
इंटरनेट सामने आ गया, काफी लाइक
shows
खजान तुम हुई. checked into Angofla have.
shows that the
Please
percentage.
mute yourself. I think Prasad, you have to mute yourself.
Yeah,
Please continue.
yeah. Now this graph shows that the percentage distribution of healthcare workers with socio-demographic profiling, and we can see that the maximum number of out-of-school adolescent girls of age 19 years have contacted Anganwadi workers, like for early marriages, pregnancy, ANC, and for all the frontline workers, we have majority of adolescent girls who are belonging to the age group of 18 and 19 years. They are accessing any helpline, any frontline workers. Is mostly the same for Anganwadis, ANMs, ASHAs, MPWs. Now here we can see that the frontline workers are performing their duties both in rural areas and as well as in urban areas, but the majority of the health line workers are working in rural area, which is very justifiable. This graph shows the marital status, and we can see that the adolescent girls who are currently married are being contacted by Anganwadis for their counseling purpose. And for Ashas and ANM, we can see that the role of education, nutrition being contacted by the never married adolescent girls.
Now
Okay.
you have 2 minutes to
Sure,
complete.
ma'am, sure. As one with the pregnancy, we can see that the pregnancy women and those who are not pregnant, they are those who are not pregnant is a layer part, and those who are contacting majority of the adolescent girls to the ANM, those who are pregnant. Similarly, we can see in the BMI and the wealth index. Now it is very important for the distribution of IC tablets, and this basically for the iron deficiency implications, and there is very important for the IC tablets to reduce the prevalence and the severity of anemia among adolescent girls. And also the Ministry of Health and Family Welfare and the government have launched many programs to reduce this severity, and they're basically the target group of adolescent girls and boys, but majorly working on out of school adolescent girls. And this program is basically a gift program, we can say that, as it's aimed to provide once a week iron folic acid with a combined tablet as adolescent, those who are going to school and those who are out of school on a fixed day. This table shows, I know it's a white table, but it's showing the distribution of IFC tablets in Anganwadi center. And we can see here the ranking wise, as in Tamil Nadu is the highest distribution tablet in 2017-18 as data has been collected from HMIS. Now its rank shifted to be second. And we can see that lastly in Uttar Pradesh, as we all can see that in Uttar Pradesh, there is the position has been changed a major. Earlier it was in 17-18, it rank was 10, but now it has position shifted to fifth. This map shows the distribution of IFC tablets through Anganwadi, and we can see that in the highest distribution was in Tamil Nadu and in Andhra and in Madhya Pradesh, and the lowest distribution in 17-18 in Sikkim, and then followed by Arunachal Pradesh in 2017-18. Lastly, this slide is my last slide. As we can see that the metrics here, the metrics show the prevalence of anemia among out of school adolescent girls and with community health workers. Basically, we have calculated two indicators. The first one is percentage distribution of
I think now you have to wrap it up.
Sure, ma'am. It's just ending up, and here is showing the percentage distribution who have contacted the healthcare workers. Basically, this slide we can see that the adolescent having high anemia and high contacting when the healthcare workers are the best performing state, which is Dadar, Nagar Haveli, Bihar, Meghalaya, Andhra Pradesh. And we can see the red highlighted districts. These are the districts, the adolescent girls with high anemia, and still there is a very low contact with the frontline workers. And this could be the reason the state must have the contact with the community oriented programs, intervention and scaling of the program should be very important for them. Thank you all.
Thank you very much, Purva, for nice presentation and conceptualization. Now the second presenter are Manika. You are there, Manika Kumari. Are you there? You close your presentation, Purva.
Yeah, sure, ma'am.
Then we can shift to third paper, enablers and barriers in the certification of national quality assurance standard. And who is presenting in this thing?
Lekha, yes. Hi, Sunisa, I'm here. I'll just start sharing my screen just a second.
12 minutes we are keeping it for each presentation.
Okay, I'll try to hurry up. I have too many slides. Good morning, all. Today, I want to talk about quality in quality standards in the health system. All of us are work in the area of health, and most of you are familiar with these issues. But we know that the government has, in India, the health system has done a lot to improve, to increase coverage after with the National Rural Health Mission, first focused on rural areas, but now expanded to all regions of the country. And we can see that, and as a result, there is both increase in infrastructure and as well as utilization. However, there are still some problems in our health system, and one of the issues is that many of the people that the public health system is targeted at still use private health services. So, in order to improve the trust in the public health system, more has to be done. And one of the programs that has been instituted recently is the National Quality Assurance Standards Program, which is going to be the focus of my paper today. Just a few slides to set the standard. I've focused it. The study is based in Karnataka, just to show you where Karnataka stands, even though there's variation in so health indicators. In the southern states, Karnataka fares worse than the other southern states in many indicators. For example, although more recent numbers of maternal mortality, MMR, in Karnataka have shown an improvement, but relative to the other southern states, Karnataka is still fairly high level of MMR. Our life expectancy isn't as good as Kerala and Tamil Nadu. We still have very low sex ratios at birth, and IMR is also fairly high. So there is, in our health system, there is much more to be done to target more sort of marginal communities to provide good health services for everyone. To also show you just a few numbers, there's been a big increase in infrastructure. The red line is for India, the number of sub-centers that are in India and Karnataka in particular show a remarkable increase. Same with PHCs and CHCs. So you can see an upward trend in the number of sort of health facilities that are made available. And also in many of the facilities that are in the PHCs and CHCs, you see that there has been, for example, there's stabilization units for newborn care, the newborn care corner. There are referral transports available at CHC. So all of this has shown there has been a lot of input into the health system. But of course, you see that in terms of human resource, there are only about 18% of CHCs in Karnataka that have all 4 specialists. So in HR is a problem, as we all know that in the health system. There are, when you're looking at health systems, there are many barriers to access of health systems, right? So one of the useful definitions is by Peters, which says the timely use of service according to need. So what the health system wants is to increase the access of the health system. And there we have talked about barriers to access in terms of barriers to availability, barriers to geographic accessibility, affordability, and acceptability. So this can come from both the demand side as well as the supply side, right? The barriers affect demand for services as well as the supply of. So Peters, we have there are various barriers within each of these 4 dimensions, and some of the ones that are very well known in research is, from the supply side is waiting time, the quality of services provided, and all of these affect whether the services are acceptable to the public as such. And so I'm going very quickly because I want to get to the study as such. So one of the factors that's integral is the quality of services provided. So across all the 4 dimensions, the quality of services is important to increase utilization by the public. Okay, so there are many studies have talked about the issues with the health system that affect that act as barriers to utilization of the health system. Okay, so as a result, well, not as a result, but one of the recent programs that the government has instituted is the National Quality Assurance Standards Program, and it was first in 2013. It was directed at district hospitals, and then later it included PHCs and CHCs as well. And the aim is to define minimum acceptable levels of physical infrastructure, services, human resource requirements, equipment norms, lists of drugs, reagents, and consumables. Basically, define the minimum standards that are necessary in each facility to provide a short quality of services. And the program is very comprehensive, and it includes, it aims to be, for example, comprehensive, user-friendly, evidence-based. There are explicit and objective standards, so it's very well thought out program, and it also has built-in incentives and enablers for certification. And the aim is that all health facilities will achieve certification. So basically, if they get the minimum score required on various indicators, then they will get certified at the state level. And after being certified at the state level, they will be certified at the national level. So what we find in Karnataka is that, and there is there's a process of implementation. So usually to enable certification, facilities that have already received Kayakalp Award are selected. And then there are quality assurance consultants in each district that are oversee the program. And then the training is done at the district level, and then to all senior personnel, and then the senior health personnel in each district then pass on the training to each facility. Okay? And one of the important aspects of implementation is that there's no penalty for not implementing. So it's the aim to get certified, only motivation is provided, no penalty as such. So what has happened in Karnataka is that almost 1,700 facilities have had received the Kayakalp Award in 2019, which is when we did the study, and about only 48 had received state certification, and only 11 had received national certification. So in 2019, when we did the study, the state hadn't, the program was still rolling out, it was still at its nascent stages. And usually the way that that because Lakshya and Kayakalp are instituted in labor and OT, sometimes the process started with a few departments. So that is included, ICU, SNCU, blood bank, radiology, and then could be scaled up to the rest of the facility. Okay, So there are 6 criteria, and the certificate there are certain ways, the scores for each department and each area of concern, and there is a process by which the facility gets certified. I'm just going to go over this very quickly. So the main research question we wanted to ask in our study was what factors enabled a facility to get certified. So this is sort of like a mid program review, trying to understand what factors would help a facility get certified, so that we could understand what the issues are for the other facilities and help with supporting them and motivating them. The study should actually also look at what would enable sustain the program. But as it was still in its nascent state, we focused on enablers. On the other side of the coin is barriers to achieving certification at the health facility. So what we did was that we were doing this study as part of the work that PRCs usually do for the ministry, and so we tried to we selected the aim, and when we conceptualized the study, we selected 5 districts in which to conduct it. Tumkur, which was an early innovator, and the district hospital and the Taluk hospital had received national certification. Same with Koppal, and Ballari, which is in a different region of the state, more in the northwestern region of the state. We wanted to do Bangalore and Kodagu, because Kodagu is a hilly region. So each of these, the idea was that each of these districts would, they vary regionally, as well as in terms of the number of hard to reach areas that are there, proximity to Bangalore. Because of COVID, we were able to do Tumkur, Koppal, and Kodagu. Tumkur, Koppal, Ballari, and Kodagu, and had not yet done Bangalore urban. So for that is the next part of the study. For this part, we're only looking at these districts, and we will hope to continue because urban health is a very important issue. So what we did was we used both qualitative and quantitative methods. We talked to all the stakeholders involved as much as possible. Conducted interviews with different personnel in each facility. We talked to people at the state and district level, and then we talked to patients and relatives that were in the hospital. Ideally, you should do a community survey as well. But since it's as I said earlier, a nascent program, we thought that the patients may not know if quality has improved. Not the patient, sorry, the patient's family may not be aware of the improvements in the health facility. So we restricted it to only looking at the facility itself and patients that were and their relatives that were in the facility that we visited. I'm going to skip this. And what we found by and large is that the program has a tremendous impact on all the stakeholders. So the health personnel, the facility, the staff at the facility, and patients all universally agreed that the facility which was certified, as well as the facility that was undergoing the assessment, so the process of certification, had all increased, had improved considerably. And we could see this in terms of the number of OPD, IPD that increased, that there was a stark increase in the number of OPD, IPD, as well as that the number of referrals in facilities that had been certified, so number of referrals out, decreased. So there was a huge increase in terms of the performance of the facilities. We also talked to staff who felt that one of the aspects of the program that really stood out for staff was that although it increased their burden of work tremendously, it also increased their engagement and their confidence in the work that they do. And this was because that part of the NCOS process is that SOPs have to be provided, have to be set up at each department and for each work, so that there's a very clear statement of procedure. So that helped the staff gain confidence in the
Okay. Please
Yeah.
wrap it up. If there is
Okay.
a time and fourth person is not around, so I will give you a chance again.
Okay. So, so mainly what we found was that, as most of us know, that one of the biggest enablers is human related. So is human sort of resource related. That means the capability of the MO at the facility, the capability or the interest and commitment from their staff, as well as the commitment from district level officials in handholding and seeing that the process works. Another aspect of capacity that really enabled the process was the social network of the social capital, let me say, of the MO. So when they had a good relationship with the district, then they had a good relationship with district administration as well as district health personnel, then the facility was much more likely to go through the process more successfully. Training was a big, very big enabler, as well as a barrier. Where there was no proper training, not enough could be done. And of course, we all know that the catchment area really matters. So you could have a terrific building and full infrastructure and HR, but if there's not enough catchment population, it's going to be a problem for because one of the indicators is performance. So finally, I just want to point out that I'm going to skip this, can come back to it, that India has some challenges ahead, and which could also be opportunities. One of the biggest challenges for the health system is the inequality. This is across regions and within regions. So there's for example, for Karnataka, there's a lot of migration from other parts of the country. So language is a issue. So how do we incorporate this these differences, this diversity of population within the health system? The other is the age structure change. There is a focus on maternal and child health that we all know of. We're starting to talk about, do more about NCDs. But the population age structure change that is expected in India is going to be a challenge as well as an opportunity. I'm just going to stop here for now, Professor Nisa, because I've run out of time.
Thank you very much. Basically, we have very short time, so we have to manage it. And this type of studies are required, and it required more time to explain about it. Thank you very much, Subha. And I also like to welcome Praveen Agarwal, Dr. Praveen Agarwal, who have joined a little late in this session. And you have to, at the end, describe about this studies also. I will request you after the presentations. And now the fourth paper is about the burden of HIV/AIDS in India by Joliet and Sandhya. Who is presenting fourth paper?
Hello, ma'am. Am I audible?
Yes, you are audible. Little louder, please, little louder.
Okay, ma'am. It's my...
Yeah.
Yes.
That is also visible. If you wish, you can change it to PowerPoint presentation.
Yes. Is my screen visible, ma'am?
Yes, yes. Start, please start.
Yes. Hello, my name is Juliet, and I will be presenting on the topic, the burden of HIV/AIDS in India and Northeast states. So this is the overall outline of my presentation. And this human immunodeficiency virus, as it attacks the immune system, and the severe phase of the HIV infection is called the acquired immunodeficiency syndrome. So since the first reported case in 1981, the HIV epidemic has become a major global public health threat and development challenge. So since the beginning of the epidemic, there have been 75.7 million, out of which 32.7 million have died. And then according to WHO, the HIV/AIDS become the eighth leading cause of death, the eighth leading cause of death globally in 2019. In 2019, despite the significant fall in HIV/AIDS death during the last 2 decades, it remains one of the leading cause of death in the lower income countries. So the global burden of disease in 2019 has also revealed that 14, 15 to 49 years and under 5 years were the most at risk. So India is the third largest country with a HIV epidemic in 2019. So according to the NECO estimates, there are 23.49 lakh people living with HIV in India, but it have a HIV prevalence rate 0.2%, which is below the global threshold of 0.8%. So, however, 2/5 of the Indian states have HIV preference rate higher than the national threshold. And as we can see that it has been an alarming issues in the Northeast states in India, and since 2017, 3 states, that is Mizoram, Manipur, and Nagaland, have topped the highest prevalence rate. And moreover, there are 5 states which have the HIV incidence higher than the national average. And so as the adult prevalence, there are 4 states higher than the national average. And the age-related mortality per 1 lakh population also is higher in 4 states of the Northeast states, comparing to the national average. So there are certain studies which shows that health status reduces economic productivity and which impact the economic growth. And there are also studies which shows that HIV epidemic has enormously affected the economically active population, which shadows the breadwinner of the family. And moreover, it results in low factor productivity due to its loss of skills and unskilled laborers, and decline in saving due to increase in medical consumptions. And so it shows that the epidemic had impact on demographic and health, which could be highly addressed by the mortality and morbidity outcomes. So studies has shown that HIV infected patients have more than 38 years less than the standard life expectancy at the age of 20. However, there are also some studies which shows that HIV positive life expectancy has increased during the past decade in both high, middle, and low income countries. However, the life expectancy is still not yet to the standard life expectancy due to the initial antiretroviral treatment. So there are also some studies which shows that the daily loss due to HIV increased from 18,000 in 1990 to 81,000 in 2010. So the burden of HIV using Delhi was calculated at the global and country levels, and then it was shows that HIV account 2.8% of the global death and 3.3% of the global Delhi 2010. So it is also shows that the top cause of mortality and burden globally, HIV continues to be the top cause of mortality and burden globally, and it ranked the most common deadly cause for both sexes in 30 to 44 age groups. So one of the problem is what we can see is the high prevalence and incidence of HIV among the working age group. And as we can see, India comprises 11.4% of the global HIV/AIDS Delhi, while it shares only 1.8% of its country total burden. So HIV presents a relatively small fractions of the total disease burden, while its shares is huge in the global HIV burden. So it is important, given the country's size, diversity, and variations across health services or HIV services, to know the impact on the economy through the indirect productivity loss of income among the working age group. So the research questions of the study is to find the impact of HIV epidemic on the GDP in India, and the impact of HIV in the gross state domestic among the Northeast states. So the objective of the study attempt to quantify or calculate the burden of HIV using the disability adjusted life years in Indian Northeast states. So the burden of HIV is calculated using WHO methodology of measuring the global burden disease. So it is calculated using the Delhi approach to measure the health gaps by combining the year of life loss due to premature death and loss of healthy life resulting from disability. So in the study, the Delhi is calculated using the standard formula where we sum up the year of life loss due to disability and year of life loss due to premature death, where the year of life loss due to premature death is calculated by multiplying the numbers of death due to HIV and the standard life expectancy, and the year of life loss due to disability is calculated by multiplying the numbers of HIV prevalence cases and the HIV disability weights. So using the human capital approach, the value of Delhi loss due to HIV is calculated by multiplying the Delhi by the GDP per capita for the working age group, which is 15 to 49. So the study is based on secondary data, which is collected from the sample registration system, where life expectancy at the time of death was calculated, and the total numbers of deaths and prevalent cases was extracted from the Institute of Health Metrics and Evaluation, and the HIV disability weight was calculated from the Global Burden Disease Report. And the per capita GDP at constant currency was calculated, extracted from the World Bank. And moreover, the numbers of deaths and prevalent cases in Northeast states was calculated, was collected from the National AIDS Control Organization, and gross state domestic product from the Ministry of Statistics and Program Implementation and state-wise population from the 2011 census. So the study is the study is divided into sections. One studies the India, which studies from the 2 decades, 2000 to 2019, and it includes all different age group and gender-wise, and the economic burden is calculated for the working age group. Among the Northeast, it studies between 2007 to 2014, and it includes only the 15 to 49 years, and it studies among the 8 states. So as we can see, this is in India, the year of life loss due to premature death. It shows that the year of life loss due to premature death, it shows a decreasing trend under 5. So it shows a new curve. This is so this green trend is the 15 to 49 years. So death due to HIV/AIDS has fallen by 59%, which could be the consistent rapid increase in HIV services like access, ART access, and so as the free ART services. And so studies have also shown that according to the NECA report, 4.5 lakh of lives were saved during 2004 to 2014 in the country, and a program like eliminations of mother to child transmission. So the year of life loss disability, it shows declining rate during the last 2 decades by 20%, and it has been declined for the age group under 5 and the 15 to 49 years. However, on the contrary, the YLD has been increasing over the period for the remaining age group. So we can see that HIV causes more losses due to premature death than disability. So the Delhi loss due to HIV has reduced by 51% during the last 2 decades. And as we can see, as we can see, 4/5 of the total Delhi loss fall under the 15 to 49 age group, which is the working age group, and indicating an absence of a very healthy workforce. So we can also see that more than half of the Delhi loss due to HIV are among the males. And then, so India ranked 15, but accounted 11%. As we can see, Indian Delhi ranked 15, but it accounted only 11.4 of the HIV deaths. And then this, and the burden of HIV in India it shows that the burden during the last 2 decades has increased by 20%, and then and it accounted for 109.7 billion, and during the past 7 years, the average burden has been very high. The average burden has been also increasing. So we can see that the male population was more affected by the burden compared to the female population. So so the burden share of HIV in the national GDP accounts the highest in 2005, which is 0.56%. So it has declined over the last 2 decades from 0.3 to 0.1 percent. So and moreover, during the 2018 to 19, the burden share have declined to 0.07%. So it is shown that the average person share of HIV burden in the economy is below 0.4% during the 2 decades, which is comparative low comparing to other diseases such as injuries, which account 3.68%. So so now we will see the burden of HIV in Northeast states. So this is the year of life loss due to premature death. It has seen that Manipur and Nagaland have the highest year of life loss due to premature death, and the year of life loss has fluctuated, and the total year of life loss has slightly declined during 2013 to 16, and Manipur and Nagaland have the highest. Okay, so this is the Delhi. So we can see that Manipur and Nagaland have the highest Delhi loss due to HIV over the decade, and due to its alarming HIV infection during the period. And so we can also see that Sikkim and Arunachal have the least Delhi loss due to HIV among the states, and Assam has the 3rd largest Delhi loss during the decade, followed by Mizoram and Tripura. And despite Assam has the least year of life loss due to disability, but it has a high year of life loss due to premature death. So the burden of HIV has increased by 62% during the last 12 decades, and last 12 years, I mean. So during 2007 to 19, the total burden of HIV in the Northeast state has accounted rupees 5 to 7 crore per year. And so during the 5 years, the burden in the economy has accounted 630 crore per year. So so as we can see that Manipur accounted 46 of the total burden share of the HIV in the Northeast states, and then during the 17 and 19 year, the burden in yes,
wrap it up.
Yes, okay, yes. Okay, so it was found that the Northeast state accounted for 3.3% of the national burden of HIV/AIDS, and then the Northeast burden of the it has increased from 11% in 2017 to 9.2% in 2019. So the burden share in the economy is higher than the national average, which is only 0.31%. So we can conclude that due to the highest, we can see that the expansion of HIV services like ART for ART drugs and all had gained a positive, have shown a positive result. And moreover, one of the interesting thing is that in year of life loss due to disability have increased over 70 age group. Okay, so which shows that the expansion of free antiretroviral treatment to people living with HIV has saved and prolonged life. And so, as we can see, the Northeast states burden share has increased to 11% in 2017, and so we can suggest that these states, Manipur, Mizoram, Nagaland, have required a specific attention where the ongoing prevention and treatment services need to be fast-tracked. So, so as we can see that HIV/AIDS is need to be effectively countered. Policy action against AIDS must be seen as a growth-enhancing policy endeavor. So, and this required a dedicated adequate resources for this purpose. So, so the government needs to strengthen the services by expanding the ARTC, ICTC, blood bank, and all other services within the District of India, as well as the high burden states in the Northeast states to reduce the HIV prevalence and incidence rate. So this is the so thank you, and these are the references I use for the presentations. Okay, thank you.
Thank you, Juliet. Very interesting paper. Whether Menika Kumari have joined the session? Menika, are you there? Okay. If she is not around, then what I can do, I will just give one or two more minutes to all the presenters to talk about their main finding as well as introduce themselves, because I have not introduced all of you. Although I am familiar with only one or two persons, but not with all the persons. So Purva, can you join again and just introduce yourself, where you are working, what you are doing, as well as one main finding from your study. Purva, are you there?
Hello.
You introduce yourself.
Hello, good morning, everyone. My name is Purva Bhala. I'm working in Population Research Center as a research analyst, and my study is on outreach capacity of public health on of out of school anemic adolescent girls. Basically, in my study, the main focus is on as how the out of school anemic adolescent girls have to be referred to the frontline workers, as how it is very important for them to contact for their personal hygiene issues, nutritional deficit. As they are not going to school, they have facing more and more difficulty, as we already have discussed that they're facing early marriages, violence, and they're getting, if they're getting married, then they have early babies. And in this age group, if they are anemic and they are getting married, so it's a very problematic for the whole scenario. And these are the main frontline workers. We all know that they're performing their duty very well. So for contacting these healthline workers and to adolescent girls will help their nutritional status to not to get deficit, but to have a benefit for their health and future. Was the main study that how the out of school anemic adolescent girls are contacting Anganwadis, Ashas, and ANM for their health issues.
Thank you. Thank you.
Thank you. Thank you, ma'am.
Dr. Lekha Subba?
I am Lekha Subaya. I am faculty at TRC in Iasp, Bangalore. My study was focused on the quality assurance in health systems. And our study, I guess, main point I'd like to make is that that in terms of health system intervention, so in terms of any program being introduced and then scaled up, it's as much as infrastructure and human resource is important, capacity building is also important. So what we saw was dynamic leadership and commitment from the staff at the health facility mattered a great deal, as well as the sort of the relationship with the staff and the community leaders. And if in the next 10, 20 years, India there are enormous opportunities for India as well as challenges. And if you want to take advantage of our population in the growth in the working age population that we expect for the next few years, then their health really matters. And so inequalities in in region, inequalities in gender, caste, and income will impede people's access to health. And so the public health system matters more than ever.
Thank you very much. The last presenter is Juliet. Juliet, you want to introduce yourself and also give main finding from your study, which is very close to your heart.
Yes.
Yeah.
Hello, my name is Juliet, and I'm a research scholar from School of Economics, University of Hyderabad. So, and then the main findings, my studies attempt to calculate the burden of HIV/AIDS in India and Nordic states using the disability adjusted life years. So my main findings of my study is that the burden of HIV/AIDS in the Nordic states, especially on the three states, Manipur, Nagaland, Mizoram, have higher HIV/AIDS burden share on the economy, while the national average is 0.1% in 2017, but it accounts for 3.3% and have been increasing during the years, which shows there's an urgent need to provide equitable, affordable, and quality healthcare delivery in these vulnerable states. So these are the main findings of my studies. Thank you.
Thank you, Juliet. Now I invite Dr. Praveen Agarwal. He's played very vital role in a comprehensive national nutrition survey, and at present he's working in different organizations, but his role in doing this nutrition related as well as health related work is significant. So Dr. Praveen Agarwal, please talk about all this paper. If you have any comment or suggestion for the authors, please feel free to give them. And meanwhile, I also request the attendees who are there.
Okay, thank you, ma'am.
1 minute. If you have any question, please write in chat box, and Dr. Praveen Agarwal will direct it to the authors. So please.
Okay, thanks, ma'am. Thank you for inviting for a call here. And I mean, I could listen all the 3 paper and also at the end of summary, although I joined little later. And I will go one by one very critical points from the paper in view of programmatic lens, how those are important for program. And good news is that recently we have the NFHS full data and some good news and some challenging news where we have to work together as a program implementer or researcher. So first paper by Purvi Bhalla and Dr. Sharma, very important in view of program implementation. And we know the Anemia of Bharat is implemented since long, and still either you see SNES or NFHS 5 or continuation in all surveys, anemia is still a high burden across the board, and especially vulnerable population out of school children. So attention focusing on that is very important. What I see, the presented finding was high anemia but low coverage by FLW at a state level. That some one quadrant was shown. There we need to focus more on the sub-district or district level analysis, where, I mean, why those FLW or frontline worker are not connecting well. And I see a very good correlation from the second paper where health quality standard was there, although that is more on the health facility side, but also frontline worker side, because we have done previous lot of analysis where we have found when the frontline worker have a poor or limited knowledge, they have a less confidence and they have a less likely to give a quality communication or quality services to the community, and then the result of those frontline functionary action is very limited on the outcome. So, and rightly told by that presenter Purva, that it's not just anemia, and we know like 50% is because of iron deficiency anemia. So until unless there is a food in mouth, there is a tablet in mouth, especially those population, the burden of anemia is not going to solve. I mean, we have seen like program is there for all. I mean, if we talk about anemia Bharat, like all different approach, treat and treatment, and also like 6x6 approach, different approach for different population. But still the challenge is until unless we have very quality frontline worker and they are really giving right messages, especially on communication with confidence, it is not going to change. So data is very important, but state level data is fine, but we have to do analysis for micro level, district and sub-district for evidence-based programming. I mean, where there is lagging. So thanks for presenting and putting those kind of paper, which is really programmatic relevance. The second paper was really interesting by Dr. Lekha. Thank you for presenting this. And the most important part is that quality of care standard. I see like program is giving focus since last 2 or 3 decades, and we have made a huge changes across the board. But still, the critical thing is very basic thing. What you have presented as enabler as well as barrier, very important, like having a staff, the quality training, because now I'm implementing in field and see how important to keep them motivated. So mixing both, they are enabler as well as they are barrier. So how to change those barrier as an enabler, how to change that threat and problem as an opportunity, that lies in the commitment by the leadership or commitment. So again, I mean, the data is again like large city-wise, or but it has to be again each and every facility-wise. We have to rank them. We have to give proper attention. We know like some of even AIMS, I was reviewing the data of AIMS in newspaper, like 60 to 70% the staffing is not there. And then who are the staff? Their training capacity is limited. So then if we talk about the front line or the community level or the lower level of facilities, I mean, challenges are much more. So those again, I mean, poor performing facility has to be given attention. Having proper staff, having their capacity built is very crucial. And until unless we do that work at community and lower level, I mean, no matter how many round of PNS and FHS we do, those kind of critical indicator will be not performing well. So thank you for that, Dr. Lekha. And the third paper I could listen, very important. We have seen like success of HIV program. Across the India, it was showing in that analysis, and she has really presented lots of data, like from 0.56% of daily burden. Currently, it's 0.0. Sorry, economic burden, it's less than 1%, 0.1% in 2017, and decrease of Delhi of 51% is very commendable. But at the same time, the presenter presented about the Manipur and Nagaland, how the economic share is very high in comparison of national, because I see that there is huge change in the program for HIV. Before there was a very dedicated unit and all. I mean, there that has, because of national average has gone down, the investment is a little lower. But of course, where there is a burden in Manipur and Nagaland kind of a state, a program has to refocus and all kind of HIV services has to be built on. But one thing I want to have a question, because overall, if HIV burden has gone down, economic burden has gone down, Delhi has decreased. So if we are presenting in comparison of other states, then burden of HIV in Manipur, Northeast must have been increased. But what about their state specific trend? Because if you do a comparison of a big pie to a small pie, and then you put a share of a particular area where the burden is more, then you will see the bigger picture. But if you see the overall that particular state trend, this picture or this evidence, this may not hold true. So that may be relook, because if overall burden has gone down, prevalence has gone down, so burden must not have increased like that. So with this question as well as few critical comments, and I congratulate all the authors for putting together the programmatic relevance paper rather than only theoretical paper. So thank you everyone.
Juliet, you want to answer to Dr. Praveen Agarwal this question? Or just take this as a suggestion also, so you can think about what else you can do in the analysis. Anybody from the audience want to ask any question to the authors? Anybody? Okay. No one? Yeah. Purabhi, it's not only the question of out of school girls approaching frontline worker. Among school also, whether frontline worker is going to school, no. So we need to think about how best we can talk about frontline worker. And for Anganwadi, this thing is people have to come to Anganwadi. They will not go to the field, whereas Asha and other people. So don't mix it up. There are services which people have to go. There are services which are available at the doorstep. So you classify these two differently. So adolescent coming to the Anganwadi, Asha going to the girls. So these are two different things. People will not come to Asha directly. Asha will go and talk to the people. So when you are analyzing, keep this thing in your mind.
Sure, ma'am.
And
Sure.
you have Lekha has presented nicely. One thing when we are comparing about the health facilities, we basically we take only government facilities, but there are quite a few private facilities which are coming up. So if we compare facilities at the primary level, that is like a sub-center level or PSC level, it is fine how these are growing. Whereas if you look at the Karnataka, Tamil Nadu, Telangana, all these states, private health facilities are coming up like anything. So the number is much more than what we are presenting it. And also we can present this by population ratio also if we feel like. And see wherever the population ratio is very high, enablers and all those things also you can talk about. If there is a lot of pressure on the people to serve the community with so many people are coming out. Look at the facilities are so good in AIMS or in Bombay also we see in science people are sitting outside for services also. So such a big rush is there. The facilities have so much this thing. So you try to relate this also about the population ratios on and pressure on the health facilities as well as training and all other things. So people will not be able to serve this many people. And at the end, they get irritated. Just 2 days back, I have gone to this Aadhaar card, this thing modification with my daughter-in-law. What I have found, people are so irritated. Everybody is irritated. And I was thinking, why so? Because daily they have to face so much pressure and they were not able to talk to anybody properly and all other things. So I was thinking about, yeah, it is true with health facilities. It is true with all other facilities when they have to work hard for so many this thing. And their anger, their this thing, all those things will come out from them. Okay. So this was second thing, we need to relate it with population also, not only the training and all other things. The third Juliet thing was quite interesting, using it years lost and all those things. So now it's not only just this thing, how much expenditure government is spending on because of that expenditure, people are surviving because with HIV AIDS also. We need to think about this thing, how much we are saving, and as well a burden you have already seen, a burden you have seen, and need to think about two ways. How much it has been spent to save this many years also. And this strengthening program and all those things are good, but how many lives we have saved and how much we have spent on this thing. And apart from this HIV also, we can do for many diseases which people are not thinking about it. For example, malaria is such a prevalent disease. How many people are dying because of, how many years are lost because of malaria. Some of the things, small diseases also have this thing. How many lives we are losing it because of this disease also are very important to discuss and analyze, not only HIV. So you have done a good job. I am not talking about it. For this is for all the audience and the other people also. We need to tell the government also how many years are lost because of this diseases also. Dr. Praveen Agarwal, you have anything to add on this thing? And apart from this, as a teacher, basically my teacher thing will come out quickly. I want all of you to write the policies in such a manner that can be used by policymakers. Don't make it pure research type of thing. So who researcher will read, researcher are not policymakers. They will not be able to use it. Whereas if you want to write anything which is useful for policies and program, write in that language. At the end, you should come out with one or two specific this thing, and that can be used by the policymakers, programmers. Okay, now again,
Ma'am, I have a very minor observation.
yes, please feel free to ask.
Okay.
Feel free to.
Okay, that is about the paper on anemia.
Which
Uh,
paper?
on anemia, the
Okay.
paper I think by Purva. So just out of curiosity, I just wanted to know that when I see the patho reports, many times pathological reports, so they mention for female it is 11 to 16 is the normal range, whereas in your paper you showed 11 comes under the moderate anemia category. So what is the truth? Because this is what we get directly when I get a report. So that means at a programmatic level, the people who are between 11 to 12, they really are shown as normal, not in anemia category. So why this difference? Does it make any sense in terms of when we do a research versus the program?
Hello, sir. Thank you for your question. I just wanted to say that while we are referring to the Anemia Mukt Bharat, which is the main program of the means of India, as they have launched it and they have defined it, how the people are being suffering, as basically the women are being suffering from anemia, and there are seven, and they have means make the section of severe, moderate, and mild. Yes, I do agree. There are at times it varies, but yeah, if we look at the proper we can see that if through a government organization, and we have to restrict it our research on that. So basically they're serving according to that only. With mild anemia, it's for 10 to 12 gram, so it's like that section only. So hello.
Uh, Praveen, you want to come? Dr. Praveen?
Ma'am, I think I'm fine, and I congratulate all for this very programmatic relevant paper. And they should do little micro level analysis as well once data is available, and really publish so that we as implementers use it. Thank you.
Okay, so please publish the papers. Okay.
Yeah, sure, ma'am.
Yeah, with this note, I like to thank all the presenters as well as organizers for giving us opportunity, for me as a chairperson, for authors as a presenters, and all the attendees for attending this session. We have started a little late, so we are now closing it at around 10:20 with only 3 papers. Huh? I was worried about what will happen if there are 4 presenters and we have to discuss about it. Thank you, everybody, and all the best. All the best for your future.
Thank you so much, ma'am.
Thank you. Thank you, ma'am.
Thank you, everyone.
Thanks, ma'am, and thanks, Praveen sir. Joined us. I have called, and he told me that please send me link. I will join right now. So thanks to
Actually,
chair
sorry,
and
I was
co-chair,
not
and
aware.
thanks to
Somehow,
all
na, I was
presenters.
a little busy. I'm really sorry to join
Okay,
late
sir.
and not
Sorry,
having.
it was our
Yeah.
fault. Actually, we have sent the mail. Sorry. So finally, thanks to chair and co-chair and all presenters. Thanks. So now we will close the formally close the session.
Thank you.
Thank you. Thank you.
निकाल के ना केवल फिर नंबर कॉल होता है मोबाइल से कुछ के निकल के साइन करानो कह रहे हैं मोबाइल आओ तो इन दोनों डबल की काट के फेंक दूंगा ज्यादा बोलेंगे मैं तो मोबाइल मुझे हम तो बड़ा ट्रिपल फुल का एक ट्रिपल और वो इनको और के बाद भी नहीं ट्रिपल फोन को पड़ गया तो सही मानना है काम को ये मौका है ना मुझे ना मैंने देखे
ಈ ವರ್ಷದನು ಬೆಲ್ಲ ತಂದಿಡ್ತೀನಿ ನಾನು ಅವ್ ತಗೊಂಡು ಮೇಡಮ್ ಹೇಳಿ ಆಯ್ತಿರಿ ಅಂದ್ರೆ ಇಲ್ಲಿ ಅಂದ್ರೆ ಇಲ್ಲಿ ಇಟ್ಟು ನೋಡ್ರಿ ಅಂತ ಅಂದೆ. ಈಗ ಇವು ಹೆಂಗ್ ಮಾಡೋದಲ್ಲ ಇನ್ನ ಬಟ್ ಇವೆಲ್ಲ ಯೂನಿಫಾರ್ಮ್ ಒಳಗಿದ್ದು ಇನ್ನ ಹೊಸದ್ ಬಂದಿಲ್ಲ.
Thank you, Chairperson. Thank you, IASP, for giving this opportunity. I am presenting a paper on estimation of life expectancy at age X for districts in India for 2011. Thank you, Chairperson. Thank you, IASP, for giving this opportunity. I am presenting a paper estimation of life expectancy at age X for districts in India for 2011 using the median age of the total population. As you all know, life tables play an important role in understanding the mortality situation of any country and its subunits.
Good afternoon, sir.
Hello.
जितेंद्र जितेंद्र
Hello.
हाँ जितेंद्र
Yes, sir. Yes, sir.
सुमेजुलू सर से मैंने बोला था कि चेयर करने के लिए किसी को बोल देंगे, को चेयर तो मुझे करना है।
सर
चेयर
अभी बात किया था मैं RS गोयल सर से।
हाँ गोयल सर तो आ गए।
बोला कि हाँ सर ज्वाइन कर लिया सर, ज्वाइन कर लिया।
गोयल सर नमस्कार। नमस्कार सर।
गोयल सर का म्यूट है। गोयल सर अनम्यूट
उनका
कर लीजिए।
म्यूट से मतलब नहीं, आवाज तो जा रही होगी। कुलकर्णी सर नमस्ते।
वो बोल रहा हो तो आवाज नहीं।
Nobody is there here. नहीं सबका
गोयल
म्यूट है
सर
लेकिन
नमस्कार।
Okay, this is Professor Goyal. Can you hear me, sir?
Yes sir. Welcome.
Thank you very much. I'm sorry.
नमस्कार कुलकर्णी सर। कुलकर्णी सर नमस्कार।
कुलकर्णी सर नमस्ते।
Kulkarni sir,
नमस्ते
good
सर।
morning. How are
नमस्ते
you,
सर।
sir?
नमस्ते सर।
Okay, can we start the meeting?
Yes.
Yes sir. So
yes sir.
So on behalf of the ISP, on behalf of the ISP, I welcome to all presenters and the chair and co-chair for this session, and especially thanks to Goyal sir. Just before 10 minutes, I have called him and sir, I request sir please chair the session because Professor K.K. Singh is not able to chair, and sir told me please send me link and detail. I will join. So thank you, sir, for very
It's a pleasure.
short notice. 10 minutes to join. Yes, sir. And then our co-chair is Professor Brijesh Pratap Singh, and he is a professor in the Stat Department, BHU. And so I am not going to take much time. And over to chair and co-chair.
Thank you, Jitendra. Sir, please proceed on.
Thank you very much, Dr. Singh. And it's a pleasure to chair this session, though at a very short notice. No issue. Anything for ISP. I request Dr. Singh to initiate the process for presentation because we have little time and number of speakers are pretty large. So I request Dr. Singh to initiate the proceedings.
Okay,
Dr.
sir.
Singh.
Okay, sir. Thank you, sir. Sir, in this session, there are five papers included in the brochure. And the first presenter is Vivek Burma, and he is going to present on Bayesian estimation of fertility rate under imperfect age reporting. Vivek, you are here. Vivek, you are here.
Very good afternoon, sir. Sir, am I audible?
Yes, you are audible, but someone also
Yes,
audible
I
behind you.
অনেকদিন থেকে তো করছিস
I-
করে আমার সেই
ICS team,
পুরনো
please,
80 টাকাটা
please,
মনে আছে
please
তার
unmute to others.
তারপর থেকে তো কিছু
ICS
দেওয়া
team.
হয়নি
Mintu ji, please mute
Vivek,
the other
তুলি ভাই
person.
একদিন বলছিল না
Vivek, presenters,
লিখে রাখিনি
this session is start from 12:15 and till 1:30. So we have 1 and 15 hour, and there are 5 papers. So for every paper, 15 minutes are allotted, and if chair permits, all the questions asked to the presenter after the
Thank you, sir.
presentation or
Sir, may
after
I-
all presenter.
Hello, sir.
Hello, Goyal sir.
Yes, sir.
Sir, question answer session is in the last. For
That is
all
that is
presentation
good,
will be done, or
That is good, sir.
after one presentation.
At the end will be better.
At the end will be better. So Vivek, you are present here. Vivek, you are present here. Professor Abhay Kumar Tiwari is visible. P. Krishnamurthy, Professor P. Krishnamurthy is there or not? There are 2 papers of P. Krishnamurthy, and another paper is
Vivek
SL
Verma is
Ragendu.
there.
Yeah.
Vivek Verma is there.
Okay, so all five persons are there or not? So we should start.
Let's check one
So
by
Vivek,
one.
so Vivek, you proceed on with your paper. Vivek, we are audible.
Yes.
So go on with your presentation.
Sir,
Vivek, you are not audible, and your presentation is all not visible to us. Yes, now it is visible. No, Vivek, you are not audible. Vivek, you are not audible.
yes, sir, I am here.
Hello, Vivek.
Sir. Am I audible?
Sometimes you are audible, but sometimes not. Well, sir. Well, sir.
I think Dr. Vijay sir, I think we may go for a second presenter and ask.
Yes, yes, I think so. I think so.
Yeah.
So Vivek, wait for some time. Wait for some time, and we go for the next paper. So P. Krishnamurthy is here. P. Krishnamurthy is here.
Hello, sir. Hello.
Hello.
Yes, sir. I sent my presentations already to the Iasp to display.
Okay. Okay, Jitender ji.
Okay, sir. Okay, sir. We will take care, sir.
Yeah.
Vivek, please down your this presentation, and we'll call later on you.
ICS global team, Mantu ji. Mantu ji, are you there?
Hello. I am here only, but I sent it.
Yes, sir. We will arrange. We will arrange, sir.
Yeah.
Jitender ji asking.
Okay. Okay. I am asking.
Jay Singh ji, namaste.
Namaste. Namaste, sir. Namaste, sir.
How are you?
Fine, fine.
Okay.
Okay,
So
some
IT
technical
team,
issues is there.
No,
Oh,
IT
okay.
team is going. IT team is going to present the Murthy sir paper.
Okay.
They are arranging.
Once it is visible, then Murthy sir will start.
Okay.
How many papers are there, sir?
5 papers.
What are
5 papers,
present?
but the network issue is there. 2 papers belongs to P. Krishnamurthy. One is S.L. Ragendu.
Okay.
One is from Professor Abhay Kumar Tiwari, and one is Vivek Verma. But Vivek Verma is, I think, facing some network issue.
Oh, okay.
So Tiwari is ready. I think Tiwari should give the permission to present his paper. There are some technical issue.
Yeah, I think PK Murthy sir's paper is recorded.
Yes, P. Krishnamurthy said that he is already sent.
Yeah, his paper is recorded.
Who is the third one?
Third one is S.L. Ragendu.
Ragendu.
Yes,
yeah, it is going.
Murthy sir paper is there.
Yeah.
So please, Murthy sir, start.
I think it is video recorded.
Yes,
Yeah.
it is video recorded.
But Iasp for giving this opportunity. I am presenting my paper on estimation of life expectancy at age X for districts in India for 2011 using the median age of the total population. As you all know, life tables play an important role in understanding the mortality situation of any country and its subunits. The main sources of mortality information for constructing live tables in India generally are the censuses, sample registration system, and the National Family Health Surveys. Sample registration system, as you all know, providing the live tables for India and its major states from 1970 onwards. However, the sample registration system does not provide any live tables for the states. National Family Health Surveys conducted by the IAPS started providing mortality data for districts also, that which can be used for constructing the live tables. So few of the researchers already made some live tables for India and its units, subunits using the NFHS data. As we already know, with a dramatic decline in the mortality of all the major states and India over the past few decades, a
क्या कमरे में लगी हुई है? तुम कहीं जा रहे हो? क्या कमरे में लगी हुई थी? मैंने खोली थी ना आपके सामने, जब मैंने कहा था वो मैं कमरा खोल दिया है। तो तभी चली गई थी ना? नहीं, तुम्हारे आने के बाद।
Mantu ji, please unmute others.
ये नहीं पता, मैं ऊपर आ गया था मैं।
Mantu ji, please unmute others.
जितेंद्र जी, जितेंद्र,
Yes. Hello.
आईसीटी ग्लोबल को बोलिए कि वीडियो वगैरह कुछ दिख नहीं रहा है।
मिंटू जी, हेलो।
वापस में बात कर रहे हैं लोग खाली।
हेलो मिंटू जी।
Thank you, Chairperson. Thank you, IASP, for giving this opportunity. I am presenting my paper on estimation of life expectancy at age X for districts in India for 2011 using the median age of the total population. As you all know, life tables play an important role in understanding the mortality situation of any country. And
जितेंद्र,
मैं बात कर रहा हूँ सर, फोन पे बात कर रहा हूँ।
अरे उन लोगों को
कुछ समय पश्चात प्रयास करें। The number you dialed is
India and its major states from 1970 onwards. However, does not provide any live tables for the states. National Family Health Surveys conducted by the IAPS started providing mortality data for districts also, that which can be used for constructing the live tables. So few of the researchers already made some live tables for India and its units, subunits using the NFHS data. As we already know, with a dramatic decline in the mortality of all the major states and India over the past few decades, a need has arisen to have detailed live tables even for districts in India. District far, no researcher tried to provide live tables for all the districts in India due to the non-availability of age-specific death rates at the district level. If so, is there any chance to provide live tables for districts in India? So the present study is such an attempt in providing a methodology to derive the live tables for the districts also in India. So the aims and objectives and data requirements are as follows. The main aim of the present study is to develop a methodology for estimating life expectancy at age X for both sexes combined from the median age of the total population, which is also of both sexes combined, and also to provide life expectancy at age X for all the districts in India for 2011. In specific to say, to provide regression models and a reference table based on them for estimating life expectancy at age X from the simple information on median age of the total population, to provide life expectancy at age X for districts in India for the year 2011 using the above methodology. So when you come to the data requirements for district level analysis,
I think only audio is coming, no video. I don't know why.
So please allow me 2 minutes to rectify the things.
Okay. Go ahead, sir.
I can, but I can't see the slides right now.
Okay, sir.
I can hear it. I can hear it.
There is some problem with ICT Global, and he is
Okay, fine.
saying this.
We can wait for a minute.
In 2 minutes, he is going to rectify. Can we go further? Dr. Tiwari is there. Dr. Tiwari is
speaker
there.
is comfortable, is fine with us.
Because we have limited time, no, sir? So
I agree, sir.
I think Professor Tiwari is ready for his presentation. So we should give the chance to him or wait. ICT
Now,
Global.
but speaker who is speaking, Mr. Mohan Yadav. What about
Please
him?
go ahead, sir. Please go ahead, sir. Brijesh sir.
Dr. Yadav, please proceed.
Yes, sir.
Please complete the presentation.
ICT team is trying for the presentation of P. Krishnamurthy.
See, I have the presentation. I can actually show it.
Okay. Okay.
So I think they are doing it.
Mm-hmm. But not from start. Anil sir.
Yeah. I think you can go about 5 minutes. After 5 minutes, you should
after 5 minutes. Scroll this. Yes.
Scroll up to 5 minutes and then show, please.
Sir, can we do it now?
Mr. Krishnamurthy is online. I believe his presentation is ready.
Yes, sir.
Krishnamurthy, can we proceed with Dr. Krishnamurthy?
for distributional analysis. What we need is we make that distributional
मनीष जी साउंड बढ़ा दीजिए.
India for year to the village of what is corrected.
It's all mixed up.
Shall I share and show it, or what is it?
Dr. Bijesh, what is really happening? Can you find out?
Yes, sir. I think who is present here, Professor Tiwari is present and he wants to present his presentation. So why not we should move?
I think we should do that. We should do that.
Please proceed. Please proceed. Please proceed.
Okay. Let us we proceed. So Professor Tiwari, you are ready for presentation?
Yeah, I can.
So start.
Okay.
Thanks, Professor Tiwari, and you are going to present your paper. I think your paper name is Probability Distribution of Surviving Children in Free Process. Okay, go ahead, sir.
Can you see my slides?
Partially.
Yes, Tiwari.
Make it full screen.
Yeah.
This is fine, sir. This is fine. Proceed, Tiwari sir.
Okay. Respected chairperson, co-chair, and participants. Title of my paper is Probability Distribution of Number of Surviving Children in Free Process. Basically, in this paper, we are going to discuss about the number of surviving children out of total birth, and the knowledge of this surviving children may be used for the future fertility behavior of a couple. So a large number of the models, large number of the procedures have been proposed by the demographer to explain the number of the births. Like Dundecker 1955, Singh 64, Singh 67, 68, Singh et al. 1974. Later on, Singh and Yadva.
मैम ये कब तक खींचना है? मैं बना तो रहा हूँ तो बहुत लंबा चौड़ा है, लेकिन मैम काफी चीज ये पेपर अपना पब्लिश भी आपका मैं देख रहा हूँ रिपीट हो रहा है कई बार.
डॉक्टर जितेंद्र प्लीज.
जितेंद्र म्यूट योरसेल्फ.
पहले वाले में और दूसरे में ना, वो पहले वाले में थोड़ा इंजरीज का
Tiwari, proceed. तिवारी अनम्यूट कर लो. तिवारी अनम्यूट कर लो भाई.
So Tiwari, please continue.
This ICT peoples are doing something. They are going to mute everybody.
Hello.
Professor Tiwari.
Go ahead.
Please proceed. Please proceed, sir. Please proceed. Professor Tiwari, can you hear me?
No, sir. Goel sir. ये ICT peoples automatically.
They are doing something, sir. They are doing something, sir.
What should be done now, sir?
Once we are unmuting ourselves, then we can ask.
Shall we start again?
We have unmuted the people, sir.
Okay. So, and after that, Yadva and Srivastava in 1993, they derived the probability distribution of birth over the time for a female, giving a specified number of births in a given period in the equilibrium birth process. And this distribution of the birth was used by the Yadva and Tiwari in 2006, and they derived the number of surviving children out of total birth in equilibrium birth process. That process starts after some times. Now here in this paper, we will discuss the surviving of children in free process. So first I would like to define the difference between the equilibrium birth process and free process. So there is major difference between equilibrium birth process and free process. In free process, at the beginning of the segment, the female is exposed to the risk of conception because it starts with the marriage. While in equilibrium birth process, there is a possibility that female is not risk for the conception in the beginning. So Yadva and Tiwari, they derive distribution of conception over the time for the interval 0 to 2. 0 to T means that T start after the marriage, and they derive that distribution for the free process. Now here authors, they have analyzed the distribution of the birth for the both process, for the equilibrium birth process and for the free process, and then they found that they found different pattern of the birth over the different pattern of the birth over the time in equilibrium birth process and free process. So it is that distribution for the surviving children in equilibrium birth process, it has been already done. Then it is logical to derive the probability distribution of surviving children in free process using some law of the probability and some assumptions regarding the survival of the probability. So the objective of this paper is to derive the probability distribution of surviving children in free process. And another objective.
Tiwari, your slide is not moving. Slide is not changing, Tiwari.
Not changing?
It is not changing. Only the first slide is visible.
Yeah. And Tiwari, put your slide in the slide show mode.
I already have.
I put in slide show mode.
But here it is moving in my computer. It is showing that. Now it is?
No, now not. You can share again, sir.
Okay.
Close and share again.
And I will continue that. So main object, another objective of this paper is to derive the surviving children in equilibrium birth process as well as free process at mortality level 20 by using the waste model life table. So now next, now it is moving.
No,
sir.
So please stop sharing and then share again. It will be working.
Please close the file and share again, sir.
Just a second. Now
change करिए.
Now it is moving, sir?
No, it is not moving. इसको slide show mode में कर लो यार. Slide show में करके फिर करिए तब हो जाएगा सर.
सर इसको आप stop sharing करके फिर दोबारा share कीजिए, then it will come.
सर stop share कर दिया, then
फिर से share करिए.
Click and share again.
డబ్బులే కాదు, డబ్బులే ముఖ్యం కాదు, దే ఆర్ సెకండరీ.
हाँ, अब स्क्रॉल करिए।
अब हो रहा है?
हाँ, अब हो रहा है।
अच्छा अच्छा, ओके,
फिर कंटिन्यू करिए।
हाँ, तो नाउ let me repeat that objective. So main objective of this paper is to derive the probability distribution of surviving children in the free process. And in another objective, what we have done, we have estimated surviving children for the equilibrium birth process and free process at mortality level 20, and we have used a waste model life table. So I will discuss a procedure for deriving the probability distribution of surviving children. Basically, this we have some assumptions. This assumption was made by the Yadva and Tiwari in 2007. Same assumption we are going to use for this case also. So what they have assumed that birth occur at the midpoint of the segment, and that timing between that midpoint, timing between the birth and survey date is taken as the time length for the survival, right? And using these assumption and above mentioned information, we can calculate the number of surviving children in the free process, with the understanding that the number of the conception in interval 0 to t will correspond to the number of birth in G to G plus t, where G is the gestation period. So for this paper, we have considered two cases. We have derived the number of average number of surviving children for time t is equal to 4h and time t is equal to 5h. This is the observation. This t is the observational period. We have considered this 0 to t. So here t is 4h. 4h is the gestation period plus PPA. So here we have considered h value of h, that is 1.5 years, right? So here observational period we have considered 6 years and 7.5 years. So first we will consider that first case, that is t barabar 4h, and then suppose we are considering t is equal to 4h, that means their observational period is 6 years, and here we will have 4 segments because here h is equal to 1.5 years, and if you have 4 segments, so there will be 16 probabilities for the distribution of the birth. 16 probabilities are like that. If suppose there are 4 segments, this probability that one birth in the first segment and there is no birth in another segment, first birth in second segment, birth in third segment, and like that, then birth in first and second segment, and there is no birth in third and fourth segment. Like we have 16 probabilities, and all these probabilities are derived by the Yadva and Tiwari in 2007. So using these probability, we can estimate the average number of surviving children out of total birth in that observational period. Here we have considered observational period, that is the 4h, that is the 6 years. This is equal to 0 into probability of 0 survival in the whole period, plus 1 into probability of 1 survival, plus 2 into probability of 2 survivals, and then 3 into probability of 3 survivals, plus 4 into probability of 4 survivals. And by using putting the value of probability of 0, 1, 2, 3, and 4 survival, we can estimate the average number of surviving children out of total birth in observational period, that is 6 years or 4h. In same way, we can estimate the average number of surviving children out of total birth in 5h. If you are, suppose you are considering that observational period, that is 5h, means 7.5 years. So this formula would be like. So now we have to estimate the average number of surviving children out of total birth. We require the value of probability of 0 survival in that interval, probability of 1 survival, probability of 2, 3, and 4. So I will consider.
Professor Tiwari, can you expedite because we have little time, sir?
Definitely, sir. Okay. So I will consider only one case, that is the probability of 0 survival in 4h, and this can be explained by these 5 mutually exclusive events. First, there is no birth, and if there is only one birth in that given period, then the child does not survive till the survival date. And if they have if female have exactly 2 births in given period, then none of these 2 children survive till the survival date. Using all these probabilities, probability of these events, we can estimate the probability for the 0 survival in that 4H. In same way, we can estimate the probability for the survival for the 1 child, 2 children, 3 children, and like that. So how you are going to estimate these probability of 0 survival in 4H? So if here we have 5 events, suppose you consider one event that E10, then how you are going to estimate E10? Again, this E10 will consider some is the combination of some mutually exclusive events, and then probability of births occur in the first segment and child does not survive till the survey date. This can be estimated. This can be estimated by this probability that birth occur in the first segment into 1 minus probability of survival from birth to survey date, and that interval with that time will be 4H minus 0.5H. Why 0.5H? Because already we have assumed that birth occur at the midpoint of the segment. So probability that birth occur in first segment already we have taken from the Yadva 2007, and this probability of the survival from birth to survey date, this can be estimated from the taken from the waste motor life table, and using this formula we can estimate the probability for the birth occur in the first segment and does not survive. In same way we can define the that is only 1 birth occur, and that 1 birth occur and in the second segment, and that child does not survive from the birth to period. This can be estimated by this P0100. This can be taken from Yadva and Tiwari 2007, and finally we can estimate this probability. Here we'll have 4 cases, and using these all probabilities we can estimate the probability of survival for the 0 children, and this will come like that. Using this same procedure we can estimate the probability of survival of 1, 2, 3, and 4 children, and by putting this value we can estimate the average number of surviving children for the given interval. So these are the probabilities. These are the probability distribution in both process, equilibrium process and free process. These probabilities are taken. These probabilities are taken from the Yadva and Tiwari 2007. And using these probabilities, we have estimated probability for the number of birth and probability for the number of surviving children. And you can see that here that the probability for the number of birth in beginning cases, that probability for the free equilibrium birth process is less compared to free process. Now using this probability, we have estimated average number of birth, average number of surviving children in equilibrium birth process, average number of birth, and average number of surviving children in free process. So for T is equal to 5H, means if your observational period is 7.5 years, then there will be 2.1390. This is the average number of birth, and average number of surviving children would be 2.02735. In same for same duration that in free process, that total number of birth, average number of birth is 2.23, and average number of surviving children is 2.11. And in same way that whenever if your observational period is 4H, then average number of the birth would be 1.714, and average number of surviving children is 1.63. And but in free process, this average number of birth is 1.80, and average number of surviving children is 1.72. So finally, here we can conclude that probability distribution of birth in both cases, that if you see the pattern, if you compare the pattern, both are different. And probability for the more number of births in free process is higher than equilibrium birth process, and in the free process, average number of birth as well as average number of surviving children is higher than equilibrium birth process. So this is all about my research paper. Thank you.
Thank you, Professor Tiwari, for a nice presentation and nice mathematical work in the field of demography, particularly in fertility. So now I request to SL Ragendu for the presentation. And SL Ragendu,
Yes, sir.
you are here?
Yes, sir, I'm here.
Okay. So her presentation is on life table analysis of the labor force in India. Is it?
Yes, sir.
Okay. Please go ahead.
Okay, sir.
Ragendu, you have 10 minutes because we are short of time.
Okay, sir.
Okay.
Good afternoon, all. Firstly, I thanking Iasp and other honorable persons for giving me this opportunity. I hereby presenting my paper on life table analysis of working population in India at a glance. We all know population, labor force, and employment are three interrelated factors, and in India, the economy is highly dependent upon production and service sectors, and the labor force made its building block. The economic activity of it and the development of a nation largely depend on the quality and quantity of their labor force. India is witnessing a rapid demographic transition and is entering a phase where approximately 60% of its population is in working age population. And we know that in India, we have won a youngest population even in this aging world. However, it can also turn into a disaster if it is not properly channelized and gainfully employed. Another concern is an unemployment that make my study more relevant. The status of unemployment rate of a nation has increased alarmingly from 5.0 in 2015-16 to 6.1 in 2017 and 18. In this context, a study on work participation rate in India is of greater relevance. The length of economically active life is a good indicator of the economic demographic situation of the nation. The study aims to analyze the workforce in India by constructing working life tables for males and females separately, and thereby analyzing the average length of time people expected to spend in the labor force. To analyze the rural, urban, and state-based variations in working life expectancy also. The information that required for my study was gained from these data, and I take two age-specific data. One is age-specific death rate from the sample registration system report of 2018, and the age-specific participation rate was obtained from the periodic labor force survey of 2018 and 90, and also the a report of technical group on population projection was used for projected population in order to calculating replacement ratio. And the participation rates were obtained for the persons aged 15 years and above, and it was constructed on the assumption that work participation rate within each age level are uniformly distributed, and all the working age population in the age group 0 to 15 is considered to be the same for the age group 15 to 19. As we go to the analysis part, I found some interesting factors about the work participation rates of India in 2018-19, and the work participation rate with the male-female classification are plotted in these graphs. We can view that work participation rate in India in 2018-19 is 47.3, and for male it is 71, and for female it is 23.3. And it is made clear that the gender inequality that exists in India, even in the working population also. Using this participation rate and age-specific death rate, the working life table was constructed, and it gives the working life expectancy and expected years of life of an individual in India. It pay way for calculating the inactive years also. It represents the non-wasting time or non-participating time of every individual. Using the life expectancy and working life expectancy, I constructed working life table for both male and female separately, and their working life expectancies are plotted in this graph. It may be shown that for male it is 39.55 years, and for female it is 13.02 years. We can see that for females it is very low years of life expectancy. Even they have higher years of life expectancy, they have poor working life expectancy is seen. The loss of active years due to mortality, which is more for male, that is clear from this table. And it is very low for male. As age increases, both for male and female, the loss of active years due to mortality increases. This gives information on the mortality pattern that affected the economically active life years of the working population in India. Interpretation on the status of the labor force has been made through the details above, those who enter into the retires from the labor force. Thereby, the studies try to assign the pressure on the labor market represented by the demands of entering workers for jobs in proportion with the loss occurred due to the retirement and death. The entertainment rate, which plots the age-specific rates of net entries into the active status from the inactive stationary population per thousand, and it is in the age group of 25 to 29, it is a higher rate for male, and in case of male it is higher in the age group of 25 to 29, and that for female is 30 to 34. The net retirement rate, which shows the age specific rates of net retires from India in 2018-19 from the active stationary population. And we can see that after age of 60 to 69 age group, there is a gradual increase for both male and female. From these calculations, I made an attempt to calculating the replacement ratio per 100 in India, and it made an index for unemployment also, and it shows how many people are available for filling the vacancies that obtained due to retirement and death. And in India, that is available to 210 people are available for filling the 100 vacant space. This shows a view of unemployment that exists in India in 2018-19. In order to extend my study, I also calculated the current study on the basis of place of residence. I take a rural and urban classification also. The age specific participation rates are plotted in this graph. We can see that for rural, the work participation rate overall is 48.9, which is a slightly higher than the national average, 47.3 that we early see. And that for in case of urban, it is 43.8, which is slightly lower than the national average also. Even in all the portions, the females are shown lower work participation rates than male. And in case of rural, we can know that all of them are participating in agriculture related activities, and they may not need any compulsory retirement. But we can see that in the urban area, the retirement age was most probably can be seen that they were participating in the service sector, and the pension age is 60, and the work participation rate become low after the age of 60 to 60 age group. The expected years of life and working life expectancy are seen for both males and females along with the classification of rural urban areas. The inactive years are more for females than males in both cases. Among them, urban females are spending more years inactively, even with a higher life expectancy. Overall, the details in the tables portray slightly more active years contributed by the rural working population in comparison with the urban. For expanding my study and for an in-depth analysis, I found the work participation rate for each race in state in India. In 2018-19, the state of Himachal Pradesh was high for work participation rate for all age group 15 to 59 and 60 plus. And second highest was for Chhattisgarh, and the elderly participation is more for Haryana. And the lower participation rate is shown by Bihar. But the elderly we can note that the elderly participation is low for Delhi, but here Bihar has 31.3, which is a slightly higher measurement, even with low participation rate for all other age groups. The difference between expected years of life and working life pave way for the study on percentage of inactive years spending by the individual. It is depicted in this table, and we can see that at the age of 80, Bihar has highest percentage of inactive years. Also, we can see we have yearly seen that participation rate in Bihar is very low. And in Himachal Pradesh, in overall all age categories, the percentage of inactive years is low. And this percentage of inactive years is calculated by the construction of working life table for each age state, and for female with the male and female classification. It is depicted in these tables, and we can see that Delhi has the highest percentage of inactive years in all age group, and Himachal Pradesh has a poor percentage of inactive years in the age group of at 40. And at elderly participation is high. We can see that in Uttar Pradesh, that is percentage of inactive years is low for Uttar Pradesh at the age of 16. And in the case of male, and in case of female, Himachal Pradesh has shown a low percentage of inactive years, which shows a higher participation rate of females in Himachal Pradesh, a slightly higher, not more than high. And in Bihar, the percentage of inactive years is very high than other states. I concluded here my concluded. The study found out that the gender differential is in participation rate exists in India even in this 21st century. The results show that female active life in the working sector being less compared with men in India. Female work participation has still become a challenge in the workforce. Age at marriage, marital status, educational attainment, social customs, etc. can make hindrances to female work participation. Even when the higher life expectancy of female, the working life expectancy is poor for females. Also, the low work participation rate and low working life expectancy for the elderly were noticeable one. In the aging scenario of India, the study throw light on need for additional planning in the policy generation and pension schemes for the old age population. The clear picture on the late entry of women in India is got from the net enrollment rate. We can see that the late entry and early withdrawal of female, which results in the low participation rate of female in India. The replacement ratio represents the pressure of labor force by the demands of entering workers for jobs in proportion to the number of jobs being vacated by retirement and death. The values of replacement ratio estimated in the study showed a higher level of unemployment exists in India, irrespective of success. And the status of workforce according to the residential background depicts a slightly higher value of working life expectancy of the rural population of India as compared with the urban. The subnational level of analysis shows there exists considerable variation in the work participation rates and working life expectancy within the regional variations. From an economic perspective, reducing gender gaps in worker participation could substantially boost gross domestic product, and the observations reveal the need for the proper reforms to enhance equal distribution of opportunities and jobs and helps in implementing necessary programs by the government that make equity and development in the nation. I concluded my study with a quote of Sophocles: "Without labor, nothing prospers." Thank you all.
Thank you. Thank you, Rajendu, for nice presentation and nice work. So I invite for next presentation, Vivek. Vivek, you want to present? Vivek, are you hearing me?
Yes, sir, I can hear you. Am I audible?
You are audible. Now you are going to present your presentation.
Sir, could you please allow me to share my screen?
Yes, yes, yes. And you have 10 minutes.
Okay,
Vivek,
sir.
already
Yes, sir.
We are
yes,
late.
sir, I can.
So conclude in 10 minutes.
Yes.
Sir, whether my slides are visible?
Yes, Vivek, it is visible. Go ahead, very fast. Just conclude in 10 minutes.
Yes, sir, I will do that. I can understand, sir. First, very good afternoon, and thank you organizers for this opportunity. As per the title, which is mentioned there, Bayesian estimation of fertility rates under imperfect age reporting. That work is in the collaboration is Professor Dilip Chandanath and Professor S.N. Dwivedi. As we all know that age is one of the important factor that determines various of the demographic and health studies, and its misreporting can lead under or overestimates the characteristic that is determined using incorporation of that. And the same thing has been mentioned in various studies, and in the it is mostly seen in the developing or underdeveloped countries, including India. Some of the studies has also described that how in the situations where age has been misreported, then using different scenarios, different information can be utilized to estimate the exact estimate of the parameter. Now, since my study is more confined with the total marital fertility rate, and as we all know that that is nothing but is a linear function of number of births to married women in each childbearing age group, that is 15 to 19 years. Under the assumption that the TMFR is unknown but a fixed quantity, then, and one additional assumption that all the reported age of the mothers are perfectly captured, then entire characterization, derivation, or estimation were well equipped and sufficient enough to describe that situation. But that is also true that a TMFR is not a fixed quantity. That is more often is a random quantity. If we will consider this as a random quantity because that is generated through the responses, then in that case, to capture that randomness, we need some prior distribution, and that prior can be updated using the methodology of Bayesian paradigm. If we look after the existing literatures that consider TMFR as a random quantity, and they have characterized the pattern and the estimation procedure, then we will not get sufficient literatures. Considering that things in my mind, I have considered the objective of my work as to utilize the Bayesian paradigm to estimate the TMFR and generalize for situation when age is misreported, which is very much often and can be observed in India situation. To do so, we need a prior distribution also, which is very much suitable for the structure and the definition of the TMFR. Keeping all this in mind, I defined some of the terminologies that I have used. If X is denoted as a binary response, which says that while covering the questions that a mother...
Vivek, please change your slide.
Sir, that is changing.
No. Yes, now it is changed.
Okay, sir. Then a question there, then a binary response can be generated whether the mother has experienced a birth in the duration of the study or not. One more thing that was captured during the total marital fertility rate, what is that age in which that birth has experienced? If I consider C is the number of non-overlapping age groups, usually we consider as 15 to 19, 19 to 20, then 20 to 24, and 25 to 28, similarly 44 to 49. And NA is the number of women in the 8th age group. Here we have assumed that because I have considered the National Family Health Survey data for the third stage, there the number of twin cases is quite less. Therefore, I have assumed that no multiple births has been occurred to the same woman in that particular year. If I consider this as a binary response, whether the mother has experienced birth in that study period or not, then that is nothing but is a Bernoulli trial, where PA denotes the probability of occurrence of a birth or experience of a birth in that particular age group A. If I consider that as a random quantity, then that PMF is nothing but the distribution of age-specific marital fertility rate. If I accumulate all the birth that has been experienced by a group of mother in that particular age group, that is nothing but is a binomial distribution. That can be easily understood. Binomial with a number of females in that age group NA with probability of experiencing a birth is that PA. Now just go with a simple maximum likelihood estimation procedure. Then the MLE of PA is nothing but number of births in that particular age group by total number of women in that age group. If I add using the Fisher's information criteria to derive our variability, then that is nothing but the PA into 1 minus PA by N. That is very renowned. Now, question changes here that if I consider in a particular age group, a woman is experiencing with certain estimated probability in a particular age group, then what is the accumulated one? Then as per the definition of TMFR, that is nothing but a linear combination of PA in alpha 8 times. Alpha is a commodity component which I am assuming as a fixed one, because in a standard literature we just multiply it by 5 to get a TMFR. I am considering as a symbol because as per the study or the requirement one can generalize and utilize that equations. If this is so, where all the classes are independent, then the mean and variance will be of this form. That is quite simple and can be understood. Now the question arises, when we consider this as a random variable and that each and every age group is related through a linear function, then the independence assumption is not very true, because TMFR says that over the period of childbearing age, what is the expected number of birth experienced by a woman if they follow the same pattern? Then each and every age group is independent for a particular experiences. But while talking about TMFR, that is nothing but is a linear combination of each and every independent age group's experience. In that regard, we have derived a prior using the Fisher's information criteria, which is of this form. I am not going to in depth about the theorem, how it is derived. That is, for the time being, I am assuming this is the theorem that has been giving us a prior distribution, which is not standardly available in the literature. If it is our prior, then based on the available information, our posterior will be of likelihood times of prior, and the explicit, non-explicit form is visible. Since the form is not standard and is explicit, therefore we have to opt the simulation procedure. That is called Markov chain Monte Carlo simulation. What it will add? This will gives us a linear estimates of the function for which we are interested, where each and every age interval is independent and has a random quantity and quantity of experience. The mean and variance are written there. Using the same methodology, we can also derive the confidence and the critical interval as per the maximum likelihood estimates and for the Bayesian estimates. Now, what is the thing here? There is a problem with that under the assumption that if the age is properly reported, then whatever the methodology we have discussed is sufficient enough. But we all know that, and it is also mentioned by while different studies comparing SRS versus NFHS with census also. Age is not properly captured while collection of the data. We generalizing these things for the maximum likelihood as well as the Bayesian setup, why we should prefer and where we should prefer so. If A is the age of the interval of a woman which was reported by that during the survey, and A star its true age, and the same A and A star belongs the same age interval 15 to 49 years, then the probability that a child born to a married woman 8th age reported age group will be formulated as PA star is nothing but is a linear combination of pi A into PA. PA is the probability which they have discussed or presented while collection of the data, and pi A is the probability that that age is wrongly reported. Then the woman will, rather than be a member of 8th age, will be a member of A star age, where PA star is the probability that a child born to a married woman in her true age interval A star, which C either missed or misreported or not captured or properly explained what is the exact age. Then pi is nothing but is a probability of shifting from the true age A star to A due to the misreporting. If we structurize the entire thing in a matrix form, that is nothing but P star is nothing but the pi matrix of a P. Then let's see what is the characteristic of the pi matrix. Since this is a probability matrix of shifting from A star age to the A, that is the true age to the another age group, if you add in the same interval, then that is nothing but following the equation that if you add for a particular A star or 8th age group, which they have reported, the entire probability will be 1. If it is so, and we are assuming the linear constant that we have considered for linear function is throughout the interval is fixed, that is not changing because of that misreporting, that is alpha A is not equals to alpha A star, then the estimate of TMFR under maximum likelihood setup will be same. The proof is written there. That is very much easily proved based on the first line which I have mentioned about the pi, that is a transition matrix that can be equated. One thing which we can see, if we have misreported the age, then our maximum likelihood estimates is not capable enough to incorporate that misreporting. That will always keep in fixed, that is mentioned in the equation 3.3. Means xi p star will be equals to xi p, which is not the perfect situation. We need something that incorporates our misreporting. We are going to generalize this one for the Bayes estimate. As we have defined for the pi, for the true age reported linear function of the total marital fertility rate, if we just replace p with pa star, that is the exact age which is already assumed to be a random variable, maintaining that equation which I have explained in the equation 3.2, then our posterior will be of this form in the equation 3.6. Sir, is that visible? Hello?
Yes, it is visible. But go fast.
Okay, sir. Now we have the maximum likelihood estimate as well the prior posterior distribution with revised form for the misreporting situations also. Now we are going to cross check whether the obtained theory is capable enough to address this situation. To realization of this situation, we have used the National Family Health Survey 3. The major reason for using that one to cross check the feasibility of the model, some of the important information are stored there. In the NFHS4, some of the information are missing. Rather than going to the entire country, we have chosen only the EAG states, that is empowered action group state, because they reported comparatively highest fertility rates than that of other parts of the country. Here we have excluded the age of 45 to 49 because the corresponding to that age, the amount of information of the individuals is quite less. That may misleads our estimates. Here we have collected the information whether you have experiences any birth in the preceding 1 year of the survey. This is time here is only 1 year. Now comparison. Since we know that maximum likelihood estimates and the Bayesian follows different methods of estimation, one talk about the data and another talk about the parameters. To make it comparable, we have used the mean square error, which is quite similar to the risk that is defined under the square error loss function. The risk function are given below under the Bayesian setup as well as the maximum likelihood setup. To compare that, the feasibility, who is reducing more error and have the capturing capacity, we are defining the terminology that is called relative risk of the Bayes estimates using a ratio which is defined in the equation 4.3. Under the assumption that the age misreporting, that estimation of TMFR under ML and Bayes technique is possible only when the pi matrix is unknown. In order to incorporate that misreporting structure, we must have that pi matrix. If we are missing that pi matrix, then we have to assume that whatever the person has reported is perfect enough. That is not a very practical situation. To build that pi matrix, I have suggested two different methods. First is called perceptual based method. We can start with the various literature has there said. Started with that, we can assume 5% individuals have misreported or 10% of the individuals have misreported, but we don't know who are they and where they have misreported. And another says that we can use, as I have in the first slide I have said, you can use other information to capture that one and recalculate that matrix, how one age is misreported in the another form. These two methods is going to elaborated by me. Now let's start. That is pi rho is the probability that a person is perfectly reported the age. For the time being, I assume 100%. Then the delta denotes the misleading or the misreporting. Then delta is nothing but 1 minus rho by s minus 1. Means I say that 5% is distributed to the another intervals. And the rho denotes the diagonal elements where the individual perfectly reported their age. If I assume rho is equal to 95%, then the 5% of the error in the misreporting will be distributed throughout the row. This is the entire structure. For the demonstration, I have given that if rho is equal to 1, then the delta will be 0. In that situation, the age is perfectly and accurately reported. And the misreporting, in the misreporting case, the rho is 95%, then delta will be distributed to 5%. And if it is 90%, then 10% will be distributed to the remaining age intervals. That is quite theoretical, we can do. And in empirical setup, we have to cross check also whether that is the perfect scenario or not. And if information permits, then we can do that. To do so, we formulated a
Vivek,
structure. Yes,
Mr.
sir?
Vivek, your presentation is very interesting, but we have to expedite it a bit. Thank you.
Okay, sir. Sir, I am just quite close to the end. That will not take too much time, sir. The thing is that a person has reported its age A in a perfect way can be differentiated with the wrong age. I have used 4 different information. What is it? Age of first marriage, duration of gauna or the return marriage if performed, marriage to first birth, and the age of the first birth child. If we subtract it and they have reported perfectly, then AR minus that adjustment will be 0. And if it is not, then we will repeat for each and every individual. That will help us to build a matrix. This is of this form using the NFHS data 3 that was generated through the data. Now we have 2 different structure. One is simulated based, another is empirical based. Now this is the result, sir. That says that under the maximum likelihood setup, theory says that that is not going to impact on your misreporting. You can see each and every time the result is same, whereas the base is keep on changing. We can see, and the relative risk, we can say, that is always found to be quite less in case of base than that of a maximum likelihood estimates. We have considered 3 different situations where 100% perfectly reported, 95% time perfectly reported, and 90% of the information is perfectly age reported. We have also plotted the graph under the maximum likelihood setup that is not showing a significant change. Whereas if we will look after the Bayesian estimates pattern, then we can see with the change in the perception about the wrong reporting, the curve is changing. We can say the entire behavior of the pattern is keep on changing. Now, if you see about the empirical structure that we have derived in the earlier slide, then here also we can see the Bayesian are performing well than that of maximum likelihood estimate. That is least relevant to capture the variability. If we accumulate the empirical comparison with the empirical derived matrix with the classical and Bayes approach, then we can see the maximum likelihood estimate is quite smooth. That is not saying I am going to be deviated because of the misreporting. Whereas the Bayesians are saying that will certainly impact on the age interval because that will change the identity and the position of the individual because of the misreporting. Now, as a discussion part, from the table, we can show that the Bayesian estimate of the TMFR and the both perfect and imperfect age reporting have found to be more precise, that is with less risk than those ML estimates. 95% of interval are quite less. And among the ML and Bayes estimate generated using the empirical estimated transition probabilities, pi-e, using the data in the table 5.2, results also reveals that Bayes estimates are capable enough to maintain that diversity which has been occurred because of the misreporting. From that, I can conclude one thing, that the results show that the suggested Bayesian estimation of the TMFR leads to population parameter more closely than that of maximum likelihood state estimators and are much more precise than maximum likelihood estimate, even in the imperfect scenarios. Even with the inaccuracy in the age reporting, the Bayesian techniques have found more promising for estimating TMFR, and often Bayes estimates are more precise, reliable than those which is obtained as compared to the maximum likelihood estimates. At the end, I just want to acknowledge the organizer for giving that opportunity and accepting that work that gives me a platform where I can disseminate my learning. In completion of that work, I want to thank my respected collaborators, Professor Dilip Chandana sir, who is the Vice Chancellor of Assam University, Professor S.N. Dwivedi sir, Professor, Department of Statistics, Biostatistics, AIIMS, New Delhi. These are some of the references. With this, sir, I am concluding. Thank you.
Thank you, Vivek, for nice presentation, nice technical presentation, I think. Some of the peoples can understand this technical issues, Bayesian paradigm technologies. But the time demands this type of analysis because all the data have some error. So there is some concept, some prior can be introduced to get a better result. Okay.
Thank you, sir. Thank you, sir.
Now I would like to Krishnamurthy sir. Would you like to present? Murthy sir, would you like to present live? Or
may I come in, sir? We have rectified the issue. Can we start the video presentation of Dr. Murthy?
But after the time, after the 5 minutes, 6 minutes, because we have no time. We are already 10 minutes more. So please, ICS peoples, start the presentation of P. Krishnamurthy, sir. Audio is not on, I think.
Mr. Venu, audio is not coming.
Venu, please
Audio
check it.
Audio is not there.
Understanding the model. Thank you, Chairperson. Thank you.
No, it is from start. It is from start. Go ahead. After 8 minutes, after 8 minutes, we start.
Thank you, Chairperson. Thank you, Iasp, for giving this opportunity.
Can I do forward?
Yes, forward.
I am presenting my paper on
8 minutes. You should forward 8 minutes.
8 minutes.
Yeah.
Yes.
Yes.
Coefficients A, B, C of the regression model observed to be significant by means of t statistics more than 2 point or so. Even though R square is low, as the regression coefficients are significant, we can use these models for further analysis. So this is the reference table we have prepared based on the regression models we have provided there. So for convenience, we have mentioned here up to 35 median of total population. So life expectancy at each of the age is given here. So given the any median age of total population shown here, or for any other median age, we can easily collect the data from this table without much calculations, without any calculations. So this is how the life expectancy at age X corresponding to different median age of total population given in the previous table. These are model values. So this is how the observed and fitted values can be seen for in case of India and Gujarat. Similar way, Kerala and Uttar Pradesh. So fitted and observed values, the estimated and observed life expectancy at age X values, we can see are very close to each other, telling that it's good fit is there. So these are the estimated values of the life expectancy at age X for West Bengal based on the median age of the total population of each of the districts in West Bengal. Similar way, these are the life expectancy at age X for Uttar Pradesh districts based on median age of total population reported in the 2011 census. So, to summarize, there is a perfect fit between the observed and estimated values, so indicating the fact that the present model may provide plausible estimates of life expectancy at age X from the given median age of total population. Estimated values for districts of West Bengal and Uttar Pradesh provided in two slides here seems to be plausible estimates and useful for further analysis. And we can also prepare a full life table based on these values. To conclude, an attempt has been made in the present study to develop a methodology for estimating the life expectancy at age X from the given information on the median age of total population. And an attempt has also been made to provide district level life expectancy at age X for the year 2011 using the median age of the median age of total population computed from Iasp data of the 2011 census of districts in India. So result shows very interesting. This method may further be used once the median age of total population from other sources like National Family Health Survey. So we recommend that there is a need for us to improve the methodology and also there is a need for us to get similar models taking state level data of each state. Thank you so much.
Thank you, sir, for nice presentation. And your second presentation is there.
Benu,
some
please play
indirect
the second video.
Yes, it is also there is a video. You have video.
Yes, so there's the same another video of
Okay.
Dr. Murthy.
Okay, how much time of this video?
Thanks to the Iasp for giving the
So keep
opportunity.
fast, I think. Goel sir. Goel sir.
The topic of my presentation is
Sir,
indirect
can I forward?
estimation of fertility and
Yes,
mortality
Vijesh.
indicated
Yes. Introduction can forward. Sir, can we forward the introduction of this video?
Please, because we got little time now.
Okay, forward till the methodology.
in India.
5-6 minutes forward.
In the year 2007.
But dear Arpit, this video is very blurred.
Yes, sir. Actually, the same quality we have received, sir, from the sir.
Okay, but Murthy sir is available here.
But no, they are not able to play the presentation.
Okay, so forward it. Go up to the conclusion.
I think last slide is okay.
If we cannot see, if we are not unable to see, then we can see listen only the conclusion. So Arpit, go to the conclusion. The last slide, last 2-3 slides.
Our Iasp data, census.
Arpit, please forward.
Conclusion.
Yes.
Right.
Increase the volume. Increase the volume of Murthy sir.
Needs fertility, mortality for countries like Ethiopia and Africa.
Okay.
Thank you.
Thank you for presentation. Now I would like to invite audience for question. If audience have any question to any presenters, then they can ask. And the presenters write the question, and one by one they come to give the answer of the audience. Okay. Any question? Any question for any presenters?
Sir, can I?
Yes. Dr. Tiwari, you want to ask?
I have some doubts with Dr. Vivek Verma.
Okay.
Dr. Vivek, have you compared this TMFR estimated by Bayesian approach and classical approach? And second point, if you are estimating TMFR for 15 to 49, then you have to see the role of age. What is the role of age here? And then how you are going to check whether these data has some problem, means that this misreporting is there or something. Can you give some explanation?
Vivek,
sir, yes, sir. May I answer now, or we'll take the all question thereafter?
No, you may answer. I think there is no question.
Okay. The thing is that we have compared the TMFR for the maximum likelihood as well as the base. There is a column theta is there that comparing the relativeness of the estimate which has been obtained. And regarding that age, you have asked that while calculating the 15 to 49, I have shown you an empirical table also, sir, which is generated through the same NFHS data, which is showing that off diagonal element is changing. That is not 100%. Somewhere that is 93%. Somewhere it is 80% of, up to 80% also. Means that the females have reported the correct age in 80% cases only. The 20% or 22% or 12%, 13%, there is a deviation. Either above age or the below age is reported. Anything else?
Do you agree, Professor Tiwari?
Yes, okay.
Okay. Okay, thank you, Vivek. Thank you, Professor Tiwari. I think there is no question for any presentation. So we should conclude, sir. Well, sir, we should conclude the session.
Yeah, this is, can I say something now?
Yes, sir. Yes, sir.
It is very interesting session with several very technical papers. And I had a chance to revise my technical demography after a while. I appreciate the efforts made by the presenters and digging into something very interesting issues, age misreporting, and then there's a life table method using employment. And Ragendu has talked about something very interesting. The female work participation is so low compared to male. And it requires some policy intervention to take it further. And Tiwari Saab, definitely your free distribution model, I appreciate and enjoyed listening to you. Vivek, your detailed investigation has given me some thought that how do we look into the life table use in different ways. Thank you very much to all the speakers. I'm sorry for some disturbance in presentation initially due to some technical issues, but it happens sometime when you're doing something online. Thank you and keep it up. Thank you very much. Brijesh, over to you.
Thank you, sir. Thank you for nice conducting this program. Due to this technical issue, we face always this type of problems. So no issue is there. And I think we have good presentations. Especially, I thanks Ragendu. She is doing MSc and her presentation is very nice. And Professor Tiwari and Dr. Vivek are giving good idea to the demographers to do some mathematicals analysis of the fertility phenomenon, whatever mortality or any other phenomenon. This is the need of, because these days we don't have any mathematical papers. Even people are saying some substantial paper, okay, there is a very technical problem can consider. No, mathematics, there is a lack of mathematical derivation or mathematical analysis in the demography these days. So my submission is to the presenters, please do something mathematical to analyze the data, because we have ample amount of data. We have after every 3-year NFHS. So I think data should be analyzed through the mathematical techniques. And thank you to all presenters and chairman sir for nice conducting this program. Thank you to all.
Thank you very much, sir. Thank you.
Thank you so much.
Jitender ji is here.
Thank you. I'm Anil.
Okay.
So this session was very interesting, and Professor R.S. Goel sir and Brijesh Singh sir both managed the session very well. So on behalf of IASP, I thank Professor Goel and Professor Singh for conducting the session nicely, and also we thank all the paper presenters for nice presentations, and we apologize for the technical issues that has emerged, which is part of all these webinars and online meetings. So thank you all. Our next session starts at 2:30 at Hall A. This is a plenary session again, PRC related session, and there is a poster session which is happening after a few minutes in Hall C. So all of you are requested to join for these two sessions. Thank you.
Thank you. Thank you, Anil.
Sir, please start the session if the chairpersons came into the hall.
Okay, okay, sir. Okay, sir.
Oh.
Hello.
Yes, sir.
Okay. So, Dr. Jayanta Kumar Basu is there. Basu sir. And the second judge is Ravi Prakash. And third is Dr. Sushanta Banerjee. Basu sir, hello.
Hello.
Basu sir, are you there, no?
I am here, Jitendra ji.
Okay, okay, sir. Okay, sir. I am calling to others judge. So our second judge, Ravi Prakash, is going to join soon. He is trying to join. Just wait for 2 minutes. Shall we start? Basu sir.
Please
Shall we
start.
start? Yeah, Ravi Prakash is going to join.
Start कीजिए.
Okay, okay. So good afternoon to all presenter and chair, co-chairs, and also ICS Global team. So on behalf of the Iasp, I welcome to all. And for today presentation, the result will be declared tomorrow in validatory session. And today poster presentation is going to judge by Dr. Jayanta Kumar Basu and Dr. Ravi Prakash and Sushanta Banerjee. Ravi Prakash is already joined. So welcome, sir.
Yep. Thank you, Dr. Jitendra. Sorry for being late.
Okay, okay. So we are going to just start.
Okay.
And in this year we will also have facility to judges can interaction with the presenter. So all presenter is here. So presenter will present one by one poster, and if you judges can any problems, any question they can ask and interact with the presenter. So over to you, Basu sir and Ravi Prakash ji.
Yes, please.
So Dr. Ravi, you have an agenda?
It seems that I don't have the updated copy, but maybe if Dr. Jayant has, so he can start.
So,
Otherwise,
Otherwise,
Shankar.
ICS Global team will help you.
Yeah, Dr. Rashtriy Shankar, you can show your poster and you have 5 minutes to explain your poster, right?
Okay, sir. Okay, sir. Shall I share the poster, sir?
Sure.
Yeah.
Yes, sir.
Hello.
Sir, is my poster visible?
no, not yet.
Not yet visible.
Am I audible, sir?
You are audible.
Yes, sir. So, sir, my title was on a study on trends in substance use and abuse in the time of COVID-19 pandemic among the general population globally. We studied continent-wise and we conducted a systematic review and we attempted to do a meta-analysis as well. So, in the introduction part, sir, we have in general seen even before the pandemic that the terms substance use and abuse have been used interchangeably. And since the pandemic had started, the rise of substance use and
Dr.
abuse
Rashi,
had
sorry
happened.
to interrupt you, but you can share the screen again. Your poster is not coming.
Okay, sir.
Only the folder is coming.
Just 1 second, sir. Sir, is it visible now?
Yes, it has come now.
Okay, sir.
Please continue.
Yes, sir. So, sir, these terms have always been used interchangeably, and as the pandemic, which had come as an unwanted guest, we all saw that there was a substantial mental health effect which was happening in the population because of various reasons. It could be due to anxiety or due to not knowing that what the pandemic will bring along with it, and many people faced financial crunches, and also health-wise they were affected a lot. So, to cope with such things, people, the ones who were vulnerable or those who were already a chronic substance abuse users, were leaning forward using substances in order to escape or cope from the situation. So, keeping that in mind, we wanted to conduct a study which was based on substance use and abuse. And so, as we can see in the methodology part, we conducted a qualitative literature search published since the COVID-19 pandemic had started, and the studies were published in December 2019 onwards. And in the databases of PubMed and Google Scholar. So we basically chose all the cross-sectional studies and longitudinal study designs. Based on the cross-sectional study designs, we calculated and we did the analysis past, and based on the longitudinal studies which we had retrieved, we showed case studies on that, which was usually done in places of Europe and in US. So and the criteria that we had chosen, the inclusion exclusion criteria, sir, that we had chosen, we kept it above 15 years because we thought that ideally from the start of teenagers, the substance use has been seen worldwide. And we also reported about different substances used and abused during the COVID-19 pandemic. And we conducted a cross-sectional and longitudinal designs, like I mentioned, were included. So the exclusion criteria which we kept were that studies on COVID positive patients. We didn't choose the COVID positive patients. We just saw in general populations who were not COVID positive. And obviously the age was 15 years and below. We excluded that. And a review-based and closed access studies were also excluded. And apart from English language, all other studies were excluded along with the duplicated studies. And in the research, the result part, we can see that a sample of 1,21,118 were overall observed. Of the total sample, 45.89 were males and 54.14% were females. And in the others comprises of 1.28%. So based on this, we saw that total 26 types of substances had been used, starting from cigarette alike, rebuildable pod module till tobacco, vape. So basically, all kinds of substances that we have heard of, almost everything had been observed in the study that people had used during the pandemic. And based on this, we can see that.
Hello.
Hello, am I audible, sir?
Now you are audible. Please.
Yes, sir. And so based on this, we also wanted to see that how much the substances use has been either increased or decreased, or it had been remained similar in the phase of the COVID-19 pandemic. So we saw that, for example, tobacco was increased by a mean percentage of 12.42, and it had decreased by 5.52, and amongst 21.77% of population, there had been no change. So likewise, in 13 substances, we saw that there were considerable differences in the use, apart from the 26 overall substances which we had observed. Also, we focused on the character, the Hello, sir.
Yes, yes, continue.
Yes, sir. Also, sir, we wanted to see that what percentage of individuals had attempted to quit cigarettes. The reason we chose cigarettes because, sir, this was the only wide reported observation in all the papers that we had retrieved from the databases. So we saw that around 34.44% had attempted to quit cigarettes, and 3.63% were successful in quitting cigarettes during the time of pandemic. And we also focused on the social characteristics, like the marital status of individuals, locality of individuals, uh, also the occupational level of individuals and educational levels of individuals. And based on this, we concluded that the combined efforts from local and global stakeholders will definitely lead to an impact in curbing the issue of substance use and abuse. And there has been a substantial increase in the amount of use of substances during the pandemic. And I feel that more based on the study which we have done, sir, the efforts which we have been putting forward before the pre-pandemic levels had to be increased more, because the mental health effect has aggravated double folds in the terms of pandemics, and likewise it has also had an effect on the substance use and abuse patterns of the individuals. Thank you, sir.
Thank you. Can you just briefly tell what combined efforts from the local and global stakeholder you are expecting?
Sir, in terms of, we have to raise awareness about the substance use and abuse. We need to make it clear that there are already individuals who are suffering from this issue, and people usually come, the aspect of substance use abuse comes with the taboo. So we have to make sure that people understand that there is a real problem which is happening in individuals who are addicted. We need to make sure there is targeted efforts which is directed towards these specified or high risk groups.
Okay. So basically, the awareness generation effort you are thinking.
Sorry, sir.
Basically, you are thinking of awareness generation effort.
Awareness effort also, sir, information dissemination, it's of utmost importance, because in pandemic also we saw that there was a misinformation spreading. There was a lot of misinformation.
Good afternoon.
Okay, okay.
Sir.
Okay, that's fine.
Also, sir, we need to understand that in a community wise, and we have to understand that what works best, which is in terms of considering different regions worldwide, one solution cannot be put forward for every other region. So we need to understand what works best and how they can combinedly accept the protocols that have been laid forward, so that they can come forward and also talk about it and seek help about it.
Okay.
Dr. Rashi, Ravi here. Just a couple of quick comments. So one is that thank you for this presentation, but I was just wondering, like, some of the results which you spoke, like in terms of changes or the trends in the substance use,
yes,
I could not see them here. Probably that was analyzed separately. So that was one thing I wanted to see. Like there is one thing which I am just getting here is that percentage of individuals who quit the cigarette use, during this period. But I'm just thinking like combining this global evidence and together and then just saying that this is the trend or this much has been quit. I'm not sure how much it will have an implication because again the context and the geographies are different.
Yes,
So
sir.
so that was one thing. The second is that also you have some comments on the linking it with the mental health status and
Yes, sir.
do you have or have you got any evidence from the literature which have shown an association and again how it changed because you have mentioned about that quite a number of times in the rationale of this study as well as in your conclusion. Thank you.
Sir, in terms of the use of the word mental health, it was basically the literature which we had retrieved from the PubMed and Google Scholar. We saw that there was a mention of mental health aspect in many individuals, which had forced people to use. But to study that if there is actually an association, we were not able to do that, sir, because we attempted to do meta-analysis, but due to a vast heterogeneity, we were not able to go forward with the meta-analysis part. So that was one of the limitations.
Okay. Nothing more from my side. Thank you.
Thank you,
Thank
sir.
you. Thank you so much.
Thank you, sir. Thank you very much.
Can we have Dr. Rajkumari? Can we have Dr. Rajkumari? Nilesh J. Yadav. Can we have Taufik Rahman?
Hello, yeah, I'm here.
Yeah, so you can present your poster. You have 5 minutes, right?
Okay, thank you. I'm sharing my screen.
Yeah, please.
Make a slideshow. Make a slideshow. Don't zoom it.
No, this is a poster, no?
Yeah, in slideshow you can still show the full screen. Just try once the slideshow.
Okay.
First do enable editing. Then you just make it a slideshow.
Wait a second. Okay.
Okay, it's nice.
Yeah, the problem like the slideshow, we can't move like. Okay, good afternoon, everyone. This is my poster. Socio-economic determinants of healthy aging in India, evidence from longitudinal aging study in India. As we know,
Yeah.
population aging is there. Hello, I'm visible. Sorry, I'm audible.
Yes, you are audible. Please go ahead.
Okay, introduction. Population age is an inevitable and demographic reality associated with the improvement in health and medical care. So the percentage of elderly in India has been rapidly increasing in recent years, and the trend is likely to persist in the coming decade also. The share of the population of over the age of 60 in India is projected to increase to 8% from 2015 to 90% in 2015.
Okay.
So there are many methods and things to quantify the concept of aging. So the new one is the healthy aging. Actually, the recently introduced by WHO, healthy aging. Before that was active aging. So WHO defined healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age.
functional ability combine the individual's intrinsic capacity, the environment a person lives in, and how people interact with their environment. So WHO declared 2021 to 2030 as a decade of healthy aging. So in the light of this decade, I'm trying to create a comprehensive measure of healthy aging for India as per the WHO framework, and to find out the level of healthy aging across Indian state and socio-economic and demographic groups, and to find out the relevant determinants of healthy aging in India. That was my objectives of study. Okay. Then methodology, data. The analysis performed based on the longitudinal age study in India, conducted jointly by IAPS. So the individual without biomarker data were excluded from the study. A biomarker data such as body mass index, gait speed, grip strength, etc. were crucial for the domains of measuring healthy aging. So next one is the measurement of healthy aging. Actually, there is no consensus in the measurement of healthy aging. Scholars were using different combinations of variables and various methods for measuring healthy aging for different countries. So the present study selected all relevant domains and variables available in LASI, which are shortlisted by WHO experts. So I'm created a healthy aging score, which is constructed with the 53 variables, which comes the variable broad domains of functional ability, intrinsic capacity, and the subdomains of cognitive, psychological, physical, sensory, vitality, mobility, maintaining the relationship and a contribution to society. So these are the subdomains. Total 53 variables taken into account. The study variables were categorized into binary variable expressing the presence or absence of difficulty. The variable with the discrete value were dichotomized as the first quartile indicating the presence of difficulty and above the first quartile as the presence or absence of difficulty. The score of each individual, the sum of the value of variable was rescaled into a value between 0 to 100 and took it as a healthy aging score. And the higher score indicated the better health. And descriptive statistics used for mean healthy aging score and different socioeconomic group. And multiple linear regression we used to find out the relevant determinants of healthy aging in India. So this is the result. The mean healthy aging score of states and union territories of India show that Nagaland has the highest healthy aging score, while Telangana has the least healthy aging score. Most of the northeast states show better healthy aging score. So tables are the mean healthy aging score across socioeconomic group. And the mean healthy aging score of India is 72.57. And there is a significant difference in mean healthy aging score across state and different socioeconomic group in India. As I said, Nagaland is the highest healthy aging score, while Telangana is the least. An individual residing in rural area is lower than the urban area. As we know that is a healthy aging, so as age increases, the healthy aging score is also decreasing. And among the social different, the females show low healthy aging score compared to men. And the mean health aging score from poorest to richest and lower to higher education level also show an upward trend. Richest people show better health aging score than the poorest people. The married status show that currently married or living together have higher score than separate individual or unmarried individual. Among the major religious group, Christians have the highest score, followed by Hindu and Muslims. Regarding the multiple linear regression, younger male living in urban areas, high monthly per capita expenditure, being married or living together, having higher education and regular physical exercise was significantly associated with the higher healthy aging score. In contrast, the habit of drinking, having chronic diseases, that's also significantly associated with the low healthy aging score. The caste group or social group was not significant as. So the conclusion is that the study also confirmed that another studies also the people who have low socioeconomic standard having low health status, but some contrasting result is that scheduled tribes show higher healthy aging score compared to other socioeconomic group. That's one contrastive result. So the conclusion is that the physical exercise, socioeconomic disability backwardness are the major hindrance to achieving healthy aging score. So there should be government and public focus towards this backward group, and these methods like introducing more social welfare scheme for the aged people to develop but to achieve the healthy aging for the 2030 for India. Thank you. Hello.
Hello. Thank
Okay.
you.
Thank you.
Respected judges, if you have any kind of questions, you can ask them. Otherwise, we can move it.
I have just one clarification. Thank you, Dr. Tohik. Just one thing, you also mentioned is that there has been various literatures which have kind of still debating about what should be the healthy aging score. So the indicators, like 53 indicators that you took, is in any way comparable to any existing evidence? And if so, then how is India doing compared to the setting where this was applied or tested?
Actually, the 53 variable I took from the WHO published the baseline healthy aging for 2020. They have shortlisted the around 60 variable. From that, I took the available variable from LASI. So, what was the second question?
No, I was still if these variables are not kind of homogeneous across the existing findings or existing literature, like you said that there are 63 and LASI has 53, right? But
yeah, LASI has 53.
Yeah, but is there any way of comparing that India healthy aging score with any other country's data?
Yeah, actually, it is actually the concept is very, very recent one. The LASI data is only came in last 6 months only, so studies only coming. So these variable only available in LASI data only. In international level, many for ELSA, English longitudinal study, and all other LASI is comparable with all these longitudinal studies with like Korea, China, everything is comparable. Now studies only coming.
Okay. And just one last point is that you said that government should have schemes, and welfare schemes. So, how far do you think it is feasible for government to have different scheme for such, specified targeted group? Because generally what I see, your predictors are related to, healthy environment, their living status, and some of the healthcare, practices and other thing, which in a way the government will be doing a kind of such a scheme which will be applicable to most of, or the catering to the most of the population in the country. So how feasible it will be, from these studies recommending government, especially so early, that you should have a welfare schemes?
Yeah, actually, I mean, health aging, especially on all the people are backward, people are facing more, bad health compared to rich group. So more welfare scheme to this targeted focusing group, that will be improved. And on other thing is that especially the healthy behavior, like avoiding smoking, exercise, that kind of things are very significant role in determining healthy aging. And especially this from the other concept of aging, like active aging and other different, this is focused mainly on health behavior actually. So in India also, government knows not initiate that kind of healthy behavior among the old age people, only giving this social welfare scheme. In that way, if the government planning like a healthy village, like health friendly towns, that kind of concept also put forward in WHO for the fostering healthy aging in India, for healthy aging all. So in that way, if government move, then that definitely that will improve the health aging.
Okay, thank you very much.
Thank you. I have no question.
Okay.
Can we have Dr. Akansha Pal? Can
Yes,
we have
sir.
Dr.
Yes, sir.
Akansha Pal?
Yes, sir. I'm here.
Yeah, please present your poster. You
Yes.
have 5 minutes. Okay.
please share your screen.
Yes, sir. So is it visible?
No, not yet.
So now is it visible?
Yes, 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 it is visible. Yes, please tell.
Good afternoon, everyone present here. So my topic is the psychological distress among COVID-19 infected survivors globally, a systematic review. So, like we have seen once with the spread of COVID-19 in the community, there have been a lot of studies which have been published, which were done on healthcare professionals about how they were overworked and what is their mental status. But not a lot of studies were published which focused on patients who were affected with COVID-19, their mental health status. So it like with this review, it is an effort to know the mental health status among COVID-19 affected individuals. So aims and objectives were to have a deeper insight into the mental status of COVID-19 affected persons and identify gaps to scale up further studies for enhancing mental well-being among COVID-19 patients. So an extensive search for the available literature was done on the electronic databases like Scopus, PubMed, Google Scholar, which were published from December 2019 to February 2021. Inclusion and exclusion criteria was set. The inclusion criteria was the public, like articles should be like between the time frame period which we mentioned, and it should be full text articles, and target population was COVID-19 positive patients, and studies from every possible region was included. Exclusion criteria was like earlier conducted reviews. We did not include earlier conducted reviews or where we did not get appropriate data. We excluded those articles, and articles written in language other than English were also excluded. Also, articles for which we did not find full text available were also excluded from our final included articles. So the results for each search string were sorted by relevance as much as possible for relevance to our objectives, and only articles giving relevant information and which were fulfilling to our objective were selected, and key characteristics were drawn out from each article. So we thematically like segregated our we thematically segregated our paper, in which we concluded our findings in a thematic order, like mental health status among patients, which were like it was divided into depression, anxiety, and other mental health status, other mental health factors. So it was done thematically. So in our findings, here you can see the three graphs which I have included. The first graph is comparison of depression reported in studies. It was the first sub-theme of our results. So it is seen that The lowest level of depression which was seen in studies were 11.9%, and the highest level which was seen was 97.2%. The lowest level was seen in Italy, and highest level of depression among patients were reported in Iran. In second graph, we can see the comparison of anxiety levels in the studies, where the lowest level we can see here is 0%, 0%, and the highest level was 100%. The highest was again reported by Iran. The mean level of anxiety reported in this review was 35.14%. And we also saw that rate of anxiety was substantially higher among women than in men. But this was this is opposite in case of India, where depression and anxiety both were reported more in males than females. Also, the anxiety and depression we saw them increase in older age group and the people who were who had longer hospitalization period, and patients who were married. Last graph shows comparison of sleep disturbances reported by studies. The mean level of effect to sleep quality or insomnia reported by studies included in the review was 57.08%. The highest level was reported, highest level which was reported was 84.7%, and lowest level was 41.3%. And it was mostly present in married females and patients with which had longer period of hospitalization. Other mental health factors which were seen among all the patients were PTSD, OC symptoms, and psychological distress, delusions, and some patients also experienced hallucinations. So this systematic review of the articles revealed that the persons being like persons who have had COVID-19 had effect on their mental health status. There were several factors. There were several factors which were associated. Some patients had fear of transmission to their fear of infecting to their own family members. Some patients mental health were affected because they were worried about they were thinking about their death and what will happen after that, and some were worried about their lost jobs. So all of this because of all of this, the patients mental health status were seen at the at the present time. The global focus is on preventing COVID-19 infection spread, which is likely to divert public interest from the psychological and mental health effects of the pandemic on infected population and the general population. The challenges of mental well-being emerge from this global occurrence that can lead to loneliness, shame, and long-lasting health problems. So global health action to tackle psychosocial stressors confined to patients and general public need to be initiated for mental well-being. So with this, I have concluded my poster presentation.
Yeah, thank you, Dr. Akansha, for your presentation. I don't have question because you have presented the areas of concern in terms of who are more likely to have the higher mental kind of, I would not say illness, but higher depression and anxiety levels. So thank you. But do you find any reasons in the literature which say that why Indian gender differences or this thing in the male versus female is different than the other settings, like why the men where we see
Yes,
that
sir.
in the other setting? Yeah.
So actually, from India, we only got one study which focused on mental health status among COVID-19 patients, which were described in detail. But in supporting literature, we found that among Indians, the men were most likely to be affected more because they are the bread earners, and like till now, and like most of the households, there are people who are where men are the only earning source of income, and women does not have an earning source of income, and they are housewives. So it was seen that among men, it was seen that this particular factor was affecting their mental health more than what will happen after, like if something goes wrong.
Okay, thank you.
Akash, it's a good systematic review I found. Only thing, just while reviewing the document, did you find anywhere what are the consequences of this mental health issue after the post-COVID stage, and what actions are being taken by the respective government? You have mentioned some of the countries like Italy, Iran, where the anxiety and depression was more. So did you find anything like that?
Sir, there are like after the lockdown and COVID-19 happened, now people have suddenly started focusing on mental health aspect also. Earlier, it was not much important for them, but now people have actually started focusing on their mental health, because at some point of time we all have experienced that that dilemma of, you know, like catching COVID, and we all have experienced that. So now what I see is like all other organizations like NGOs and government are also working on schemes which are focusing on mental health status. Like specifically in India, we have seen the suicide rates have gone up after the COVID-19 and the lockdown happened, because a lot of people have lost their jobs, and uh, the like in our country only the suicide rates have gone up. So now organizations, specifically NGOs, NGOs which are focused on mental health aspect only, they're working towards it, and like now there is much more awareness among people also.
So did you see that now in some of these countries when there is an institutional quarantine during the COVID?
Yes, yes, sir.
So that during that time, whether, I mean, apart from the regular medication or vaccination efforts, that's different. For that, this mental health or psychological issues, they have taken any action? Any of your literature said? Because this is the important area what you have focused. We have not much thought of it, or not much actions being taken on this. But this is an important area itself.
Yeah, so in the literature, like while looking at the literature, supporting literature, we also saw that being in institutional quarantine, people were seen to be more like affected by like their mental health status were more affected, because they were away from their family members, and some patients have just some qualitative reviews included that some patients have asked to meet their family members or just to see their family members once, and they started feeling better. So these were the things which were seen among like institutional quarantine places where people were affected more.
Okay. Okay, that's all from me.
Thank you so much, sir.
Thank you.
So can we have Isa? Please share your screen, and you have 5 minutes. I'm audible?
Yes, you are audible. We can hear you.
Is Mupenzi Isa? Mupenzi Isa, we are not able to hear you. Can we have Vinod Joseph? Can we have Vinod Joseph?
Dr. Vinod, if you can hear us, please reply, sir.
Can we have Mupenzi Isa?
Yes, Ms. Isa, there must be some issue with your audio. So kindly check your audio connection again.
Am I audible?
You are audible. Now, yeah.
I'm audible.
Yes.
Yes, now please share your screen.
Okay, sir.
We are not able to see your screen. Please turn on your, share your screen, please.
Please have an option because the one of the floor is not working.
Yeah, Ravi sir, can we move it for the next candidate?
Yeah, sure, because we have to also see the timing. So
Yes. So can we have Raj Kumari?
Yes.
Yeah. Yeah, please share your screen. You have 5 minutes. You can explain it.
Okay. Hello, sir. Hello.
Hello.
Can you call the next participants? I'm having some problems. I will try to come in the next presentation.
Arpit, how many more presenters we have for this session? Hello, Arpit.
अरे पूछ रहा है वो कुछ जवाब दे उसको।
Hello, sir.
पूछ रहा है वो कुछ जवाब तो दे भाई स्क्रीन पे।
Hello, sir. Can you hear
यार पहले
me?
ये खत्म कर लेना, दूसरे हॉल में क्या करना है? दूसरे में वो नहीं है, संजय नहीं है क्या? यार अभी ये तो खत्म करा के जा, तेरे पास लिस्ट है। हद है तो बिना अरे उसमें अलग अलग है, मुझे क्या पता नेक्स्ट कौन सी है? तो मुझे बता दे उसमें से कौन सा नेक्स्ट है। तूने जो मेरे को भेजी है उसमें कहाँ क्लियर हो रहा है यार नेक्स्ट है, या उसमें तूने 66, 23, 68, 108।
Hello, sir.
Yes, yes.
Can I share my screen? I'm uploading now. Sir, can you see my that PPT?
No, we can't. No, we can't see your PPT. It's only the folder.
We are not able to see your PPT. Please open your this PPT.
Yeah, I'm trying.
Yeah.
Can you see, sir, my PPT?
Yes, yes. Please.
You have 5 minutes. You can explain it.
Okay. So, I will explain whatever that is given in this PPT. I will not go in details that. What is the definition of the MMR? That is maternal mortality rate, that is given by the WHO. It is according to the ICD, that is 10. That a maternal death is defined as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidents or incidental causes. So this is given the definition of the maternal death by the ICD-10 WHO. And the international classification of that disease, that is given according to the grouping, that is 15 death pregnancy under the headings of the pregnancy, childbirth, and the periods, and the coding is 000, that is 099. They have recommended that maternal death may be maybe this aggregated into two groups, means that the cause of the death of the maternal death they have classified into two. First one is the direct causes of death, and then another one is the indirect causes of maternal death, that is the obstetric death. And the maternal death is the only vital indicator which shows the greatest differences, that is the disparities between the developed and the developing countries. And the objective of this study is to find out the medical causes of death in Sikkim, that is one of the state of Northeast India. And the material and method that the data which I have collected is based on secondary data that is published by the birth and the death cells and under the government of Sikkim, that is Department of Human Care, Human Services and the Family Welfare, that is in Gangtok. And then the report is only we have a limited that data. So I have collected data from 2007 to 2012. And for that data analysis, I don't go in details. I just give the descriptive, that is frequency percentage, and the data that analysis was done in species. And the reasons was found that only 73 that registered medically certified cause of maternal death occur within this period. Only that 73 that was found within this period. And then according to that ICD, that codings that they have given direct and indirect causes, in my study that direct causes accounted for 66, that is 90.41% of death, while the indirect causes that contributed only 10 death, that is in terms of percentage it is 9.59 to the total registered medical cause of maternal death. And the three major causes of the maternal death was found to be the postpartum hemorrhage, that is 22, and the percentage is 30.4 percentage that maternal death was related to the postpartum hemorrhage. And then that in this that hypertension that counted around 13.70%, and the eclampsia that counted 12.33%, and the death due to that eclampsia that was 99.05, and there were only 4 maternal deaths due to abortion during this period in the states, but the number is very few. But as we just see the 2017 to 2012, so I think that this is one of the case that we can take in a serious way, because that what we have to find the other factor, that why that the pregnant woman is died during the abortion. There should be some other social factor. So that is one things that we can consider from the social point of view, not only just looking at that classification of the maternal death. And the cumulative percentage of the top direct causes of maternal death was 78.09, and the frequency of other indirect causes of maternal death was 14. So that the other indirect causes, that the number of that frequency was very less. So I just compile it into the others that grouping. And anemia was the first leading indirect cause of death, and the resulting around 71.43 percentage. And while jaundice and the dilated death cardiomyopathy, that is heart disease, that also constituted around 14.2% death to each of the indirect cause of death. So, just as compared with the other finding, that anemia is one of the indirect causes of death in India. So in the study also, it is coming to be parallel to the finding of this present study. And that anemia and jaundice, when we just take the cumulative that countings, it accounts around 85.71% of death during this period. So discussion is the study revealed that direct cause of maternal death contributed to 90.4%, and the indirect cause accounted around 9.56%. And then around that 80% of maternal death are due to the direct causes, that is obstetric complication of pregnancy, labor and perioperative interventions or incorrect treatments, and then 20% are due to the indirect causes. So this is the findings of the WHO that done in 2005 and 2012. So main things here is that as looking at the other finding, that the finding of this study is also coming the same. So this is the meanings. So the major cause of maternal death in India, according to the 2001 and the 2003 that SRS, that is sample registration system report, they have also found that hemorrhage, sepsis and hypertension, and then obstructed labor, abortions, and the other things also contributed to the maternal death. And the anemia, that is 19%, was the only leading cause of the maternal death. So the main that conclusion here is that direct the obstructive cause of death was higher than the indirect cause of maternal death in the state. And understanding the cause of death and trying to know that which cause of death are very common in this hilly area, where the communication and the transportation and the lack of the others that health care system is very poor as compared to the other part of the India. So that is one thing that the finding of the study can be also useful for the others, that the people and for the state government to take some precaution to prevent this cause of death. Because maternal death that happens in pregnancy, it means that the woman is not bound to die during pregnancy. It is a natural phenomenon, but still we are contributing one of the highest maternal death in the world, and reducing the maternal death is one of the aims of the so many that international and the national data development programs. And still India is also reducing in this maternal death of that pregnancy related one, and that even though in Northeast also we are also facing these problems, and we have to find out the other clinical as well as social and factor which we can try at the grassroots levels of the head policy of the state. So I finished my presentation here. Thank you so much. I think that.
Thank you. Just I have a basic question. You have taken the data from 2007 to 2012.
Yes, sir.
Whereas the most updated results are available now. You use the Research General Office data for MCCD report, medical causes of medical certification of causes of death data, but 2019 is already published till 2019, and also for SRS also. So these are the results. I believe some of this information got changed in the recent years on the causes of maternal death. So I request you to review this result with the most updated reports which are available, most recent reports.
Yes, sir. Thank you so much, sir.
Okay.
Yeah, for your suggestion.
Yeah,
okay,
thank you, Dr. Jayant. I also don't have much of the question, but except the same fact reiterating that you have to focus on the latest available data, because I also saw that you refer to the 2001 to 2003 SRS, where the distribution of causes of maternal death were there. And if you see the latest reports, there are reports available for India, also for the other countries where the PPH is the maternal, the leading the cause of the death for the maternal death so far as concerned, followed by APH and anemia. So I think when you talk about the causes and contribution, I think they don't vary too much across the states or geography, especially within the India, unless until you have the gaps in identification and management. So maybe you can relook into the latest data. But thank you.
And one more question to you. Please keep in mind that MCCD data, medical certification of cause data, in
Yes.
India as a country as a whole is also very poor. It's only around 22%. We
Yes.
have such kind of data for all for causes of death. So among the northeastern states, okay, Sikkim is relatively better in that sense. So when you do the analysis, please look into these limitations also, and also update the entire information based on the recent. You can look into it, is easily available. I have seen the reports of MCCD 2019, 2018, and SRS also 2018-19. So please check and review the interface. Okay, keeping in mind the limitations.
Okay. Thank you so much, sir, for your that useful that guidance and that suggestion that given to me.
Okay, most welcome.
Sir, I think Mupenzi Isa have resolved the issue. So Mupenzi, please present your poster if you're ready.
Okay, sir. Can she please close the
Mupenzi,
screen?
please show your presentation.
I can share when she has to close her screen first.
Yeah.
One second. Is it visible? Is it visible, sir?
No, not yet.
No,
Not
sir.
it.
But it showed me that have already shared.
Yeah, it has come.
Visible, right?
Yes.
Yes, sir. Sorry, I have technical issue before, but I think I can use the 5 minutes you have been given.
Yeah, try to be brief with your problem statement and clearly just highlight that the problem statement and the data used and what are the key findings. So maybe
Okay,
rather
sir.
than going through the whole thing. Yeah.
Yes, I'll be quick. So my study is related to contraceptive use among reproductive age female in Rwanda. As you seen, I've used the data from DHS 2014-2015. And this study also aimed to find the prevalence rate of contraceptive use among married women and unmarried women, because my country is different from India. So also unmarried women or female, they can use the contraceptives. So also to find the predictors of contraceptive among reproductive female. So we used descriptive statistics to find the prevalence. We used the chi-square test and logistic regression to find the predictors of contraceptive use. So in this, we also use the WHO formula to find the prevalence women. So, which the prevalence is 53.3%, which is very low.
Please unmute to others. ICS team, please unmute to others.
Excuse me. I can hear some voices in background. Can I continue?
Hello.
Yes, can I continue?
Yes, sir, you can continue. So I request ICS team to please unmute to others. Please unmute to others, ICS team.
Can the host please unmute?
Yeah, RPG and Manish ji.
So, Gitanji, it is Mr. Tawfiq, if he can mute himself. Mr. Tawfiq,
Mr. Tawfiq, please unmute you.
Mute himself.
Yes,
Anil Chandra, you are also co-host. You can also mute.
So have you seen the married women, the prevalence rate of contraceptive use is 53.63, which is very low. And the prevalence of modern contraceptive, as you see, like injection are the highest in use, and the low in use is IUD. And the prevalence of traditional method, you can see the day method is the most used among the females. So when it comes on the predictors, you can see that as the age of the respondent increase, there is a chance of using a contraception. Also, on the changing of status from single to married, there is a higher chance of using a contraceptive. Also, on the part of education, the non-educated women are having high chance to use contraception compared to the educated women. So, on the religion belief, the Muslims or Islam believers are the ones using contraceptive compared to Christians counterparts. And the working status are those who are employed are more likely to use a contraceptive. And also in the wealth index, in the middle classes are the most highest to use contraceptives, while the ones in the first class or the rich people, the rich women's. So there is also some indicators, like visiting health facilities, being told about contraceptive facilities on the health facilities, and hearing contraceptive from radio as a source of information. So we have seen that visiting health facilities, those women visiting health facilities, they have chances of using contraceptive compared to the one who didn't visit the health facilities. Also being told about contraceptive on the health facilities, they have more chance to use contraceptive compared to the one who are not visiting or who never been told about contraceptive. Also, the radio as a source of information. The ones hearing about contraceptive from the radio as a source of information, they have more chance to use contraception compared to those ones who didn't listen to radio or hearing the information about contraception on the radio. So also the study has concluded that the contraceptive prevalence rate in almost female segments is low compared to the government set target, because if I remember well, in the target of contraceptive use in 2014 up to 2017, it was at least up to 73.2. So, which is still very low, as here we have 53.3. Also, generally, including unmarried and married, they have only 30.6 as a preference rate, so which is very low compared to 73.2. So as a recommendations, I recommended that the contraceptive use related subject should be included in the school curriculum because it have seen that educated women are not willing to use contraceptions. So also in the religion services, they have to include the contraceptive awareness. So the religion believers, they can also get information from the churches, from the mosque, so that could be better. Also, the NGO and concerned institutions, they should be taken much care about contraceptives to raise the target of the government, as you have seen that it's 50, and among married women it's 53.3. Also, and like overall prevalence is 30.6, so which is still very low. But for the information of the new data of DHS, I have seen there is some slightly increase from 30.6 to 48.6, I think, which is still very low compared to the target. I think that's all. Thank you.
Thank you.
Are there any questions?
Yeah, just one clarification or maybe one suggestion I would like to say that you have given the predictors of contraceptive use among reproductive age females in Rwanda.
Yes.
Okay. So right. So those are the broad predictors you have given, but if you go deep into this analysis, and I think you are talking of all of the modern contraceptives. And I suggest if you go a little deep into the analysis and see method-wise, like spacing methods, apartment methods, like that. What are the predictors? Can you have any? Do you have any idea? Throw some light, because my assumption is that there will be a lot of variation in the predictors.
Yes, you are right. As you see, like so many people, like women, they usually they don't go for permanent contraceptive use. They usually for temporary ones.
Spacing one.
Yeah, they use temporary, like a 3 month, 1 year, 3 years. So they don't usually go for permanent.
Okay. Yes. Anyway, we'll come back to this. Let us have other questions.
Thank you. I don't have much question, but again, just a couple of suggestions. One is that the variable on visited health facility in last 12 months, I think that has a cause and effect relationship also, because there is a possibility that women went to the health facility to obtain the family planning service, and thereby there is a higher chances, or is it the general healthcare due to which they have got it, and the chances were high. So if we can convert this or use this variable in terms of the exposure, like whether they have in the DHS, generally the question is also there, like we can compute about their exposure to the program, both in terms of the frontline worker and also from the health facility. I think that can be a better measure to use here, because there has been a lot of now papers which are arguing this variable on that, whether we should consider visited health facility, when we are not very clear it is whether for that same method. If it is for the family planning, then they are likely to have a more use compared to the others. So that is one. Second is that like again in many settings, especially rural settings, the mass media exposure, and then that is something done by radio is found to be effective, but it is not it is coming other way here. So there might be required some explanation. Is that what is the thinking? Is there like what is the understanding from this variable, that how the radio or that kind of mass media exposure is not working towards improving the more modern contraceptive use?
But it's significant. The mass media is significant.
No, it's less likely, right? So those who have heard about family planning on radio, they're less likely to use the method.
Yeah, it's less likely. Here, I think there is some new program for now because you have seen I have used the old data. So maybe for the new DHS data, there is some new program implemented by the government. So those one visiting the health facilities, there is some programs implemented by the government. So to educate those women coming for delivery and some other purpose or some other health issues, to teach them or to encourage them to use the contraceptive. So I think according to this new implemented program, I think people will get to use more contraceptives compared to the recent situation.
The prevalence rate, what you are giving here is for spacing methods only. You are saying maximum they are using the temporary methods, yeah?
Actually, there is in the WHO there is two different like prevalence rates you can calculate. There is a prevalence rate of among married women. Also, you can also find like a general prevalence rate, including the unmarried women, depending on the countries, because about.
Sir, I'm not getting into married or unmarried. I'm talking of the reproductive age women, as you are saying. But my question is that is this prevalence rate, what you are talking of here, is for the temporary method or permanent method or for both?
No, it's for both traditional and modern.
Okay.
Yes.
Both traditional and modern. So why don't you redo this analysis based on the methods? Like you are saying that traditional methods are also there. So traditional methods and then temporary methods, then permanent methods. If you redo this analysis, result may show something different, or it gives a better picture over here.
Yes, actually, I have tried this one. I have tried to analyze using only modern methods and traditional methods. So by using modern methods, I have seen more predictors which are highly significant, and also they are high likely to use a modern contraceptive.
Okay, absolutely fine. I agree. But within modern methods, why don't you break up? Like do the analysis separately for the temporary methods and permanent methods.
Okay, you mean like I can make a comparative between two, modern and traditional?
Yeah, that will make it more interesting.
Yes, I tried that. Thank you so much.
Okay, welcome.
So can we have, okay, so can we have Elizabeth, AM Elizabeth?
Yes, I am here.
Yeah, please present your
yeah, I'm sharing my slide. Is it visible?
Yes.
Yeah. The topic was this topic is on sustainable development of elderly health and well-being in India and an integrated multi-sectoral approach at regional level. As we know that this population aging is inevitable, so to maintain functional ability and well-being the older people, we need active participation and management of its own health. Besides that, we need to address all our social determinants for improving the quality of life of the elderly, and thereby it requires very multi-dimensional and multidisciplinary endeavor to have a very cumulative and impact. And our sustainable development goal focus on leaving no one behind and everyone is a partner in development. It emphasizes on localization of SDG for its optimum achievement. And here, when we talk about the localization of SDG, we try to collaborate with the local governments, particularly the PRIs at rural and municipal bodies at urban level. And here in this paper, we try to examine the engagement of local government in the current programs and schemes meant for elderly, and how the collaborating with multi-stakeholders will be carried out at local level for better health outcome of the elderly people. The materials that were used were the secondary data source, that is all the published journal articles, reports, government reports, reference papers relevant for the topics that I've downloaded. And here the table 1, here it shows about the elderly health sustainable development goals and the responsibility of the ministries and the local government responsibilities, which I have identified from the various reports that I have compiled. So when I did the analysis, I find that among the elderly, there is an increase in the acute chronic morbidity and disabilities with advancing ages, and at least 2/3 of the elderly have at least one kind of chronic conditions, and is more prevalent in the elderly women as their longevity is coming out to be more compared to the man, and this more in rural areas. And most of these chronic ailments are arthritis, hypertension, cataract, and diabetics, and few of which required long-term medical interventions, causing a lot of medical expenses for the family. And moreover, this kind of chronic diseases and prevalence is shows quite state-wise variations. And further, these vulnerabilities among the elderly seems to be increasing with the declining functionalities, particularly with the ADL. And it indicates more economical and other burdens for the family and so at society level. So to address it, we have under health system, we have a national health program for elderly, national program for the healthcare for elderly, and it envisages architectural correction for providing accessible, affordable, qualitative health cares through convergence of logistic manpower and resources, and repositioning of the very primitive preventive curative rehab services through community-based primary health approaches, and again delivering this intervention through national health missions, Ayush, and other line departments like Ministry of Social Justice Empowerment, Ministry of Rural Development. And it also highlights about the strategic action plans to at local level for implementation of coordination to make it more worthy. And it also finds involvement of local governments like PRI municipal bodies for maintaining accountability of the program. So when you talk about the elderly good health and well-being, we talk about the intersectoral mechanism for collaboration at local level. And here elderly health emphasizes on age appropriate care. So that includes long-term care services and technology for prevention, detection, and treatment of diseases. And the SDG 3 that focus on good health and well-being consists of a number of 12 targets, and which is most significant for elderly health, and all the responsible ministries and local governments, which I have already shown the table 1. So what the LG need to do now, that need it's local government that need for increasing the quality of life of elderly people. First, they have to focus more on IEC activity of the elderly people, and for the people in the community regarding various health services that is available at different level, and how these services can be accessed, and campaigning all the health insurance schemes covering the elderly, which has been introduced by the government. They need to involve the formation of elderly people association at local levels, and they need to ensure that their representation in Gram Swasthya Sabha, Rogi Kalyan Sabha, Jilla Swasthya Samiti, etc. And also involve the periodical social audit and collected information, the health profile elderly in their locality, and also identifying the high-risk elderly persons for appropriate timely intervention, organizing medical camps for screening elderly for their various morbidities at regular intervals. And also they need to support the local health workers and make and ensure that the referral and regular follow-up treatments for the elderly people were carried out, particularly during the medical camps. And they need to be aware of the main health issues in the localities along with the Department of Health, and how to address this effectively in coordination with other departments. And this will help this local government for intersectoral linkages for early health intervention. And to reduce the fatality of communicable diseases, they have to work on this ensuring the basic services like drinking water and sanitations. And they need to have collaboration with other departments like social justice, women and child department, tribal affair departments for establishing old age homes for destitute elderly, short stay homes and daycare centers for elderly in their locality. So that with the support of the elderly and their families, keeping elderly at the center stage. The main here I have developed one conceptual framework for local government to address the socio-cultural determinants and to ensure the quality of care and life of elderly people. And this local government has to, along with the other departments which has been identified, like all the ministries like family welfare, Ayush, drinking water, urban housing and urban affairs, research and development, there are around 19 departments and ministries are there, along which they have listed out how the local government will be involved. So the local government needs to be first made aware of what all those government schemes that's available with the different ministries, and they need to work with the health department along with other departments to implement this to address the socio-cultural determinants. So for addressing the social inequality for the different segments of the people is very important, particularly which includes also elderly people. So replication of if you give a input on all the segments, ultimately it will reach to elderly also. And the 17 SDG listed in the UN also focus on the local government intervention for timely achievements. And it requires more integrated horizontal cooperation and coordination, at least in planning policies and programs between the different departments, including panchayat, local community, municipalities, and regional cross borders, and local governments should ensure that this is happening. And LG is also essential for reducing the inequality, internalizing resources to most deprived areas, building capacity to identify and tackle social determinants like poverty, exclusion, and to provide services in a non-discriminatory way in the community consultation process involving minorities and traditionally unrepresented groups. Further, they also need to take action for elderly well-being by combined engagement of all other actors like government, private, non-profit organization, community groups, and regional health authorities in consultation with local government have the responsibility to direct, plan, and deliver services, particularly the specialized services for health. And additionally, they need immense services across broad areas of services like building of public work, parks, recreational centers, community planning, libraries, then income generation activities, and involving adult education programs. But the conclusion is that, however, the lot of activities has been listed out by the different departments and to ensure the involvement of the local governments. The local government in our country have limited professional expertise and experience to understand the health challenges in the community and the potential for health promotions. Hence, the regional health authorities needs to play significant and meaningful role in partner with the local government in addressing the health challenges of the elderly. These are references. Thank you.
Okay.
So judges, respected judges, if you have any kind of questions, you can ask them.
Yeah, so no question, and I think this is an important summary of all the government programs and the policies which are there. I think the issue here is that the convergence and the challenges in bringing down all or I would say various or most of the departments which need to come together and work on the helping the elderly is important. So I think this is a very nice summary of presenting what is being happening and how different departments are responsible. Just in the as a suggestion, I think if the information is available on what are the challenges basically at the local level in implementing these policies, because many a times these policies are done or kind of drafted based considering the pan India level situation, but again it needs to be modified according to the state need and the context and other things. So maybe some pointer on that can also be highlighted in the paper, wherein it can be mentioned that the opportunities or the flexibilities to modify them in the local context is also important. But thank you very much for presenting this.
Thank you, sir.
Thank you very much. I will reciprocate the same thing. It should be looked into state-wise. And the other thing is that it requires a lot of interdepartmental coordination.
Yeah, it's required a lot of interdepartmental coordination. But
Yeah, right.
rightly now we don't have so much of interdepartmental coordinations. Everything in a document is well written, policies and programs are well framed, but there's a lack of coordination. Maybe the departmental initiatives, they may be sending some letters to some other organizations. So the ground reality, there's a total lack of coordination. You can say that. So we need to address that. So then only we can give a good elderly friendly activities.
Right. Not only for the elderly, for any other
For all other communities also, all categories of people also.
All social protection scheme has facing the same problem.
Yeah.
In interdepartmental coordination. So can you address some of these challenges in your paper or in your section based on your analysis or everything? How to address this challenge? How do you address? It's just writing a
First, I think we need to strengthen our local governments, because the PRIs that they actually don't know about what the schemes are available, what the programs are available, what exactly that's available, which they can implement. So I think we need to give better orientation, better training for local governments, particularly the PRIs. Then we can, they are the actual people who can implement most of the schemes at grassroots level.
Right. So it has go to the down. Maybe
yeah, you have to go to the down. Even states have their own programs also there. But when it comes to the implementation part, the PRIs are not that much aware of. So so they're not able to. They're unable to implement that.
Right. Thank you very much.
Thank you.
So can we have Dr. Ann Nirmala Sarwan?
Yes, sir.
Please show your poster, and you have 5 minutes.
I am doing a oral presentation, sir. Mine is not a poster. I am presenting an oral presentation.
Okay, oral presentation is not here. Okay. This is the poster session. Jitendra ji, over to you, sir.
Ma'am, your paper is selected for oral or poster presentation? Hello? Hello?
Mine is an oral presentation, sir. I am doing it after 4:15. I was just viewing the.
No, your paper is in which session?
4:15 session, sir. Mine is an oral presentation.
So it is not here.
So this is not here, no?
No, sir. I was just seeing what's the best posters, sir.
Okay.
Okay, sir. Okay.
I think no one is there, sir.
So Jitendra ji, I think we have completed all the posters over here.
Okay.
So are you going to send any score sheet or something? How do you score this thing?
I think, sir, Ravi Prakash will send to you his score, and you may compile and select one and send to ISP.
For yesterday's one,
For yesterday, I got it. For yesterday, I got it. For yesterday, I get by TS Samla.
Okay. So today Dr. Ravi Prakash will send to me, and I'll. Okay, fine.
Okay. So shall we close?
Yeah, you can close, sir.
Okay. So on the behalf of ISP, I thanks to all presenters and congratulations in advance for the award. So award will be announced in tomorrow in validity session. And I really thanks to Jayanta sir. He is a judge from yesterday and yesterday process also today. And I also thanks to Ravi Prakash. He joined us as a judge very short notice. And finally, thanks to all. So thanks. So now we formally close the session.
Thank you very much. Thank you.
Thank you very much, Doctor.
Thank you, sir.
Thank you.
Dr. Dolly, are you there? Hello? Dr. Dolly?
Hello, sir. Yes, sir, I'm there.
Yeah. Okay. So let's, plan the session. Yeah.
Yes, yes, sir. Yes, sir.
What's your background? Your is what's the background?
Yes, sir. Yes, sir. I did my PhD from IIPS.
Okay. Now, where are you currently?
Sir, currently I'm in Patna. I'm an assistant professor at Center for Economic Policy and Public Finance, ADRI, sir.
Acha, yeah. Okay. So you're an assistant professor there. Okay. Very good.
Yes, sir.
Very good. I'm, I'm Venkatesh Srinivasan. I served with, you know my name definitely. But I served UNFPA for more than 3 decades.
Okay, sir.
Okay,
Good.
let me
Very
put
good.
my face also. Yeah.
Yes, sir.
And
Yes, sir. Yes, sir.
I've been actively engaged on several issues, including one aging. Yeah. So what we can do is there are you call for the presenters.
Okay, sir.
And there are 6 presentations. So let us give them 10 minutes. So the entire session is 90 minutes, right?
Yes, sir.
90-minute session, na? Yeah, 4:30. Yeah. So let us give them 10 minutes or 10 to 12 minutes max. So people will take another 2 minutes extra. So
okay, sir.
Okay, yeah, 12:06:72. And then smile, introduce. You can summarize, and then I will make my final comments. Yeah.
Okay, sir. Okay.
So you call for the individuals and then presentations, and you can do a summary, and then we will wind up. Okay.
Okay, sir. Okay, sir. Fine.
Okay. So we'll join around 4:20. 4:25, 4:26. We have already joined, so we can start. Let's see, how people turn up. So latest by 4:32 or so, we should start the session. We shouldn't delay.
Okay, sir. Okay.
Okay. Thank you.
Hello. Hello.
हाँ डाली
Shall we start, sir?
नहीं थोड़ा वेट कर लो अब
Okay, okay.
अभी टाइम है ना
2 minutes.
2 minutes now. So who is the chair your chairperson
Chairperson. Huh.
chair who is the chair going to chair in your session
I'm there. I'm there.
No,
Venkatesh
sir,
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 Venkatesh sir.
Yeah, sir is there. Sir is there.
Okay.
Jinder,
हाँ सर नमस्कार
namaskar. How are you?
हाँ फाइन सर
Congratulations. Yesterday you got the award.
थैंक यू सर थैंक यू
Nice. Do hard work.
यस सर
No physical interaction, but at least virtual interaction is there.
yes sir
Good. Keep it up.
okay so I think most of the projectors are also already joined
Okay.
okay so shall we start
Yes.
so on behalf of the ISP I welcome to all the presenter and especially to our chair and co-chair so Venkatesh sir and he was
Okay, sir. Namaskar.
Namaskar, Dr. Adinarayan. How are you?
Thank you.
So Venkatesh sir is a well personality. He was the second position in the UNFPA earlier. And sir, your co-chair is Dr. Dolly.
Yeah.
So she did PhD in aging.
Okay.
So this session is aging, so that's why she is a co-chair. So over to you, sir. I'm not going to delay anymore.
Yeah. Thanks, Dr. Jiten Yadav, for the introductions. And it's good to note that young professionals like Dr. Dolly is taking interest in the issues of aging. Just 2 days back, after the release of the NFHS, as usual, the media people were, asking for, interviews. So one of the leading Hindi channels was interviewing me and they were asking, what is your take on NFHS? And then the discussion shifted towards aging. Then I was saying that it is very critical that this country needs to seriously look at issues of aging so that we do not have, problems in the next, after 10, 15 years because of the increasing size of the, 60 plus population in this, country. And it is good to note that we have a separate session on aging in this Jubilee, session of Iasp. And I only wished that, there were more participants to hear, the papers being very good papers that have, been put together for this session. I wish only that, there are more people to hear this, very good research that has been undertaken. A few things on the research in aging. Well, at UNFPA, as Dr. Yadav said, I spent more than 3 decades. And one of the areas that we started focusing on in India is aging. In fact, that has been one of the basis for the Center for Aging, which Dr. James has started at IAPS recently, which we had been contemplating for some time. So the issue of aging in this country is very very critical. I have been saying in different fora that only if the country had looked at young people and their needs and skilling some 25 years back, we would have been in such a bad shape now. That in the last 5-7 years, we have been trying to catch up with skilling and so on, which we have not been able to do very well as we would have intended, it to be. So similarly on aging, when I compare having been, part of several international fora, when I see countries like Taiwan, let us say Taiwan, has excellent, programs on aging currently. But when you look at the history, in the sense in the last 15, 20 years back, they started these programs. they also were about 9%, 60 plus population then. So we were around also 9%, 8.7% something in 2011 as per 2011 census, 60 plus, aging. So, but unfortunately, the pace at which the support for programs and research hasn't been that much. But I'm glad that young scholars as well as old scholars, Dr. Adinarayana, all are there. So the senior scholars as well are taking interest and guiding. I hope hopefully the younger ones in taking up research on aging. Issues on aging are very critical. It's not just about the demography. I think that part has been done, by the demographers in terms of estimations, forecasting, and the projections and so on. But what is needed mostly is research on sociological issues. What are the coping mechanisms of elder people, healthcare, seeking needs of elder people, psychological. I've been very closely associated with the University of Heidelberg. So the amount of research that they do on psychological issues of the aged are very critical and are very poorly researched. But I see the session today has 6 papers, and I see research on psychological distress, health seeking needs, cognitive impairment, and so on, and living arrangements, health seeking patterns, and so on, which are, I think, very critical for the country, and research is being undertaken. So with these words, I welcome all the presenters to this session, and I request Dr. Dolly Kumari, who's the co-chair. She herself is a scholar on aging, to conduct the session. We have about 6 presentations, and I would request all the participants, all the presenters and the participants to actively engage themselves in discussions post the session. So let's have the presentations, post the presentations. So let us see how it goes. At least 3 presentations we should have, and then some discussions probably, and then maybe 3 more. Let us see, the interest levels of and the questions that will be posed. Yeah, over to you, Dr. Dolly.
Okay, thank you, sir. Thank you for the very enlightening welcome remarks. So we'll start now. So I would like to invite the first presenter, Dr. Narayan Swami, for the presentation. Please, sir.
Yes, thank you, Dr. Dolly. Thanks to the chairperson, Dr. Venkateshan Srinivasan. My paper, I will try to share first, see whether I will be able to share. Is it okay, sir?
It's coming up. Yeah, it's coming
yes,
up.
Sir, yes, sir.
Thank you, thank you. This is a small research. In fact, the data is by Dr. Nirmala Srinivasan, who got her PhD recently. The next presenter. The data is from Puducherry, and of course, the scenario of elderly has nicely put forth by Dr. Venkateshan, and one of the major dimensions is psychological dimension, which are not that much studied. So keeping that in mind, this paper is explored. So we will see how it goes. The presentation is about an empirical assessment of psychological distress and its determinants among the elderly widows in Puducherry district. Me and my co-author is, of course, next paper she is going to present. The rationale, are you able to see the next one, sir?
Yeah, absolutely, no problem. If there is a problem, I'll let you know. Yeah, please go.
Because what happens is 1 or 2 seconds it will be delayed. That's all.
Yeah, no problem. We can see.
Okay, the rationale behind the paper, of course, in India, rapid growth of elderly population is taking place, and such population is expected to cross 320 millions. That's what expectation. Of course, it may be a little bit more or less by the year 2050. And this is likely to be 20% of the total population at that point of time. And everybody knows that with increase in age among the elderly, the physical health certainly deteriorate because of the deterioration in the functions in the bodily functions, and which in turn will also affect the psychological or mental health to a large extent. As rightly pointed out by Dr. Sri Venkateshan, many studies focused on determinants of physical health as far as India is concerned, but few only attempted to study the psychological health, especially in terms of elderly widows, especially in terms of elderly widows. That is another thing. So normally, elderly in general studying is one aspect, and this is a specific study on elderly widows in Puducherry. So keeping this in mind, this paper deals with measuring the extent of psychological distress among elderly widows of Puducherry district and what are their major determinants. And friends, the objectives are threefold: to measure the extent of psychological distress among the elderly widows in Puducherry district, to examine the differentials, if any, exist in the magnitude of psychological distress of the elderly widows across their demographic and socio-economic characteristics in Puducherry district, and finally to find out the major.
Hello, sir, please put your PPT on slide mode.
Acha, you want to slide mode?
Yes, sir.
Thank you, bhai. Is it okay?
नीचे में है right side में, नीचे में है right side में.
किधर है यार? Not to be seen.
और नीचे right side में, नीचे और नीचे right side में.
हाँ, नीचे. Yeah, clear. Next. Move your cursor.
Where it is?
No, at the bottom, no, at the bottom, there is that slide.
This one.
Next one. Yeah.
Oh, sorry. Visible?
I think यादव जी वो आता नहीं है कभी इसमें.
That's what I am.
ठीक है.
इसलिए मैं पहले बोला नहीं. ये कभी आता नहीं है.
Okay.
Please continue, sir.
Able to see, na?
Yeah, we are able to see. No problem.
That's okay.
Okay,
fine.
Please continue.
But I had to move this a little bit.
What? No, you go ahead. You keep changing the slides. It will keep changing.
No, the screen is very big.
Oh, your screen is gone.
It is there now. Okay.
Okay.
So the threefold of the objectives I explained. So the data, as I told you, data and methodology. The data was from rural and urban areas of Puducherry district, and of course I have given how the data, the sample has been selected at the first stage out of 8 urban wards and 2 rural communes. 2 urban wards and 1 rural commune were selected. At the next stage, 20 census enumeration blocks.
That Radhanarayana, you might have to go to the next slide. Slide we see is only objective still.
That's what I'm telling. So some minor problem is there, maybe in my laptop, or that's why I asked whether the slide is.
No, first 2 are coming up. Second is not. Now it's not.
Data and Matra. Now it's okay?
No, it's not coming. What you do? Yes.
Individually, I will try one. No other.
Yeah. It is
now it's okay.
Yeah.
So the first stage, 2 urban wards and 1 rural communes were selected, and at the next stage, 20 census enumeration blocks from urban areas, 10 villages from rural areas were selected, and at the final stage, 13 households per PSU selected, wherein at least 1 elderly widow is dwelling. So in all, 390 elderly women were selected and studied for this small piece of research work, out of which 260 were from urban areas and 130 from rural areas. I'll go slide by slide, sir. Well, measurement of psychological distress is the major concern of the paper. All of you know, I hope, the Goldberg's GHU 12 scale has been used, wherein 12 items have been asked to the respondents, and their responses have been elicited based on a Richard type scale. So the cumulative score ranges between 0 to 36, and
Can others
calculation
mute?
these tests
Uh,
by
Dr. Radhanarayana?
yes, sir. Some disturbance is there. Hello, please ask to mute.
Who's the host? Who's the host? Can you mute everyone else?
Yeah, somebody's mic is muted.
No. Who's the
Hello,
host?
Sandeep ji.
Okay, okay.
Fine now, fine now.
Okay, okay.
Okay, go ahead.
Based on this cumulative score, the dependent variable has been formulated, wherein 0 has been given a score for which the score is 12 or less. That is, they are better in mental health status, and 1 is any score of the 13 and above that reflects the state of psychological distress. So that is our definition of dependent variables. The independent variables are 14, of which demographic, socioeconomic, and health-related factors have been included. And mostly all these independent variables are categorized in nature. And the analysis has been done with chi-square test and cross tabulations. And the second, the final analysis is binary logistic regression analysis. Coming to the results and discussion, are you able to see now?
Yes.
Okay, good. So the overall among the elderly widows, 59% of them are suffering from one or the other in the state of psychological distress. There is a score about 13 and above. Well, the results based on cross-tabular analysis with chi-square analysis with the chi-square test of significance showed that the percentage of elderly widows who are in the state of psychological distress is lower among those who are residing in urban areas, belong to backward and forward caste.
Please shift the slide.
Okay. Sorry, this is what happening. Okay.
Yeah.
Now it's okay?
Yes.
So those the percentage of elderly widows who are in the state of psychological distress is lower among those who are residing in urban areas, belong to backward and forward caste, studied in middle school and above, and owning a house, belong to families and households of higher income as well as standard of living of index, and have higher exposure to mass media, perceived self-reported health status as fair and good, and suffering from 1 and 2 or more chronic morbidities than their respective counterparts. Conversely, the percentage of elderly widows who are in the state of psychological distress is higher among those who are who belong to 60 to 75 years and 75 plus years age groups, economically dependent, and have a PPL card and suffering from any physical disability. Well, the chi-square tests are significant at different levels, and among all the factors, living arrangements didn't show any association. These are the logistic regression analysis, as I told you. Of course, I am going to the findings directly. These are the tables. The finding shows, the result shows that the logistic regression analysis highlights of the 11 factors included in the model, the odds of psychological distress are lower among those elderly widows who are living in urban areas, studied up to middle school level and above, and belongs to families that have higher monthly incomes and owning a house, and also belong to forward caste than their respective counterparts. Conversely, such odds are significantly higher among those elderly widows who are suffering from 1 and 2 plus 2 and above chronic morbidities and economically dependent, have a BPL card, and suffering from any physical disabilities. Well, though the cross-tabulation analysis, some of the variables have shown significant effects, the net effect, when it comes to net effects, the advanced age and while advanced age is positively associated, where living arrangements, living alone is negatively associated, but they didn't turn out significant when it comes to logistic analysis. So keeping these findings, a few policy implications have been proposed here. Aged persons in general and elderly widows in particular have to be motivated by the younger ones and adults by providing suitable facilities and services to them so as to keep up their psychological and mental health status in a better manner. And elderly persons living in rural areas have to be provided with healthcare facilities and at their doorsteps so as to keep up their mental health status in a better manner. Elderly persons used to be encouraged to save money and also to own assets or property on their name till their twilight years. So this is a paper of mine. Thank you for patiently listening. Any clarification, suggestions, welcome. Thank you, sir. Congratulations.
Thank you, sir.
Thank you for the good
Very nice
presentation.
presentation.
Yeah. Yeah. Dr. Dolly, yeah, you can ask, you can call the other.
Okay, sir. Okay. So, sorry, I forgot to tell every presenter that we have only 10 minutes for every presentation. So, make sure that you'll finish within that time period. So, the next presenter is Dr. Nirmala Srinivasan. So, she is going to present next. So, ma'am.
I'm here, ma'am. I'm ready. Okay. Can you help me with the screen sharing?
Okay, ma'am. Ma'am, I'm not able to see your screen. So,
no,
Hello,
ma'am, I
sir.
can't
Please
share
exit your screen. Please exit your screen, sir.
Screen can't be shared, sir.
Dr. Adinarayana has to exit.
Adinarayana, sir,
Yes. Done.
Now, ma'am, please share
Yeah,
your screen.
I'm sharing, sir.
Okay, as she is sharing, Dr. Adinarayana, later you can throw light on living arrangements. What implications do you think? Because that was one of the issues. We don't have to discuss now, but yeah, I just
we'll discuss. Yes, thank you.
A very good evening to one and all.
Good evening, madam.
Thank you for the opportunity provided to me to present in this Iasp conference. The topic which I'm going to present today is factors influencing care-seeking behavior by the elderly widows in Puducherry district. In India, this study was conducted among the elderly widows. Elderly widows are not only are more vulnerable socioeconomically, but also they are also vulnerable in receiving care and support from their children and others. So with the increase in age, there is a need for a lot of care and support in terms of physical, economical, emotional, and psychological in nature. But their physical health is largely deteriorated because they are suffering from a lot of physical disabilities like movement, hearing, memory, and dental problems. There are very few studies conducted on focusing on this physical support. So hence this study was conducted to explore the same with the elderly widows in Puducherry district. The objectives of the study was...
Madam, one second. I think your second slide itself didn't come up, the rational slide. Now we have gone to the objectives. Just keep pushing the slide. Come to the next slide.
The objective slide, sir.
Yeah, we are still on the first slide. We are still on the opening slide.
But for me, it's moving, sir. I'm not, I don't know what's wrong.
Problem.
But for me, it's moving.
But Adinarayana, what did you do?
No, we have to go back, click the second slide, click the third slide like that.
Okay, go to the slide. Go to the slide sorter on the side, no? The left side.
Left side.
Madam.
Yes, sir.
Left side. Left side slide click பண்ணுங்க.
The slide
okay,
left slide
sir.
இருக்குல்ல அதுல போய் அந்த டூன் போட்டுருக்குல அது அமுத்துங்க பார்க்கலாம்.
இங்க பாருங்க சார் இப்போ
வரல. ரெண்டு இல்லமா ரெண்டுக்கு போங்க. ஸ்லைட் ரெண்டு இருக்குல அங்க போல நீங்க. லெஃப்ட் சைடுல ரெண்டு இருக்குல. ரெண்டாவது ஸ்லைடு.
அது கிளிக் பண்ணுங்க.
Oh my god.
Yeah, oh Soumya. She's not going to that. Please go to the slide sorter on your left hand side. There are slides, no? Go to slide number 2 and click.
Slides.
Are you following? No, you're not following.
Yeah.
Slide ke pogala. First slide la irukanga.
Illa madam. Slide sorter side la varudhu illaya 1 2 3 nu. The rendavathu slide ku
go to slide. Yes sir.
Yeah.
Click பண்ணுங்க.
இப்போ சார்
செகண்ட் க்கு போங்க. இன்னும் போகவே இல்ல.
போகலையாங்க. அது செலக்ட் பண்ணலையா?
செகண்ட் செலக்ட் பண்ணுங்க.
1 2 இப்போ சார்
இல்ல வரலாமா?
ஸ்கிரீன்ல தெரியுதே நீங்க செகண்டுக்கே போகல.
எனக்கு போகுது சார். எனக்கு போகுது.
Is the organizers having this presentation? We are wasting time.
No, sir, we don't have the presentation with us.
सबका presentation ले रहा चाहिए ना शर्मा जी, तो ये तो बेकार हो रहा है. Okay, I don't know what to do. क्या solution है आपका?
Sir, shall I present it?
Okay,
just
now
like
yes,
this?
now it has come. Okay, go ahead.
Shall I do this like way?
No, now it has come. Objectives has come. Yeah, please.
Okay. Okay, I'll do it, sir, like this.
That's what now it is coming.
Yeah.
When we go to a slideshow, it's not coming, sir. It's
So don't worry about that. Okay.
Okay, sir. The objectives of the study is to understand the extent of seeking physical care or assistance among the elderly widows in Puducherry district. To examine the differentials and magnitude of seeking physical care or assistance among the elderly widows across the demographic and socioeconomic characteristics in Puducherry district. To explore the major factors influencing the extent of physical care and assistance among the elderly widows in Puducherry district. Data and methodology. The study was conducted among the rural and urban areas of Puducherry. At the first stage, 8 urban wards and 2 rural communes were selected. Among the 12 urban wards, 2 urban wards and 1 rural commune was selected by simple random sampling basis. In the next stage, 20 CEBs and 10 villages were selected on a simple random sampling technique. At the final stage, 13 households per PSU, in which each one of the elderly were dwelling were selected based on systematic random sampling. Out of which 390 elderly widows were selected, 260 from the urban and 130 from the rural areas. The measurement of physical care by assistance was done by based on their day-to-day activities like cooking food, visiting temples, shopping, visiting post offices, bar bank. The dependent variable were given numbers like 0 for no need or no one for taking care by taking care by self, and 1 for seeking care support from anyone for more to 1 or 2 day-to-day activities. The independent variables were current age, educational level, monthly family income, SLI, place of residence, economic dependence, chronic morbidity status, cash living arrangements, personal monthly income, ownership of the house, total family members, number of daughters, and any physical disabilities and functional disabilities. Cross tabulation with chi-square and multivariate logistic regression was done. The percentage distribution of the elderly widows on seeking or not seeking physical care was 35%, 35.9% were not seeking care from anyone, and 64.1% were seeking physical care from or support from 1 or more. Results based on the cross-tabular analysis revealed that with elderly widows who were seeking physical care or support was found to be higher among those higher in age, that is 65 to 75, and above 76 years, and getting higher income, who belong to who had a social pension, who belong to families or households with higher income, and who were economically dependent, who belong to ST or FCs, and who had 1, 2, or 3 daughters afflicted, who had any physical disabilities, and who belong to family members 2 to 4 and 5. Than their respective counterparts. Conversely, the elderly widows who were seeking physical care or assistance was lower among those who were living alone, who were owning a house, were suffering from 1 or 2 chronic morbidities, and whose functional ability is moderately high than their counterparts. The chi-square results in these regards noted as highly significant, except for caste and chronic morbidity status, less than 0.05. The place of residence, educational status were not significant associated with physical care and support. This is the tabular column showing the factors influencing physical care and assistance of the elderly widows. Coming to the results based on multivariate logistic regression analysis, based on the 11 factors included in the model, the odds of seeking care and assistance on day-to-day activities was higher among the elderly widows who were residing in families with 2 to 4 or 5 plus members, that is less than 0.05 and less than 0.001. And those who were having one or 2 or 3 daughters, and those afflicted with 1 or more physical disabilities and with the advanced age of above 75 and plus, less than their respective counterparts. Conversely, such odds were significantly lower among elders where functional ability is moderate or at higher level, and those who had an house, who were owning a house. While the net effects of the urban residents and the living alone are positive, having middle school, higher family income and economical dependent are negative on their extent of seeking physical care per assistant, but the results are statistically insignificant. Coming to the policy implications, imparting cultural values and traditional values among the adults or younger children in taking care of the elderly persons, and the adults have to be motivated to maintain a good health by following healthy lifestyles, so as when they become older, the physical disabilities and chronic morbidities will become lessened. And the elderly persons need to be encouraged on the importance of saving money and keeping assets and the property on their name till the end of their life. Thank you.
Thank you, ma'am. Thank you for the very good presentation. So I would like to call third presenter.
As the second person is coming in, Dr. Nirmala, please look at your data. I would like to have a discussion later. And what is the effect of girls, on seeking care? Something you mentioned. Maybe I missed out, or if you want to get more deeper into what does it mean, right? So we'll get into it. Yeah, call for the next presentation. Yeah. Sorry.
So Mr. Mohammed is there. Hello. I don't think he's here.
Is there a co-presenter? Is there a co-presenter there? No.
No, sir.
Okay, only one. Yeah, he's not there.
Okay, so and I would like to call fourth presenter. Are you there? Hello. But I think he's also not there. The fourth presenter.
Also not there.
No, sir, because we are not getting any response from any of the authors.
Okay.
Okay, so fourth presenter is there, Manoj.
Yeah, he's there. Manoj Dakwa.
Yes.
Hello.
Yeah.
Am I audible, ma'am?
Yes, we can hear you. So I would like to welcome you to present your paper.
Okay, ma'am. Actually, I am the fifth presenter of this session.
Yeah, but second and third is not there, and I think, or maybe they're not audible or they are not responding. So.
Are you prepared or not?
Okay, ma'am. I'm prepared. I will share.
Okay.
I will present my paper. Let me share. Is it visible, ma'am?
Yes, visible. Visible.
Good evening, one and all. Thank you for giving me the opportunity to present our paper on Iasp conference. Myself, Manoj Dakwa, and I will going to present our paper on disease and its pattern of hospitalization and outpatient among elderly in India, evidence from LASI. Outline of my presentation. First, I will present our background of the study, then data and methods, then key findings and conclusion. First of all, background of the study. As we know, the age structure of India's population is undergoing a deep left transformation. The elderly population is increasing not only in absolute term but also relative proportion due to the improvement in longevity, reduced lifetime fertility and mortality. As we know, the healthcare demand of elderly are quite different from others. Mortality pattern vary by age pattern, and older adults are experiencing a more significant burden of disease than other age groups. And disease pattern of elderly vary by their age structures also. So a significant difference has been in the utilization of health service by age, sex, and education among Asian countries. So some study has been made to address the mortality and disease pattern, out-of-pocket expenditure, inpatient and outpatient care, and there has been no study of disease and its pattern of hospitalization and outpatient among elderly in India. So this paper aims to examine the disease and its pattern of hospitalization and outpatient among elderly in India. Then data source and methods. Data. The data from longitudinal lodging study in India, OF1, has been used, which was conducted in 2017 to 18 in India, and it was
एक सेकंड मनोज आप ना नीचे जाके जो परसेंटेज है ना फॉन्ट थोड़ा बढ़ाइए
ओके सर
थोड़ा बढ़ाइए बढ़ाइए ठीक ठीक है
ओके थैंक यू सर so it was a panel study representative of the older and elderly population aged 45 and above. And in this survey, a multi-stage stratified area probability cluster sampling design was used, and OF1 of LASI survey covered around 72,000 sample of individual aged 45 and above and their spouses. Then dependent variable in this study, inpatient and outpatient visit are the outcome variable. And in LASI survey, every respondent asked two questions. First one, over the last 15 months, over the last 12 months, how many times you are admitted as a patient to a hospital or long-term care facility for at least one night? And next one is in past 12 months, how many times did you receive healthcare or consultation from a healthcare provider, including home visits? So those individual responded. Response. They did not stay at hospital, and other are inpatients. And those respondent response in last 12 months did not receive healthcare or consultation from a healthcare provider, including home visits. They are not outpatient, and other are outpatients. Independent variables in this study, we will include independent variable, some demographic factors and some socioeconomic factor. Demographic factor like age, sex, type of resident, socioeconomic factor like caste, religion, education, working status, mean monthly consumption expenditure quantiles. In analytical approach, inpatient and outpatient visit can be significantly determined by multiple factors, such as in analytical approach, different type of disease reported by individual respondent were classified into 4 broad categories. First one is communicable diseases, second one is non-communicable diseases, injuries, and fourth one is other diseases. Like the classification of causes of death report India 2001 to 3 for analytical purpose, and this present research is it 60 and above individual included and categorized into 5 broad age group, that is 60 to 65, 66 to 70, 71 to 75, 76 to 80, and more than 80 years. And bivariate analysis was applied to understand the inpatient and outpatient proportion by disease and its pattern among the elderly. And chi-square statistics and logistic regression has been applied to know the bivariate differences and factor associated with it. Coming to the result part.
बढ़ाइए थोड़ा फॉन्ट थोड़ा सा बढ़ाइए फॉन्ट नीचे हाँ और थोड़ा सा या बस very faint.
Coming to the result part, more than 2/5 of the respondent in age group 60 to 65 years, and sex of the respondent more or less equal. Female are 52% and male are 48%, and more or less respondent are equal from all monthly per capita consumption expenditure quantiles, and majority of the respondent complete their 5 to 10 years schooling, followed by 1 to 4 years schooling, and half of the respondents are living with spouse and children, and followed by living with children and others, and 41% of the respondents are currently working.
Please go ahead. Yeah.
Then age pattern of if you see the first diagram, that is pattern of the inpatient and outpatient. In general, pattern of inpatient and outpatient are more or less equal. On the contrary, outpatient is 7 to 8 times higher than inpatient in all age groups. The average inpatient rate is 11.7%, where outpatient rate is 82%. So inpatient rate higher among 76 to 80 age older. On the contrary, outpatient visit higher among 66 to 70 year older. So there was a significant difference of inpatient and outpatient among older. Then coming to the disease pattern of inpatient and outpatient, that is second diagram. Almost half of the inpatient and outpatient suffer by non-communicable diseases, followed by communicable disease and other diseases. And there was a significant difference of inpatient and outpatient visit by disease types. Coming to the third one diagram, that is pattern of inpatient by disease type. So inpatient visit higher among all the age group because of non-communicable diseases. On the contrary, inpatient visit higher among 66 to 70 years older person because of communicable diseases, and due to the injuries, is it more than 80 years older are more hospitalized. And coming to the last one, that is pattern of outpatient by disease type. Outpatient visit also higher in all age pattern because of non-communicable disease, but outpatient visit higher among is it 60 to 65 elderly because of communicable disease. So because of injuries, outpatient higher among more than 80 years older, followed by 66 to 70 years older. So there was a significant difference in all the age group of outpatient visit by disease types. Coming to the major findings, so outpatient care visit are nearly 7 to 8 times higher than the hospitalization rate of elderly. So non-communicable diseases are more common among the elderly, and when increase in proportion of elderly adults, and it will enhance the non-communicable disease burden. So the likelihood of inpatient care is higher among males, and outpatient visit is higher among women when who are currently working. And inpatient rate and outpatient visit increase with increasing mean monthly consumption expenditure quantiles among the elderly because of the higher ability to pay. So there was no significant effect of living arrangement on inpatient care, but outpatient visits are significantly higher for those living alone than living with spouse and children. Coming to the conclusion portion. So the older population will increase in near future in India, that create pressure on public health services. The public health system must ratify shortly to meet the demand of this section of the society. So the uses of private healthcare is very high in India, which promote the inequality of healthcare utilization because of the ability to pay healthcare expenditure. The requirement of long-term healthcare may increase the burden of the healthcare service utilization among the elderly population. So some socioeconomic and demographic characteristics also play an important role in access to healthcare services for the elderly in India. And affordable health service and quality development are the major tasks for the Indian public health service, and it will ensure the quality access of healthcare services among the elderly. So there is a need for collecting detailed and quality data on disease pattern, health services, and expenditure in India. This is the reference. Thank you.
Okay, thank you, Manoj. Thank you very much. So next, I would like to call Sripati and Dr. Sen Gupta for the next presentation. Hello.
I'm here, ma'am. Am I audible?
Okay. Yeah.
And also, Dr. Mohammed has come. We'll give him the opportunity next.
Okay, sir.
Can you see my screen?
Yes.
Yeah. So good evening, everyone. Thank you for giving me an opportunity here. I have made this research with my professor. Dr. Rangan Singh Gupta is my professor, and we have worked together for this research. And the title of it is Life of the Elderly During COVID. Can you see the next screen? Just a second. There is some issue. Yeah. Can you see the screen now?
Yeah.
Yeah, so the introduction, it's basically about, like during the COVID-19 lockdown, there were many effects, not only on the elderly, but on many other people. There were various socio-demographic groups which were affected, out of which the elderly were the worst affected one, because they were already vulnerable. Most of them were vulnerable with one or the other issue, be it diabetes, be it respiratory illness, or be it any other issues such as BP, anything like that. They were the more ones who were vulnerable to during the time of COVID. And this study attempts to understand the impact of their lives during that particular COVID lockdown period. So this is the I have done various literature reviews, and this is the outcome of those literature reviews that I have understood. The key issues that most of the elderly were facing were not only physical, but it was also psychological, as one of our presenter mentioned earlier. Psychological is very dangerous, and yeah, the elderly, they were affected very badly, and most of the elderly are dependents. Like when you consider people about 70 plus or 80 plus, they are mostly dependent upon the caretakers or whatever they are mostly dependent is what I mean. So they had many situations, like people can be lonely, or they may be depressed, they may be facing depression, or they may be fear of contracting virus. You have heard few stories like people were so scared that they have locked themselves in rooms for so long during this time of COVID. So yeah, that thing. And there was strict lockdowns in a few of the areas where there were no caretakers who were to take care of the elderly people, and all the burden of the house chores, all that thing have fallen on them. Where most of the people are not technically savvy, right? The old people are not technically savvy that they order their own medicines, yeah, order the food for them. They have to do it on their own. So yeah, that had an thing on them. And most of the elderly, few of them have lost their socialization. There is increase in anxiety. There has been loneliness that has created mental strain, depression, fear of contracting the virus, isolation, increase in mental problems, and many more of such. So the main objective of this research was to understand the positive as well as the negative attributes of the elderly life during the COVID-induced lockdown period. So the data, we have done an in-depth interview where it was conducted through an open questionnaire where we were asking them about their family members, knowledge about COVID, how they maintain their active aging, like were they doing any exercise, yeah, how were they actually maintaining it, the relationship pattern within their family members, the social network, be it their medical needs, any other needs, the psychological issues that they are facing. All of such questions was made into a questionnaire and given to them. The interview were done through both telephonic and in person, as it was done during the between the first lockdown and the second lockdown that was happening. I mean, the first wave and the second wave. So we have collected a sample of 29 individuals. It's a very small sample, but yeah. And where the females' age was about 55 years and the males were considered more than 60 years were considered for this research, where 12 male respondents and 17 female respondents were there. And most of them were from urban area with the mean age of 69.8 and 66.9, as you can see. So the methods, we have done a content analysis to identify the themes from shared experimental accounts of the elderly respondents and identified the most common themes that were coming out as emotions, perceptions, attitudes, and behavior that you can see. And the family members of the elderly have been classified as old elderly members who stayed with their children, and third one was the ones who reconnected with their family during the lockdown. And yeah, these were our results. Firstly, the elderly members, especially the males, they were mostly exposed towards COVID situation because the research was done mostly on basis of Telangana and Andhra Pradesh people. So most of them, the females, they are old age people. They are females were mostly in the house where the males had to go out, get stuff for them, be it medicines, be it vegetables, all that during the morning and the evening. So they were more exposed to the situation, and they were hesitant for using online platforms for shopping. They are not that technically savvy that they use because they were in their own place. They were not dependent on anyone. Yeah, they did not reconnect with their families. We are talking about those people. And about the people who could reunite with their family, they were more happier. And female respondents whose children came back to them during the lockdown, they were even more happier, and they were literally thanking the government for extending the lockdown. Many of the people had to come back, go to their native places for during the lockdown period, as it was not suitable for them to stay in the places that they were. And yeah, India, spirituality is considered as one of the bigger practice where many people believe in God, but during COVID, even that could not, maybe, yeah, it helped, but not completely, right? So yeah, that point is being highlighted there. And yeah, the lack of household support has become a serious concern for them, where they had to take care of every house chore, and the health conditions were also taken into consideration because elderly are already it's considered that they have problems within themselves, like ankle pain, yeah, knee pains, and all. With all that, they were working for the house where they had to take care of it, and the community or the family members were providing support to them remotely. So many of them stated that taking care, like people like me, I went to my grandparents' place where I was completely in my college where I had to study. But during that time, I went to my grandparents' place where I had that complete meaningful time with them, where I've engaged. I got to know a lot of stories from past things. So yeah, it was good for me as well as for my grandparents as well. So they had a regular pastime activities where the psychological pressure on them was less because we kids were in front of them. And we had found that most disconnected females were more discontented, and males were going out of the house for basic needs, the risk assessment and precautionary behavior varied extensively and had a gender dimension. Like male members were more adventurous in the sense, like they go out, get all the groceries for the house and all, where females were comparatively risk averse, and the presence of the children has been happy for them in that environment. So the synopsis of the result is that we have classified them into three, right? So the elderly members who were staying alone, they were not tech savvy, they were critically exposed, and things like online banking, shopping, medical facilities, that has become a problem for them. Other than being exceptionally defenseless to the infection, their advanced age has additionally made it hard for them to drive and mingle, adding to their depression and nervousness. And secondly, those whose family returned back to their native and started staying with the elderly parents, they were more happier during the lockdown, more engaged, and spending time has not been difficult for them, and spending time had made them even more happier during the lockdown. And the final one is the risk assessment and precautionary behavior varied extensively and had a gender dimension, meaning the male elderly respondents were found to be more confident about the knowledge related to COVID, where But yeah, they were more bored, irritated with the lockdown, and that they had to stay in the house. They can't uh, specifically go outside for the purposes that they used to go before. Female, they engage themselves spiritually for the TV shows and etc. So the conclusion of this study that we have done is that, yeah, as coin has two sides, there are both positive and negative impacts on the elderly member, where the family structure has played the most important role in determining the psychological status of the elderly. So these were the articles that I've used for my literature review. These were the references. Thank you.
Thank you, Sfurti. We have finished within time. So I would like to call next presenter, Mohammad Rana. Are you there? Hello? No. Hello?
His name was there. No. Yes, he's there. Dr. T.
Okay.
Muhammad.
Okay. So
Dr. T. Muhammad, you're there. Where are you?
Yes, sir. Yeah.
No, it's your
So
turn.
sorry. Yeah. Can I present now?
Yeah,
Yes,
yeah.
yes.
We are waiting for the last half an hour for you.
Sure. Hi everyone. My name is Muhammad. Sorry. Good evening, everybody. My name is Muhammad. I'm a PhD candidate at International Institute for Population Sciences, Mumbai. Here, I'm delighted to present a paper on the depression and cognitive impairment among older adults, which is associated with the spousal death. And here we examine the widowhood duration, which does matter or not. As all we know, depression in the older ages is a significant public health concern due to its association with higher levels of disability, mortality, morbidity, and healthcare cost, as well as quality of life. So we know that similarly, the cognitive functioning, which includes the memory, execution, and all, is a vital aspect of healthy aging, which enables the older individuals to sustain better psychological well-being and independence in later life. Generally, women are more likely to survive their spouse's death due to general gender differential in age at marriage and higher mortality rates among men. Seeing the previous studies, we see that the studies report a trajectory of psychological distress and adverse mental effects due to widowhood, which appears to follow a crisis model, with distress peaking shortly after the widowhood and gradually diminishing with time. In this study, the objectives are to examine whether widowhood is associated with depression and cognitive impairment among older women in India. Also, we investigate the extent to which widowhood duration, living arrangement, employment status, social participation, and other socio-demographic factors are accounting for this sort of association. So for this study, we are deriving the data from the longitudinal aging study in India, which was recently released, which is a baseline wave conducted during 2017 to 18. So the LASI data, it contained 52.02% of the older women, which adds up to 16,366 older women in India across all states and union territories. Thus, the effective sample size for this present study is 16,075 older women who are aged 60 and above. Nearly 291 cases are dropped due to they are belonging to the separated, divorced, or never married women category. So for the analytical purposes, we use the descriptive statistics in the initial stage, then the cross tabulation along with chi-square test to see the to find the significance levels among the possible associations between the variables. Additionally, a binary logistic regression analysis was used to establish the association between the outcome variables in this study, which are cognitive impairment and depression, and widowhood duration along with other explanatory variables. Coming to the detailed measures of the outcome variables, we are taking two outcomes here, which are namely cognitive impairment and depression among older women. The variables are coded as binary in nature for the analytical purposes, and the details are given in the paper, which is cognitive impairment we measure through 5 broad domains of memory, orientation, arithmetic function, executive function, and objective naming, which are measured among all the older adults in LASI survey, which was taken from the HRS module, the Health and Retirement Study in US. Then the cognitive impairment in our study is based on these measures, including immediate word recall, which has 0 to 10 points, delayed word recall, and orientation related to time, place, arithmetic ability based on serial sevens, computation, backward counting, and executive functioning based on paper folding, pentagon drawing, and object naming. So adding all these scores into a 0 to 43 score, we computed a composite index, and the lowest 10th percentile of this index is considered as a proxy measure for cognitive impairment or poor cognitive functioning among older women. Coming to the second outcome variable of this current study, we have a major depression among older adults, which was measured through an internationally validated scale of short form composite international diagnostic interview, CIDISF, which has 0 to 10 score, and we are taking a 3+ score as those who are having depression or major depression. This scale estimates a probable psychiatric diagnosis of major depression and has been validated in field settings and widely used in population-based health surveys. So the explanatory variables, we have several variables, and the key variable is widowhood duration, which was coded as currently married, widowed who are just widowed for 0 to 4 years, and then those who are widowed for 5 to 9 years, and then those who are widowed for 10+ years. In this study, age was coded as 60 to 69, 70 to 79, and oldest old, who include those who are 80+. We have educational status as categories of education, no education, primary, secondary, and higher. And then other covariates of this study include living arrangements, marital status, social participation, life satisfaction, ADL and IADL limitations, which measures the functional health of the older adults, and then the household characteristics such as MPCE or the monthly per capita consumption expenditure, religion, caste, region, and place of residence. Coming to the results from the analysis, we found that around 36% of the older women were widowed for more than 10 years. 25% of these older women who suffered from cognitive impairment were widowed for more than 10 years, whereas 14% of the older women who suffered from depression were widowed for at least 4 years. Older women who were widowed for years, more than 10 years, were 43% significantly more likely to suffer from cognitive impairment in reference to the older women who were currently married. The older women who were widowed for at least 4 years were 2 times significantly more likely to suffer from depression with respect to the older women who were currently married. Coming to the detailed results of the study, in this table we show the profile of the current sample population. We have 36.4% of the older women as widowed, whereas 44.6% as currently married, and 9.9 and 9.1 as widowed for just for 0 to 4 years and 5 to 9 years. And we have 1,829 older women who are aged above 80. And as generally known, older women in the study are mostly uneducated, like 81.5% of the total sample are either uneducated or having less than primary education. So coming to the bivariate analysis or the results of the bivariate analysis, we see that those who are currently married are having the least cognitive problems or cognitive impairment and depressive symptoms. Whereas those who are widowed for more than 10 years are having the highest cognitive impairment, which shows 25.2% of the older women who are widowed for more than 10 years are suffering from cognitive impairment. On the other hand, in case of depression, it is somewhat inconsistent, where we see those who are widowed for just 0 to 4 years or just widowed are suffering from the highest levels of depression, or the major depression is higher among those who are widowed for 0 to 4 years. And it is declining by the widowhood duration, whereas the cognitive impairment is the otherwise, which shows the increase by widowhood duration. And coming to other covariates, age shows that older adults who are above 80 are those who are having higher cognitive impairment and higher depressive symptoms. On the other hand, interestingly, the education so shows that the association with mental health outcomes shows that those who are uneducated or not having a primary education are cognitively impaired much higher than the other categories, and they are also much more depressed than the other categories of educational level. Coming to the multivariate results of the current study, we see that those who are, after adjusting for all the variables which we have mentioned in the variable section, which we have mentioned in the measure section, explanatory variables, which include household, individual, and health-related variables, we see that those who are widowed for more than 10 years are having higher likelihood of suffering from cognitive impairment or having cognitive impairment in comparison to those who are currently married. In case of depression, it is the otherwise, where we see those who are widowed for just 0 to 4 years are having the highest odds of, or higher odds of suffering from depression in comparison to those who are currently married. So the major limitations of the current study include the cross-sectional design of the study, by which we cannot infer causality from the estimates of this observed associations. Similarly, the analysis did not take into account the non-married partners, or whatever we dropped in the as a missing case, or as in the data selection, and information on earlier marriages of these older women, then quality of the marital relationship and causes of spousal death and caregiver status. These were not considered for the current analysis. This might be the limitation of the study, and it could suggest for the need for further investigation on this topic. Moreover, we were unable to adjust for pre-widowhood mental status, which is likely very important for assessing determinants of health outcomes following the spousal death. Also, it provides a clear support for the idea that becoming a widow may immediately lead to having depressive symptoms and gradually resulting in impairments in cognitive functioning, which may have major policy implications, which adds to the strength of the study. Also, the data set for the study was from a large population-based comprehensive survey with a detailed assessment of depression and cognitive impairment, which is also the major strength of the current study. Similarly, the richness of the information which allowed us to obtain a thorough understanding of various aspects associated with mental health outcomes among older Indian women by their state of marital relationship may add to the policy implications. To conclude from these findings of the current study, we can say that the study highlights that widowed older women are disadvantaged with respect to the duration of bereavement that leads to worse mental health, both in the short and long terms. They join the previous studies. The findings are consistent with the previous studies on the association of several socio-demographic and health-related variables with depression and cognitive impairment among older women. Incorporating information on marital status into the design of intervention programs for aged population may help better target the potential beneficiaries. Further, future research of widowhood-associated cognitive impairment and depression should focus on specific subgroups at greater risk who are with a focus on gendered pathways to widowhood, which may include the older women as well in their suffering from mental health problems due to widowhood and the changes as per the widowhood state, the duration. That's all for now. Thank you.
Thank you, Muhammad. So, do we have another presenter? Mr. Alok Roy?
He's not there.
Okay, sir. So, we'll call for the discussion now and questions.
Yeah, go ahead.
Okay, sir. So, if anybody have any query or question or any doubts about the presentation, please ask your question.
Okay, let people think of the questions. See, I think one of the important things of these presentations is not to just make the presentation and see your name on the program and add it to your CV. No, that's a very diminutive way of going about it. You need to hear the presentations, find out what is it that you have inferred, what is it that you want to. That's very important. So let us start with as I had said. Let me also give a hint to the others. I had already told Dr. Adinarayana. I'll come back to him. Muhammad, I want you to later elaborate on your recommendation of design of interventions. How does it have an implication? And what do you actually mean by design of interventions? Okay. So now let me start with, let's do like this. Let's go, I'll pose the first question to Dr. Adinarayana, and then, we'll then go to the other presenters. And if others have questions to Dr. Adinarayana, they can, pose it now. So Dr. Adinarayana, you're saying on living arrangements, what is the implication of, living arrangements? What is it that, could be thought of in terms of, policy implications or programmatic implications? Can you throw some more light?
Good. Nice question, Dr. Mangishan. So the idea is the majority of the elderly widows nowadays, what happens is they will not be taken care by the children. Because husband is not there, over a period of time, they will also slowly thrown out of houses. That is what is happening. And here the variable has been dichotomized. That is, those who are living alone, I think it is around 33%, if I remember well. 33% of the elderly widows are living alone. And others we have categorized as those who are co-residing. It may be with sons, daughters, and others. Okay, these are the criteria. Well, as you said, the idea is how far the living alone are suffering or not. That's why the number that is what is the score is 1 is assigned. Living alone purposely has given highest score and tested in the analysis. Strictly speaking, policy-wise, whether they are going to have any psychological depression or not, that's what trying to see here in this. So, fortunately or unfortunately, the results are not that much statistically significant, of course. But at the same time, the bivariate analysis, I didn't show the tables to your good self. Even the multivariate analysis table also has shown that they have lesser psychological depression, distress. That shows that once they are psychologically strong, the other way, see the cause and effect, the reverse causation effect, we can say here. Those who are psychologically not that much depressive, they are likely to give live more as alone. So that is what happening. So we have to, policy-wise, if you take, I think we have to inculcate the boldness and other things among the elderly widows. Of course, the other paper now, just now shown by the Muhammad, impressive that duration of widowed also has to be taken.
As an effort.
Generally, in the initial stage of 4 to 5 years, the depression or what you can say, psychological distress also will be more.
No, good that you related that. In fact, I was just about to, say that the paper that Mohammed presented, interesting that the cognitive, the depression actually, goes down with increasing, increasing
in this research also, the duration is available. We will try to see how it will affect.
No, it's an interesting. I think one of the things, which is important for us is to look at the huge number of poor who are living alone and the need for, the CSR and government to start, old age homes or care homes or whatever you want to give it a name in a big way in the country. This is very much needed. This could be one of the straightforward things, because living arrangements seem to have a very major impact. Anyway, that is good. So, any other questions to Dr. Narayana?
Can I add upon Dr. Venkateshan? So, in this sample, what happened is, you see, in Puducherry, the all widowed women, of course, invariably widowed women are getting social pension or social welfare pension, isn't it? The money is a little bit higher side. It is almost around 3,000 rad. 3,000 up to 3,000.
Far better.
So as you said, I think the next stage, that is the CSR, etc., coming into the picture, it may be taken very late, I think, because economic security is the more important one. So that way the government is protecting. As far as
and also, if your results can show how living arrangements, if living arrangements and by age, how it is affecting, so then there has to be also differential payment, for
women, it is there.
Which currently is not practiced. Everyone gets the same amount. No, 3,000 rupees or whatever is 1,500 somewhere. And
yes.
So those are also very important things. You see, at the end of the day, these are very good studies, and we need to come up with implications. It's not publishing in a, we can publish in all fine. Very good study. Any other comments? Any other questions to Dr. Adinarayana, the very senior researcher? Okay, I don't like this type of a where there are no questions. But anyway,
don't worry. All the clarification suggestions also welcome.
Anything. Any
we are exchanging ideas.
We need discussions actually, not presentations.
That's good.
Okay, next one, Dr. Vimala, what's her name? Nirmala. Yeah, good presentation. I wanted some, this thing on girls taking care. I think girls' effect on care, something you had mentioned. What is that? Is there any, can you throw some light? Are girls becoming more caretakers of, Can you just throw some light, madam? Hello, Dr. Nirmala, can you unmute?
Yes, sir.
Did you hear me?
Yes, sir. There was a power cut in our area, sir. There is heavy rain in Pondicherry.
No problem.
Yes, sir.
So what is the effect of, girls taking care of their parents? Is there anything significant that you are bringing up? I heard something I didn't.
Yes, sir. Actually, the girls are more taking care when the mother or when the elderly are sick. They more than physical care. The son or the daughter-in-law gives, sir. But mental care, the daughters are the more to give mental support for the elderly, sir.
Is it significant?
Yes, sir.
Okay. That's a good. That's. I think one key takeaway from your study seems to be that, given the patriarchal society and the role of boys as the utmost importance, your study is giving a very different flavor, or a new flavor, I would say. Any other questions to Dr. Nirmala before I make a suggestion to her? Dolly ji, आपको भी, you are just not to call people to presentations. कुछ पूछिए लोगों से. चलिए next वाले के लिए तैयार कर लीजिए आप. Okay. हाँ, Nirmala के लिए we don't have. So okay, what I thought, no, Nirmala, Dr. Nirmala.
Yes, sir.
uh,
Yes, sir.
Now that you are in Pondicherry, not
Yes,
in
sir.
Jaipur, you should call a few journalists and present your key findings. Your key findings are very interesting, actually. You know,
Yes, sir.
you need to share that this new thing that you are bringing up, that girls are becoming the caretakers for, parents, and not the boy and the, family, is something that you should highlight. See, from every study, only one, aspect gets highlighted, not, the sample and methodology. Those are for us. But for the
Yes, sir.
media, it's one. For you, there is a very good, pointer that you have. So you should
Yes,
call
sir.
a few people and share your report, and have Dr. Adinarayana make also some comments, and you should do all these things, because without getting to the media, hardly 6 people are hearing, and maybe some people will read your paper. So you have a good paper there. Anyway, any questions to Dr. Nirmala? No. Okay. Dr. Dali, kuch pushenge aap?
Yes, sir. Yes, sir. I have a question for
हाँ,
Mala. So, in her finding, she found that daughters are providing psychological support to the parents, and son and daughter-in-law are economic and physical support to the parents. So I think there is a north-south difference because in north mostly parents are like to stay, not with their daughters. Okay, so if she found any literature to segregate that, it is very interesting actually. So,
Dr. Nirmala, no, there is no big difference between north and south. The patterns are the same as in terms of social positions and family living patterns. But anyway, you have posed a question. Dr. Nirmala, are you there? No. Dr. Adinarayana, you want to comment?
Yeah, I want to add that I am waiting for that. Thank you.
Boliye, sir. Boliye.
The thing is, you see, added upon to your comment, Dr. Srinivas Venkateshan, the daughters, actually, she has observed in her paper seeking physical care and assistance only. Please try to, because as Dali has slightly overlapped psychological, her answer also was wrongly wrongly given. Strictly speaking, this is physical care and support. Well, as you said, the daughters are coming up nicely. The suggestion given by you is well taken. I think she has just completed. Last month only awarded the PhD. Your point is valid. I think results have to be reached. If I am in Coimbatore, I might have done easily. Now I am in a little place like Tirupati. Difficult to do.
But Dr. Dali is asking this question: is there any difference between the north and
Yeah,
south?
she has north-south differences will be there. In fact, the south women are little bit bold, isn't it? They may not depend that much upon the daughters, strictly speaking. But the cultural and traditional attachment towards daughter is more compared to sons. So in that way, this can be argued that the daughters are more attached to the elderly woman, or the other way, elderly women are seeking physical care more, because mostly they will be nearby only. You know the marriage pattern in southern places. Mostly they are nearby only. So due to that, I think they are giving more. They are seeking more physical care and assistance from daughters. Of course, availability of daughters is one of the important things.
That's a different thing. Yeah,
Sons may be living mostly outside of the city, or mostly migrated, or not. Daughter-in-law may not allow to help by son. All these intricacies are there. You may be knowing very well. Anyway,
Yeah,
nice,
another thing.
Dr. Gali.
Another thing, Dali,
Please.
is that there is a transition in the familial system in the south, whereas in the north, or I'll give you a comparison. In the north, you're still, the parents of the girl will never go to the, daughter's house and have a meal and so on. Those type of practices have now gone in the south. We do not follow those, जाके रहते हैं and so on. यहाँ पे तो जाएंगे पानी भी नहीं पिएंगे, and all those type of things have changed. So वो यहाँ पर भी, आ जाएगा 10-15 साल में यहाँ पर भी. improve हो जाएगा. Anyway, so shall we move to the next one? Let's give opportunity for everyone to say, on Spurti. What's her name? Yeah. Are you there? Yeah.
Yes,
A good presentation on COVID. Let me give Dolly your impressions on this paper.
Okay. Sir, I think this paper was nice, and the interesting finding was that though COVID poses very difficulty for the people, but somehow it is good for the older people because they got the opportunity to meet their children. Okay,
yeah. So I think to me you are right. In fact, what I would suggest, this is a good, interesting paper. I just last year, when I was still in UNFPA, so I had supported HelpAge with almost 500,000 grant to take care of the needs of the elderly, across the country. There are a lot of problems. Technology is a problem for the well-off, but for the poor, it is a different set of problems. As you had mentioned also, Smriti, that mobility was a problem, and then health was a problem. I remember my mother, when she was in Bangalore, the help had stopped coming because they were being beaten up by the police. Then the Ministry of Social Justice issued an order that people, caretakers, should be allowed to go and do their duties for the elderly wherever they are employed. So they were giving the relaxation. So what I would suggest is she there? Is this young person there? Murthy?
Yeah, she is there.
Okay, yeah. I think, this is a very good study. You should, do a small synopsis. God forbid we don't have a third wave. We don't know. It's hitting Europe and other Africa and so on, very badly. So just do a small synopsis and send one letter on your findings to the Secretary, Ministry of Social Justice. Why I'm saying this is that in the last few months, all of you should be knowing that there are a lot of movement in the Ministry of Social Justice on aging.
Yeah.
And this is due to a secretary who's currently there and he'll have a few more months. Who's supported the private sector, who's supported, who's going to start something on motion for the elderly and so on. So, send your key findings so that there are, for whatever it is worth. See, what happens is that young researchers, your work should be known outside. A person like me, how will I come to know? I have to either be on these meetings or someone writes to me, I'll look at it, okay, this girl lady has done some research, interesting. Maybe the next time if I have something, then I will call upon this person to come and make a presentation or so on. So you need to be, your name should be in circulation. Your name should be in circulation not only through your publications, which is a very academic thing, which is needed, but let us say NIST. You write this letter, with a synopsis of the key points, not your methodology and so on. What is the findings? What is the recommendations for anything in the future? And send it off to the director NISD. And I hope you know what NISD is. And send it off to the Ministry of Social Justice, Secretary by name. For whatever it is worth, yeah. Are you hearing me?
Yes, sir.
Yeah. Okay, you put up your camera. So send it. Don't worry. No responses, koi dikkat nahi hai. Problem ledu. Or letter last same problem avadu. Okay, write letters. Communicate. This is very important. Unfortunately, in our country, we don't have a course on communication of results, research results, which is done, very prominently outside. So you should do your research and be able to communicate, or else what is the point in doing research? Yeah, you can become an associate professor, वो सब तो ठीक है. लेकिन जब तक आप नहीं, if you are not communicating your results, it's not of much value. Good study. You know, any observations? Dolly to bata diya. Dolly. Anyone else? What are the other participants? Yaar, kuch to pucho baki logon se.
Venkatakrishnan sir.
सर बोलिए. अरे आपको तो आप तो बाप को तो बोला ही नहीं है. आप तो इतने young people कहाँ हैं? Where are the young fellows? Yeah, go ahead, go
They
ahead.
are not asking, you see.
I feel bad. बोलिए sir.
Now your discussion reminds me one small incident to share with you. Just 2 minutes, okay? I have completed my PhD in 1985.
Okay.
At Sri Venkateswara University with Professor Mahadevan. So those days, you see, I was working in IIPS, so I presented and completed and asked my guide, okay, sir, I am leaving to IIPS. He said the incident like you, Hey, Baba, one more work is there. What is the work? The work is to Xerox, of course, those days even Xerox is not Roneo mission. So we make a Roneo mission of, copies of 2 copies and send it to PMO office. I was wondering, what is this PMO office? Who will read by? So he was telling, because at that, my topic of research at that point of time was age at marriage of girls and boys in Andhra Pradesh. And you know, still Andhra Pradesh is lagging behind among the south states. The child marriages are very rampant. So the argument goes, Arey sir, what is you are telling? He was telling the same story like you. See, there are secretaries are there. They are meant for that. At that point of time, the discussion was going on whether to increase the age at marriage of boys and girls to or not. You may be believing or not, even now, those ages are not disturbed at all. Okay, so he was telling that they will read. Definitely they will read. At some point of time when discussion comes in Assembly or Rajya Sabha, they will place it. That's what his argument. You know, congratulations to Dr. Spurti Reddy, very nicely done. And I was also thinking about to congratulate you. Only thing is, what is the sample size? I forgotten or you have not?
Very small, so 69.
Huh?
Very small, so 69.
No, don't worry about this. You tell me, what is the
29,
sample size?
29.
Don't worry. That is ideal because
not
we have
bad.
done a qualitative study. Don't worry, because these are all things which Dr. Venkatakrishnan is encouraging. You see, the small things only will be a big ocean. Thank you for the opportunity given.
Good. No. Good. We should hear Dr. Adinarayana, who's a veteran, and it's important. We need discussions in these sessions. It's not just presentation and running away. Muhammad, the paper of Dr. Muhammad. Comments from others. Dolly, Spurti, anyone? What is it that you have? Very good study, by the way. Yeah.
So, sir, I have a question. Since he has done a duration of widowhood, but I think my observation is if he could include the age at widowhood, I mean, when she or he, I mean, I don't know, male or female, when the women become a widow, because I think if at early age, if she become a widow, so psychological pressure is there, but cognitive impairment is maybe less. But by increases, if maybe a woman at her 60s, if she is widow at 60, maybe she faced both psychological and physical, cognitive impairment and depression both.
Muhammad, you want to respond?
Yeah, actually, the whole objective of the study was to see the differentials in this cognitive impairment and depression. So what we have found, even we have other studies which examines the complexities or the associations between this depression and cognition among older adults. There also we found that this depression can be a prodrome, or what we say as a precondition of these cognitive problems, cognitive deficits. So seeing these differences in this cognitive functioning and depression among older adults, like after getting more of widowhood duration in the increasing the widowhood duration, older women are getting more of cognitively impaired, but then depressive symptoms are reducing. So here, what we have to, as per the Srinivasan sir already suggested, talked about the recommendations of the study. I would say that in my understanding, we could develop a strategy to address the problems.
Just hold before you get to that. Just hold. Yeah, just hold. You're answering Dr. Dolly. One thing before you get to the interventions. See, I think to me, depression as the widowhood, the duration increases, it is reducing, whereas cognitive impairment is increasing. I don't think there is much of relationship between, widowhood and cognitive impairment. Rather, it is an effect of the life. After all, the age is also increasing. So the cognitive impairment will, anyhow increase, whether they are widowed or not widowed. There might be some, factor where there is widowhood and age, and if you can segregate it and see if widowhood is additionally creating any more impairment than for people who are not widowed, what is there, then it will be interesting, which is not part of your study. So to me your study is not so great in terms of any result which says that cognitive impairment is increasing with widowhood. I don't think, because that is related to age to me. But on the other hand, depression is very interesting. What's happening is that women are settling, in the phase of widowhood, and the depression is reducing with widowhood. The age, after 10 years or 5-7 years or 10 years, whatever was that. So that is very interesting, aspect of your study, which is the most scintillating or important, important inference in your study. Okay, so that's what I wanted to make that observation. But if there are any other questions, we will take, or else.
Can I add to this? Just
yeah, no. 1 second. I'm giving you the opportunity. Please explain. See, one thing you should, others have also done that without naming anyone. But you are a young researcher, I can tell you. See, don't come up with implications at the end which are not related or not well explained, by your study. There can be recommendations, but be a bit more elucidate on what you mean. Someone had said, expenditure, should increase. So have you done, what was your analysis? Did you do any analysis or economic aspects that you are talking of? I didn't see that. So what I'm saying is that always give your recommendations first based on inferences, and wherever you are giving a new recommendation which you think is important, that's your prerogative, please explain a bit. So therefore, you have talked of design of interventions. Can you explain to us what do you mean by what interventions are currently being offered, and how we could revise the interventions or redesign the interventions as you are suggesting? Yeah, Muhammad.
Yeah. So as we have found that the depression is much more problematic among the widowed in their early periods of widowhood. In my understanding, I feel that we can recommend that the mental illnesses have to be more addressed through the clinics, or wherever the older women are approaching for their chronic conditions, or they are getting hospitalized for any chronic conditions or illnesses. There should be some strategy to address their mental illnesses as well. So in the clinics, wherever the clinics are located, there we can make some more mental psychiatrist and.
Very good. This is the type of specific recommendations you should make. So what does it mean? It means that there is a program for the healthcare of the elderly, and you should have gone and seen what does it do. Probably it doesn't do much on mental health. So then your recommendation, even without going through also, you could have made a more detailed, more specific one, which is very good. I congratulate you for thinking on these lines. And I also request you to pursue research in this area in terms of looking at, the effects of programs for the elderly. What does it look at? What does it take care of? What is the relationship with your Lassie inferences or others who have worked on Lassie? And, So yeah, there is another 7-8 minutes. So yeah, thanks, Mohammed.
Thank you so much.
Dolly ji, कुछ है आप हो गया आपका? Has he answered to some extent? Yeah. 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 Okay, Dolly is not audible. Yeah. Dr. Dolly, are you okay? Okay. Next, we have one more presentation we missed out. There was one on Lasi. You know, who had made that? I'm forgetting.
Dakwa sir.
Third वाला. Third किसका था? Third हमने जो दिया था?
Yes, sir. Manoj,
Sir. Fifth sir, now fifth.
हाँ, मनोज का. मनोज, यार एक चीज बताओ, आपने इतने सारे recommendations दी last में. How many of them are related to your study? And I'm not putting you on a spot, but just to, because you are a young researcher, you should look at, and can you relate your, the recommendations that you are making to the analysis that you have undertaken or the inferences you have drawn. Currently working, you said, can you throw some light on what is the percentage of of the respondents to your study, or the are currently working? Because a few months back I was looking at the Manrega data, and I found that even 80 plus, there were 15 lakh people in the country, though it's a small figure as compared to but still it's a very bad figure in terms of 15 lakh elderly were asking for job cards, or had prepared job cards, or were having job cards for Manrega. So it means that 80 plus are still working. So anything that you had, I had just noted down something on currently working. What is the percentage of people in your sample that are currently working?
41% of the respondents are now currently working.
And what age groups are they? If you bifurcate,
60 plus, 60 and above.
Yeah, 60 and above, 99 tak bhi hai, but I'm asking you in 60 to 70 or 70 to 75, 75 to 80, ऐसे करके बताइए. नहीं आपके पास है.
Sir, मैंने नहीं देखा ये.
Okay.
How many?
See, these are the type of things, 60 plus, yeah, everyone is working nowadays. Definitely the poor are working till 70, but are they working even beyond 75? What percentage of your sample is working about beyond 80? Because this is a very important finding of can be an important finding of your study, that still the poor are working, to make ends meet. And this could be the most highlighting, aspect of your study, wherever you present. Yeah, and therefore the need for, what is happening with the Ministry of Social Justice. They have opened a site. आप लोगों किसी को मालूम है क्या कि they have opened a site for opportunities for the elderly. They are linking the the companies, or people looking for and the elderly. There is a site that they have opened. So what it means is that the elderly poor are still working in India beyond 65, yes, beyond 70. So which is fine to keep them, their cognitive, faculties, but good. But it's not a very healthy sign, because they are dependent on themselves for their daily living. So if you have any, if you can dig a bit deeper and see of this 41%, what is the bifurcation, or what is the, this thing of people in different age groups that are working? Yeah, that will be useful. Yeah. Anything, yes, Dr. Adi Narayana, overall, Baki, you are also a, co-chair in a way.
Not necessarily. A very nice discussion is going on. You are putting forth more and more insights into the elderly, of course. I remember another incident. Just day before yesterday, I had a talk with what is that? As you said, the HelpAge India, the Madras School of Social Work, and Social Justice Department, the ministry. They have come together, and a state policy for elderly is coming up in Tamil Nadu very soon. State policy for elderly in Tamil Nadu. That's a good sign. I think most of these points were covered. Of course, I am going to give some more inputs, my inputs by another 2 days.
Very good.
So I remember your discussion with you will enrich some of these points. Okay, that's a good idea of attending this session. And of course, all young chaps are doing nice work. We are not denying, as you rightly pointed out. I think this has become a habit of youngsters to by oversight, or we don't know. Even when we attend a PhD Viva. It used to be common. All these things will come into picture. So we used to tell vehemently that only link with your findings. That used to be happen, of course. Well, otherwise the paper by Makwa and others, they have done very good work actually. Given the large size of data in their hands, more things may be done. I have one more suggestion to Muhammad. I think Dali has asked about the age and widowed duration. Strictly speaking, these two will interact. After some time, what happens is the age and duration of widowhood will interact. Instead of doing that, I personally feel, say 0 to 4, 5 to 9, and 10 to 14. That is the duration, 3 categories he has taken.
Widowhood, yeah.
Given the large size of the sample, is it possible to independently do the regression analysis by age group wise, the duration wise, so that any factors changing over a period of time, controlling for this, that can be observed? A small suggestion. If Muhammad takes in right perspective, I don't know who is his guide. They will take care, I think, if he is doing his PhD. Very nice.
Any thoughts,
Thank you.
any thoughts, Mohammed? Quick thoughts before we,
Yeah.
conclude this.
Thank you. Thank you.
In the multivariate analysis, we have also seen that the same pattern is already there.
Achha.
So we thought of doing this interaction analysis, the moderating effect of this age in the association of widowhood duration and mental health outcomes. That also has some sort of same patterns, but that can be another area of study which we can do here.
Good.
Very good. Good that you have taken on board Dr. Adinarayana's, thoughts and suggestions. Thanks, Dr. Adinarayana. KVR. Yes. Yeah. KVR. Yeah. I wish that you had more, participants. They are only presenters and chairs and co-chair. So in this session, so KVR, as the organizer, he's there. He's opened his mic. So I'm just giving a suggestion, just on maybe a lighter note, but on a serious note as well. So we should have more young, people to come and listen. They're all very good studies. Anyway, thanks.
Sir, if we have time and give me a couple of minutes.
Please. क्या दिक्कत है?
Although I'm going to all halls to see the attendance, so I came here a little late. So one thing, but just when I entered the nice discussion about the young old and old and their work participation, I heard a paper by in the afternoon by one Shyamala from Karnataka also, talking about the labor force participation of the old people. So it is very, these things are coming interestingly. Only thing is that it is, I feel that some insights into data should go further, that not only the poor are working, it is not about the livelihood, it is the pride also, self-pride.
That is correct.
People work for self-pride. That also needs to be taken into account. See, as you said,
that is what positive aging. People are talking about positive aging. That is what.
Yeah, absolutely. See, why Ministry of Justice has opened that site to invite old people to enroll themselves.
Making use of the skills and training.
Yeah, so that perhaps that needs to be borrowed from Europe and other countries where they are working. So this is one thing which more insights are required. And then, of course, about the attendance, combinedly, we all should do something, sir. Tomorrow, we are having a session of the past presidents for way forward to Iasp. Maybe this is one of the agenda, how to make the attendance more. be it a virtual platform or a physical conference.
Don't think much. Give some guidance. I'll tell you, all the people here, all the young people here, please ensure you bring at least 5 more. Manoj, Mohammed, सब 5 लोगों को लाइए भाई. We should have good attendance यार. कैसे होगा? अब डॉक्टर आदिनारायण के स्टूडेंट्स तो है नहीं, अभी पढ़ा नहीं रहे हैं, but the others are all active. You should bring
your own friends should discuss your paper.
Yeah, exactly. Anyway, for tomorrow, session, which is concluding, and the concluding session as well, there are interesting, presentations by very, authorities in this area. So you should hear. And thanks, Dr. Subramaniam. You have brought up, the issue of pride as well, which is important. But most important is the living, for people working for their own livelihoods.
Yes.
Very critical in this country, which is unfortunate, that we see the guard at the gate and all, 75-year-old person, standing there all throughout the day and for his living. So anyway, we are an economy that is improving. Hopefully things will change. But one thing, on the pride and, use of skills that Radhinarayana brought in, there are a lot of discussions going on internationally on low fertility. So one of the things on low fertility is not to increase fertility by incentives and so on. That countries like China can, probably think of, but, democratic countries should think of extending the, working age, then using the skills, as you said, KVR, of Dr. Narayana, who said on, the productively using the skill set, so that there is productivity still from people till about 70, 75. So that will keep the economy, moving. Despite low fertility, so these are the things actually this area is becoming very interesting, aging, because it has got relationship with several others. And thanks for the interest shown by this young faculty as well as older faculty like Dr. Radhinarayana in doing research, and keep pursuing this area of work. This probably will be the area of work that will fetch, a lot of importance in the future. And also one recommendation to that girl from Telangana, Andhra, who did this study, send your synopsis to also Tata Trust. They're very active. And, to Tata Trust, so that your name will be known, So, okay, thanks one and all. Thanks for the presentation. Dr. Dolly,
I have a doubt.
Any comments, Dr. Dolly? Yeah.
Sir, am I audible? Actually, I have a doubt. You said NIST. Can you just tell me the full form? I actually have no idea about NIST.
Arre Baba.
NIST, I will not tell you. You go on to the web and find out.
Yeah, go to the Google and find out. It is attached to Central Ministry.
Yeah.
NIST, right?
Yeah. You should never ask this.
No, I thought it is T, sir. T ankunna.
No, not T. D for Delhi.
Now I know. Yeah, now I know it.
Yeah.
Thank you.
No.
Good.
So, Dr. Dolly, anything from your side before we close?
Yes, sir. Well, I think with the lower fertility, and we have to focus on aging and migration, because NFHS 5 recent data, we reached replacement level fertility. So we should focus, but I think we should focus state-wise policy for the elderly and migration both, because we have a different demographic transition in every state.
Correct.
So that's it, sir.
Yeah, good thoughts, Dolly. We have a very differentiated fertility transition in the country, and we need to take care of each state differently. With Kerala around now, with 2021 census, whenever it comes and gets conducted, you'll find something around 16% or so, whereas the country will move towards 10-11% overall. And you're also seeing the fertility changes in NFHS, that you're seeing TFR getting majorly reduced. So these are things which should be kept in mind. Thanks, Dr. Dolly, for bringing it up. Thanks one and all for the great participation. And I like sessions getting extended, so we extended by 5 minutes, and that's also KVR, one of the parameters of the success of this session. So thanks for the participation, and have a good evening. Bye-bye.
Thank you, sir.
Thank you so much, Dr. Venkatesh Srinivasan, for chairing and carrying out the session so nicely. the quantity of audience is less important, but the quality of discussion is very nice. So I'm really thankful to you for generating the discussion. And of course, Adinarayan Garu always, when it comes to elderly, he will become very young. So always his thoughts are very useful insights for the youngsters. So thanks for all the presenters. Thank you very much.
Thank you. Bye-bye.
Thank you, Subbu. Thank you.
Tomorrow morning, 9 o'clock. Tomorrow morning, 9 o'clock will be the session. Please
okay.
join.
Thank you. Thank you very much. Thank you, Dali.
Thank you, sir.
Maro room ke la,
हाँ हाँ करिए